Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are three categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality-packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good morning, everyone, and welcome to PerfWeb 28. It's going to be a great show for you today. The first part of the program, of course, is going to be set up as a discussion, I guess fireside chat is what they call it, but we're going to be discussing three real interesting topics on Nido Cardioplegia, when to transfuse, and hyperkalemia while coming off bypass. Before we get started, got to go through all the housekeeping notes. So we're on all the social media platforms. I need you, please, to like, share, and follow and subscribe and click the notification bell on the Facebook, the Twitter, the YouTube, and our new LinkedIn account, okay? We have a call-in number, and we're opening the phone lines immediately. And it says phone lines seem a bit busy, by the way, Magics. People are already saying they're trying to call in and it's busy. But there is our phone number. Is that right? That's not the number I'm putting on the thing. You gave. That's not the number you gave me, Magic. Oh, it is 347-694. Yeah, it is 4400. Yeah, you're right. It is the right number. I'm sorry. That's our phone. I'm sorry. That's our phone number. And if you'd like to join our faculty, please go to our perfweb.us website, or is it Perfusion Education, whichever it is. You want to throw that up? And there's a list of our faculty. What page do they go to? Is it PerfWeb?
Yeah, they go to Perfusion Education.
Perfusioneducation.com. Perfusioneducation.com. And at the bottom of the page, you'll find a form to fill out. Fill that out. In fact, next month, Dominic Capoletti is going to be giving a lecture. He reached out to us, so I'm kind of excited that he wanted to do that. And now let me do introductions. I think that's everything. To my right, everyone already knows Min Tran. He is my favorite of all time. Always will be, always has been, for time in memoriam. Next to him, John Ingram. John, so good to see you this morning.
Good to see you again, Joe.
Again, John traveled here from Florida, got in at 2 o'clock in the morning, and he's here to do the program with us. And immediately to his right is Rodell Ebus. He is our fashion aficionado, as you can see. Not wearing his bow tie today, no. But you know, these guys here, this represents probably 80 years at least of on this, just these three, including me. I hate to say it, I think it pumps us up to about 120 years of perfusion practice experience. And on these three topics, again, we're going to first talk about transfusions, Nido Cardioplegia, and then on to the hyperkalemia coming off pump. John, that's something that you found sort of interesting. Also, what is the Twitter? What is our Twitter handle? It's I will write it down. Okay, you got all of that. Okay, somebody's going to help you there, JCam. So just be patient with us there. So let's talk about. And John, you've got a couple of slides, but I've got to start this conversation off with. As long as I've been doing this, and it's been a long time, I cannot believe how we are still having a debate about transfusions. I mean, you know, it's sort of like it's the topic du jour every single meeting that you go to for the past 10 to 15 years.
At least.
At least. Why are we still talking about it? How can we not have already come to a consensus? So do you want to start it off with your slides, and then I'm going to kind of let you sort of lead this discussion down the path you think it may need to go. And the phone lines are open, so call in.
I think it'd be a good start just to see what the World Health Organization feels about when you should administer blood to a patient. Mm-hmm. And then from there, it can go down so many different paths. Do we have the clicker?
Yeah, the clicker's right there.
It's on the right.
Can we throw the slides up?
That's not the okay. And it's just a 2 or 3 slides that kind of give us all a reset on where the World Health Organization is on whether or not you should transfuse blood or not. So, okay, it'd be nice if I held it this way. So there's about 10 conditions here that they have. But the first thing is a transfusion of blood and products should be undertaken only to treat a condition that would lead to significant morbidity or mortality that cannot be prevented or managed effectively by other means. So they're kind of saying it should be one of your last gap measures when you've tried everything else. This is sort of what they're insinuating there. And of course, if you need to increase oxygen carrying capacity of the blood, you should consider administering blood. If you need to restore the blood volume because your tissue perfusion is poor, you're hypoxic. If you have coagulation issues, if you need to replace platelets or factors or other plasma proteins, you should consider administering blood. And in the course of cases of trauma and bleeding, you have massive blood loss, certainly you need to be administering blood. If you have patients with certain thalassemias, leukemias, diseases where they just don't produce their own blood on their own. And then if you have excessive destruction of cells, mechanical disease, well, we have mechanical all the time with perfusion and ECMO and some other things. Of course, in maternity, you have catastrophic situations when the patient's bleeding or they're already anemic postpartum. And then in the age group of 5 to 29, I found this interesting because we consider this our healthiest, probably our healthiest group of age category, but they look at it as a vulnerability in this age range because they're young and they may not be eating properly, but also because of their high activity and their propensity to be a high metabolism, but also because of their propensity to get in accidents and
yeah,
easily easily have
motor vehicle accidents
or even just on the playground and have something, you know. So they found that interesting when I pulled this up, that they look at that age group in particular. Patients with chronic blood disease, of course. So perioperative transfusion, they look at 8 grams per deciliter for patients undergoing cardiovascular surgery. They also include orthopedics and acute GI bleeding. So their cutoff is below 8.
And this is who?
Well,
this is the World Health
Well, those health
Organizations.
organizations, guidelines.
It's
opinion.
their guidelines, okay.
Yeah, so, and if you have somebody with chronic anemia, it should be below 7. Somebody with an acute blood loss, if they're down to about 30% of their volume of blood loss. And that was pretty much the World Health Organization's guidelines on what they feel people should be considering when they give blood. So I thought that was a good start for us to ponder some of these things.
Yeah, I think all of those are all very good points. Let me share this with you and give you some thoughts about this. All right, so when we think about blood, we think about obviously the oxygen carrying capacity, and in the critically ill patient. So you've got all these various different subsets of patients in the population that we deal with, right? So we've got the routine, otherwise healthy, well-nourished, isolated coronary disease or valve disease or whatever. Maybe the person has been playing golf or exercising routinely through their life, and they have pretty good reserve. My view is that person can probably tolerate a relatively low hematocrit or hemoglobin and get through the operation. Their production is higher. They're gonna, they're gonna just tolerate it better. But somebody who is more elderly, especially little women, who are fragile, who have underlying renal dysfunction, all the things, almost no reserve. I'm concerned because I hear people talking, and people who profess, I won't mention names, but who profess to be transfusion management experts. You go to all these meetings.
Right.
We've all been there. And they stand up there all pompous that we don't transfuse until you've reached below 6. Well, I mean, are you nuts? I mean, I've seen too many times. I think that's insane. I think it is absolutely irresponsible to have these artificial thresholds. I think you have to look at any one individual patient, notwithstanding the risk and benefit balance that you have to have. What say you?
Oh, I agree. I just came from a conference and, talking about restrictive transfusion and having that trigger. You have to look, you can have that basis of, say, 7, let's just say 7. You can totally have that basis, but you have to look at the individual and their disease state. I mean, if you like John said, like if you have a mechanical issue or you have a weird disease state, that 7 might not be the magic number, and you have to transfuse. So no, you have to look at every patient individually.
Mm-hmm.
That's how I feel.
John?
Yeah, I have a lot to say about this. And back in the old days, Joe, back in the old days when you were around and I was around, I found something interesting is that if the patient, while we were on bypass or coming off bypass, needed blood, it was always give 2 units. Nobody ever said give 1 unit.
No.
It was always 2 units.
Yeah, if you're going to give
And
one, you may as well give 2.
I was
I don't
told-
know that that's right.
Now that's changed, but that's
Yeah.
why I'm going back, because I want to progress. Going back, nobody ever said give 1 unit of blood, at least not to perfusion. It was always give 2 units.
Right.
And so one time I had a conversation back in those days, and anesthesiologist said, giving 1 unit's a liability. That's malpractice. If the patient needs blood, they need blood. They just don't need a little bit of blood. So I kind of just stuck in my mind. Whether that was accurate or not, I don't know. But I remember him telling me that one time. And you flash forward to the future. Now in 2017, I mean to the present, in 2017 I was at a hospital, small town hospital, and this is not a knock on anything, but they had one anesthesiologist in charge of a whole team of about a dozen CRNAs. And they were excellent. And they all did cardiac, and they did it all. But they had gotten to the point where their cutoff was, I had to come off pump with a hemoglobin of 9. And if it wasn't 9, I had to give blood. And I found myself giving blood at, 8.8, or even sometimes even if it was 9, we'll go ahead and give it anyway because we're going to get diluted when I come. Because they wanted the patient to be so stable, is my impression, that they didn't want to have to struggle managing the patient after we came off bypass, which, I kind of have a little bit of issue with that because, I actually made a note in the pump chart one day that I felt that this was inappropriate, but me giving the blood. Because
That's
it was
the right thing to
it
do.
was 8.9,
Yeah.
and they wanted him to give 2 units of blood. And then there was also many times when we did give 1 unit of blood. And I kept remembering back to the days when I'd heard that, if a patient needs blood, it needs to be a serious reason. There was his point when he said, don't ever give 1 unit of blood because I think it's a liability. His point was, patient needs blood, the patient should really need blood. Shouldn't be like, oh, well, maybe, okay, go ahead and give it. You know what I mean? The patient should be suffering either hypoxic, serious volume depletion, poor perfusion, unstable cardiac-wise, whatever the reason is, the patient should need blood. But not just sort of on the fence and, well, okay, go give it. And give 1 unit, by the way. So those are the 2 things that came to mind when Rodell was just talking about. What is the rule out there? Is it set? Most of the time I see to be around 7.
It's a fantastic question. I mean, you go to, how many hospitals do you go to? You go to about 8 different hospitals?
8 different hospitals.
Well, 7 now.
7.
I'm sorry, I had to throw that in there. But tell me, what's your experience? You work with a variety of different surgeons.
I want to say that.
Plus, you worked in the med center.
I have, and for the most part, I think most institutes, usually try to dictate when we want to transfuse blood, and sometimes, a lot of time, it's anesthesia's preference. So, and obviously, at the end of the day, it should be a relationship between anesthesiologist, perfusionist, and the CV surgeon, managing all this. But I want to say the ballpark is probably usually between 7 and 8. That 7 would be probably like a borderline cutoff where we would actually be very concerned with coming off bypass with a hemoglobin lower than 7. Obviously, you can run into all kind of issues coming off bypass, and post CPB not having adequate hemoglobin. You have less red cells. Hypoxemia. Hypovolemia. Having to deal with hypertensive issues due to secondary to being anemic. Sometimes that can be an issue, and then obviously you don't want to treat those things with just pressures and then let your kidneys take a hit.
Right. Yeah, because anemia, hypoperfusion or hypoperfusion from the sense of an inadequate delivery of O2, as you have already taught us in some of your earlier lectures, the kidneys are extremely sensitive to that, very vulnerable to a decrease in DO2. And of course, I think those are all good points, but what's your perspective on individualization? In other words, we have this number, but why do we have these? I don't understand why we have arbitrary numbers. And has it been your experience that the number itself is the trigger, or is it the number as it relates to the case I'm doing right now?
Exactly. I think it's very patient specific. I think you have to look at everything.
But what is the practice out there?
I want to say 7. 7 would be the borderline cutoff.
Yeah.
Hemoglobin that most physicians and institutes are comfortably coming off bypass with a hemoglobin up. And then obviously, usually we can give back a couple of cell saver units and that'll get our hemoglobin up. So I think, at the end of the day, you have to be diligent of trying to transfuse, but at the same time, you need to treat it depending on the scenario and the patient's case. And if that's gonna affect the patient and benefit the patient in the long run.
What's your experience in these hospitals? Is it an arbitrary number, or is it the number as it relates to that moment?
It's the latter. It's definitely the latter for me. And who's to say that?
For you, but what about for
me?
the other people you work with? The other stakeholders, the
other
anesthesia,
yeah.
the surgeons. What is your sense of that?
It's usually the latter, and we always have a conversation. We always have a conversation. I have a conversation with the CRNA or the anesthesiologist, and even the surgeon. I always address the surgeon like, Dr. So-and-so, this is my hemoglobin, this is my hematocrit, but I have this to give back. I can hemoconcentrate. I can do everything I can before we even have to transfuse. I mean, these guys are, their feet are to the fire when they have to transfuse. Their STS numbers are dependent upon this. Their scores and their ICU stays are dependent upon transfusion. And I see it all the time. And actually, one of our hospitals, compared to the other hospitals in the Houston area, had the lowest transfusion rates, and that surgeon was very proud of that. And he does some complex surgeries. I mean, that compared down to the downtown area. So that's saying a lot.
Yes, totally.
And he's pretty restrictive with his transfusion, and he is all about the science and everything you can do without transfusing. Very restrictive.
Okay, hold on one second. Do I need to tell people?
No, they have do change already.
Oh, okay. So, everybody, if you haven't noticed, the phone line number I've been giving you is not accurate. So now the new number is up, 713-505-0486. So if you've been trying to call in, but the phones haven't been working, that's why. So it's up. But I think those are all very good points. But I don't know that, I think it's important to be I don't have a problem with them being proud of having the lowest transfusion numbers in the community where they work. I think that's okay. I don't necessarily think, however, that that's always the best for the patient when that's your goal. I think your goal should be to only transfuse when needed. And I'll tell you this, besides oxygen delivery, what else does hemoglobin provide? Well, it's our number one buffer. So do we want to have, a problem for the patient to manage their own acid-base balance because of low hemoglobin, low buffer? And of course, it's very strong. It strongly contributes to the overall oncotic pressure that you need within your blood in order to not third space. And so, but then of course, tools like ultrafiltration, we're embattled with that. I don't know if other people have had this experience where there's actually people now trying to write papers that say that ultrafiltration during bypass causes renal failure. I think that's kind of crazy. And my last point is this. Now, I understand that there's a major difference between homologous blood transfusion and autologous blood transfusion. But I think everybody knows the prevailing feeling, the prevailing sense or recommendations are that pre-donation, for example, is still kind of questionable because the blood is taken out, put in a bag, put in a refrigerator, and it's left there for some period of time and then given back to the patient, right? And there's some concern that that may not really be such a good idea. But it worked really well for Lance Armstrong. Okay? So there has to be some validity because he had to have put that blood in the bag and then waited until he replenished that supply, which is going to take a bit of time. It's not going to happen overnight. He had to recondition himself to his, new hemoglobin as it continued to build back up, and then he gave himself those transfusions, or the other people within that system that did it, in order to improve their endurance because they had a higher O2 delivery. Their O2 content went up because of the elevated hemoglobin oxygen carrying capacity. So hard for me to understand, again, that's not the same as allogeneic blood where you have the risks of transfusion reaction, cross-match, mismatch, or mismatch of your type and cross, the microchimerism that can occur, the increase in infection rates, and all of those things, the immunological consequences of giving a transfusion. I do understand it's a concern, but at the same time, there are so many bad things that happen to patients when they have to struggle to deliver enough oxygen to their tissues. John, you wanted to say something. I kind of monopolized that.
I wanted to talk about what Adele was saying a minute ago. The STS, go ahead, you have a question?
I have one question. I'm sorry. In my limited experience, this is from Nestor. In my limited experience, I have found with regards to transfusion, every patient is different. Surgeons will listen to the recommendations of a trusted, experienced perfusionist. I think we agree with that. A good surgeon will. Okay, a good surgeon.
Right.
Because there are surgeons still that exist that don't want to hear anything from anybody. They know everything. And we must be comfortable with our devices and experience when giving recommendations. That brings up iStat versus a co-oximeter or a spun crit. So that's a whole nother discussion. John, forgive me. I wanted to get that question in for Nestor. Good question, Nestor.
Yeah, good point.
Please forgive me.
So when the perfusionists, in my opinion, find ourselves in a very unique position when it comes to this, because you were talking about the STS and the surgeons in the hospital wanting to have their numbers favorable, and that is admirable if you're using low amount of blood products and your numbers are good. It's not if you're using low amount of blood products and your numbers are bad, right? So they're torn between, if I give the patient blood, he or she may have a much better outcome, but if I don't, and he does well, then my numbers are good on it. So they're kind of on two sides of the fence on what's going to happen with their STS numbers, right? But going to that same point, perfusionists, I think, are the only ones in the medical field that find themselves in this position. We're on bypass, we have a certain hemoglobin. The patient's not yet unstable because we're supplying their oxygen needs. They're getting ready to go on their own. The question is, are they going to be unstable when they go on their own? So, okay, should we give blood ahead of time? Well, maybe they're going to be unstable, maybe they're not. So how many times have you ever heard a surgeon say, let's just go ahead and come off and wait and see if the patient's unstable? Very rarely they say that, right?
Yes.
They say, no, go ahead and give. So we find ourselves as perfusionists sitting on the threshold of taking a patient who, when we hand it off back over to their cardiovascular system, may be fine and may not be fine.
Right.
Do we want to go ahead and say, let's go ahead and hand it off to them and let them become unstable? Now anesthesia has to try to rush and give the blood, which is going to take a lot longer than we can do because we're in seconds, they're in minutes, right? Giving the blood products. So that I've always found to be an interesting thing. But one thing that you're doing very smart, when you tell your surgeon that my hemoglobin is, let's just say 6, but I have extra volume, I can ultrafiltrate. You're giving him or her tools and reasons to think that, okay, we're not stuck right here, we're going to get better. Let my perfusionist take me there, then we'll come off and then we'll see, right? So I think that it becomes a little more complicated when you don't have the volume. You can't say that, but then there's surgeons that don't want to hear it anyway. When they hear hemoglobin of X, or anesthesia, same thing. When they hear hemoglobin of, and most of the time, if it's a number under 7, they don't. Most people don't hesitate.
Right, but that's the worst thing you can do if you've got 3 liters in your reservoir on a patient that isn't going to need it all to come off.
Right.
You know, I mean, you know, if you come off and you have, and now you have to send it to the cell saver, or I guess you could use the hemobag. You know?
Yeah, hemobag.
What's?
Oh, jeez.
Oh, good gracious.
Steve?
No.
What was his name? Paul? I forgot his first name.
I mean, I must be having a stroke. I'm getting old.
Please.
Keith Smolik.
Keith,
What am I
Keith,
thinking? Hey, Keith. I'm sorry about that, man. But, you know, the hemobag, or we can just make our own, which we've done before. You know, we've all done it. I've come off pump before and ultra-filtrated my reservoir and then chased, so I'm giving high hematocrit, high plasma content, or, you know, essentially just, you know, low plasma water. Right, I've just muffed the circuit, though. Right. And that seems to work really well.
It does. I always do that. If I have enough volume and left, and then I can see that they are not needing any volume right now. You know, CPP, PA pressures, everything looks stable. Pressure looks stable. And, you know, I mean, I have like 3 minutes, 4 minutes. I mean, I can easily take down 200 of that, you know, and concentrate it. And while I sit in my reservoir, while they're still waiting for the protamine to go in, while they're waiting to see a reaction to the pressure. Then once they do need some volume, I know that volume that's going in has been concentrated because I just muffed it.
Yeah, absolutely. Exactly. And it doesn't take long at all, especially if you have a good VM concentrator and you hook it up to vacuum. So we've got Jeff Campbell called in. Jeff, how you doing this morning?
Good. How are you?
Who is this?
Jeff Campbell. We can't hear him.
Jeff Campbell, University of Florida Medical Center.
Here, it sounds kind of
muffled.
It sounds horrible. Hey, Jeff, go ahead and talk. Try talking.
Yeah, I'm just going to chime in on the current topic. So, I mean, I agree with the panel. I think these blood transfusions, I think you have to look at it as a liquid transfusion. And there's a lot of articles that show the consequences of transfusing blood, the cardiac surgeon, for plenty about that. Actually, I worked with a surgeon for a long time, Dr. Thomas Rowan, very well published on the subject, and shows the increased morbidity and mortality with not only low hematocrit on bypass, but also the use of blood transfusion on bypass, and the two combined exaggerates the effect. So low hematocrit is bad, blood transfusion is bad, when you do both, it's even worse. With that said, I think, you know, you have to look at each patient, each case independently. You just can't transfuse off of a number. So if you have, sometimes I'll have a patient, they have a hemoglobin of 6, and all parameters look fine, SVOP is fine, pressure is fine, not having to give any alpha agents, keep pressure up. Cerebral oximeter is fine. In situations like that, we'll just keep the hemoglobin of 6, not transfuse. Then we have a patient have a hemoglobin of 8 and the cerebral oximeter down, can't maintain decent blood pressure without alpha agents, something like that, we'll transfuse. So it's patient, you have to tailor your blood transfusion protocol to the patient and the procedure, I think.
Yeah, well, I think everyone here would agree with everything that you said.
Absolutely.
Rodell knows you, apparently.
Yes.
Yeah,
is this Jeff or John? Is this Jeff or John?
This is Jeff.
Oh, hey, how you doing?
Good.
Yes, we met, and we've met a couple times, actually. I hope your daughters are okay. I hope your daughters are okay.
Yeah, they're older now.
Yeah, I know. I know. How's that Achilles? I know you tore it a couple years back.
Yeah, good.
Oh,
I just
good.
did a half Ironman, so it's not good.
Hopefully you didn't get transfused.
No.
No, but did they use platelet gel?
No.
Yeah, that's because I.
Kind of, we were out playing the gel in my hospital, and it was like kind of I tore it, and like 2 days later I had surgery, so I didn't really have time to get it set up.
Well, they've got a lot of platelet gel in Orlando at Disney at Pixie Dust. But getting back to this issue, John, you know, I think it was, I mean, Jeff, it was like Dr. Spees, who we all know from Emory, I believe, and he wrote that book on transfusions. And he had that paper that I thought was very important, which is you're damned if you do and you're damned if you don't.
Right.
And you know, I think for me the takeaway message of this whole discussion is you have to do everything you can to minimize your need for transfusions, optimizing the patient's fluid status, the use of ultrafiltration, the use of albumin, which carries with it, I mean, really no risk whatsoever. The use of
mannitol.
Of minimum prime circuits, mannitol you can use as well, very beneficial. But I think that at the end of the day, keeping the volume where it needs to be, and I think as perfusionists, we've sort of forgotten that there are 3 very distinct fluid spaces in our bodies, in our patients' bodies. You've got the intravascular, you have the interstitial, and you have the intracellular. The intracellular, of course, the highest fluid content, and the intravascular, the one that we are always thinking about, has the lowest fluid content. And I think that we need to be better at checking the microvascular, microcirculatory system, which I don't think we do a good job of. I don't think most of us even calculate DO2 on a routine basis when we do cases. I think we need to be more respectful of all of those things. Minimum prime circuitry, the use of tools to optimize, not dry the patient out, optimize their fluid status, and then evaluating the patient's hemodynamic stability to determine the complexity of the case, the other comorbidities, to determine whether or not this patient would actually benefit from a transfusion. And I think that if you come to the conclusion within your practice based on your experience and based on your understanding of that patient you're doing, you should give the transfusion and do so without feeling fearful that you're going to be punished by some system because you did what was right for the patient. So I think we have a multitude of issues to address, and unfortunately it's complex. We have 30 minutes to do this and we have 2 minutes left. So let's go around the table if we can. Jeff, why don't you start it off and we'll just go around the table and get final thoughts.
Yeah, well, I think the other thing with respect to this topic is goal-directed perfusion. So if you have, you have to consider how your DO2. So if you have a lower hemoglobin 6 or whatever, I think you need to flow higher. You need to maintain some critical DO2 level. So if you're at hemoglobin 6, your flow requirement must be maybe much greater than it would be at the hemoglobin 8. And there's a lot of articles that look at acute kidney injuries with respect to DO2 delivery on bypass.
Yep. John has talked about that.
Starting off the transfusion, if you're able to flow higher and maintain that critical DO2, I think that's another option you have as well. So, yeah, minimal circuits, prescriptive oxygenation, 3-inch venous lines, things like that. I mean, we've done all that. It does help. So I think you have to conserve the hemoglobin you have starting in the room. Meticulous surgery, not losing a lot of blood, and just doing everything you can to minimize that transfusion and maintain good oxygen delivery and bypass.
Very good.
That's my thoughts.
Jeff, those are all, I really, I couldn't agree with everything that you said more. And I hope that the younger perfusionists who may be watching this now or will watch it in the future will derive some really good lessons from your experience and our experience. Rodell?
Oh, I totally agree with Jeff. You know, it's, oh, hey, go Bucks, by the way. So I agree with him on that. We have to have that critical DO2 level. I mean, that's how I've always practiced. You know, whether I knew that number or not, I keep my hemoglobin up. You know, it's funny, everybody watches me cut my circuit up. I don't, everybody, the thing was, the new sexy thing a couple years ago was a mini circuit. Mm-hmm. We have a circuit. I make a medium circuit. I cut my venous line, I cut my arterial line, I have them cut it up at the field. So when I wrap, it's minimal detriment to the patient. So that's how I keep my hemoglobin up, on top of my oncotic drugs, on top of my hemo concentration, on top of me talking to the anesthesiologist or CRNA, hey, can we cut the, that 1 liter of lactated ringers that does not have to go in. This patient's fairly stable. It's an isolated CAB. You know, they're not struggling. It's not a left main. It's not aortic stenosis who's, you have to worry about
any hypotension at all.
Right.
Right.
So that's not dependent on volume. So
right.
Again, I'm trying to find that critical DO2 level and staying with a high hemoglobin.
I agree with everything you said with the exception of RAP. John?
I think from a historical perspective, something that people forget about, Joe, you may remember this, but if you go back way before there was any immunosuppressant drugs and they wanted to experiment and they were doing organ transplants, what they gave patients to suppress their immune system was blood. That's what they would give people to suppress their immune system.
I didn't know that.
Yeah, that was when, if you go back before, what is it, cyclosporin or whatever, the okay, if you go back before that, which I think only was invented, came out in the late 50s or early 60s, they were doing organ transplants before that and they were being unsuccessful. They would give patients blood to suppress their immune system. We've long since forgotten that that's a negative of giving patients blood.
And that's a problem.
And one of the many, but I think, what Rodell says is great, and I think of all of us, we're basically looking at preventing getting to that low hemoglobin in the first place, doing whatever you can do, planning out ahead of time. And I remember one time I had listened to a lecture and at a meeting, and someone was talking about this very same thing, and someone stood up and asked a question and said, we do all this in the OR, but as soon as they get to the unit, they just give them blood. And they just, they don't have these tight constraints of going all the way to the edge before they give blood. So this what you're talking about, as perfusionists, we can do a little about it, but not a lot, but to try to carry that mentality over, at least into the post-operative phase, because sometimes it is negated. All of our efforts sometimes are negated in the ICU.
Yeah, no kidding. That's very true.
Yeah, I mean, I think they all made good points, just keeping, being aware and keeping thoughts on all the variables that factor into what's going to help the patient, because at the end of the day, that's what your goal is. And all the tools that we have set for us, hemoconcentrating muffin, minimizing our circuit, reducing the hemodilution, even maybe having the surgeon in the scrub at the field cut some of the circuit off, because usually they have a lot an extension, of circuit.
Well, I call that the surgeon's loop.
Exactly.
When the venous line comes up and has a big giant loop to it.
He doesn't have that with me.
That's just
none
crazy.
of my surgeons have that with me
for?
anymore.
I understand sometimes you got to move it over, but you don't need a big giant loop in order to do that. It's kind of silly. Right. And I hate going to places. I don't know if you've ever experienced this, but those are all very good thoughts. And I agree with everything on that. But have you ever been places where they have their way of doing it? They've been doing it like this forever. It's really not a good way to do it.
Right.
And you'll mention something like, hey, can you cut that line right there? And they're like, this is how we do it. And you get the scrub who has no and I love scrubs. I love everybody that, I love people. I mean, I do. But sometimes I think they get caught in this paradigm of,
routine.
Why are you even saying this to us? But they're not thinking what the consequence of it is. And that's something that bothers me.
So what's interesting about that, I did get a lot of pushback because I will cut at least 18 inches off of both sides up at the table pack.
And our lines are too long. We need to fix that.
Well, I tried to fix that. It's in the process. But nonetheless, I did get that pushback, and they're like, well, we've never done this. How come you're the only one that does this? No one else does this in your group. I said, well, guess what? This is for the patient. And that ends the conversation right then and there. I'll say, like, the surgeon, I go with this surgeon at all these places. He doesn't have a problem with it. I don't have a problem with it. Please do it. I mean, not as stern, but if you have that conversation as a professional to professional, it gets done.
Absolutely. And I think sometimes we also need to be thinking, we need to ask the surgeon sometimes, please make sure, manipulate the cannula. We got crummy drainage, and we're pouring fluid in the patient. We know this is not going to end well. It's not helpful to the patient. Some people, I've made this comment, it's kind of a joke, it's both easy and hard to kill people. Thank goodness, because we do heart surgery on people, and what we do to them, and they come out and survive it, it's really hard to kill people. But yet it's sometimes some people, it's the simplest little thing, and it tipped them over the edge. And you never know where that's going to happen or when it's going to happen. But on the immunosuppression thing, maybe if we were a little more cautious, gave blood as needed, and we reduced the strain on our blood supply, the cross-matching, the freshness of the blood, the antibody searches, the nucleic amplitude testing, the NAT testing that they do on it, all of those things may actually reduce the immunosuppression effect of blood, making the blood supply safer by reducing the strain on blood banks to keep up with the amount of blood that we use. Because cardiac surgery is, 25% of the nation's blood supply is consumed just within cardiac surgery.
It's quite a bit.
Yeah. Apparently my mic went down. The batteries should have. I told you we should have changed the batteries. Okay. I think we have successfully completed this topic.
Yes.
Jeff, thank you
Thank
so
you, Jeff.
much for calling in.
Thank
you, Jeff.
Our John just logged on, so he's logged.
Thank you so much. We appreciate it. Call back on another one if you'd like, because we're gonna tackle
All right.
Del Nito Cardioplegia next.
Yeah, thanks, guys. Yeah, bye.
Sounds good. Thanks, Jeff.
Thanks.
That was a good, lively debate. Can we get Dr. Samir up, and because this is on Del Nito Cardioplegia. Vicky, can we get Dr. Samir up, and we'll get him set up while we start this, and we can go straight to John's slides. And he's got some slides on Del Nito. I think the next ones, if we could throw those up, and he can sort of prep us for this next discussion.
Well, the only thing I put together here, because I knew Dr. Samir was going to have a thorough talk on this, was...
He's not talking about Del Nito Cardioplegia.
Oh, he's not? He's talking about the other?
No.
Okay, so, well, this is what I put together because for people who don't use it and not really familiar with it, or even people who are, it's just a one slide that gives you the actual ingredients of the original, the way Dr. Del Nito originally described it in his original article. Okay, the base solution is to be plasmolite, 1 milliliter of plasmolite A, and that's a basic solution with normal sodium, potassium of 5, magnesium of 3, and a pH of 7.40. Okay, the next thing is to add mannitol. And it's interesting because they only add 3.26 grams of mannitol. But this gives you your osmotic pressure, your free radical scavenger component. Then they add 2 grams of magnesium. A lot of us are familiar with that already. That's a calcium channel blocker. It improves myocardial recovery. Then they give sodium bicarb, only 13 milliequivalents per liter, but that's your pH buffer. Then as far as potassium goes, it's 26 milliequivalents in the 1 liter bag, but the actual delivery of the potassium, if you'll read articles, it usually says it's 24, and that's because you're diluting it with 1 to 4 blood. So all of these numbers are going to come down a little bit. And so, of course, the potassium is for myocardial depolarization. And then you have the lidocaine, which was one of the big elements when he developed this, and that is 130 milligrams. It's a sodium channel blocker and a hyperpolarizing agent. So this is just a quick down and dirty slide about what is Del Nito. Now, the reason I put the originally described formula up is that the conversation that you run into, if you go around, is people are always tweaking this. There's so many different versions of what people are doing with this that Dr. Del Nito has come out a number of times and said, a lot of people are using modified versions, number one. Number two, I never prescribed it or developed it for adult cardiac surgery. And so, you know, he was trying to pull back on what he originally put this together for. Having said all that, there is a lot of success that people are seeing with Del Nito. And I guess at this point I would just turn it over to Dr. Samir, but this is delivered also at a 1:4 blood to crystalloid ratio. And the blood is also for a little bit of oxygen delivery and also for buffer capacity.
Well, thank you very much. All of those are, I think, very good points and a good, I think, tee up to this. So first of all, would like to welcome Dr. Hani Samir. You remember Dr. Samir from our previous programs. Dr. Samir, thank you for being here so early in the morning and making it out here to the hinterland. So,
actually, I had a tour of Magnolia this morning. It was great.
Was it good? You had to go through Magnolia?
Yes.
How was your area? Did it flood pretty bad?
The Med Center did flood very bad this time.
Yeah, it did?
Yes, I mean, it's all. I mean, getting into the Med Center was the problem.
Yeah.
I mean, we had to shut down transplant because we couldn't get in. They couldn't fly in or out, so we had to shut down transplant.
Well, welcome. I'm glad you made it here this morning.
Thank you.
And we're looking forward to your afternoon session on ECMO. He's talking about ECMO today. He's going to be talking about when to call for ECMO and when not to call for ECMO as his part 2. Okay, followed by walking patients around with Christine. Is she here yet?
No, not yet.
Not yet. Well, welcome once again. Thank you for coming back and seeing us up here. We
me.
appreciate having you. So what is your thoughts on all of this, Dr. Samir, on Del Nito cardioplegia? It seems to be the latest and greatest idea. Everybody's kind of jumping on the bandwagon with it. I think that John just mentioned that, you know, Dr. Del Nito himself, named after, did not develop it for adult cardiac surgery. It was designed for the pediatric patient population. I have some concerns, and I'll tell you what those concerns are. And I think you brought it up, though, with the modification of this original formulation. Some people are having great results with it. I know several. In fact, Dr. Wynn has great results with it. A lot of people are talking about how great it is. But in the 11 years that I've been here in Houston, I saw one case of true cardiac stunning following, basically post-cardiotomy, following bypass surgery, where I believe the problem was inadequate myocardial protection with cardioplegia, a lack of good cardioplegia delivery on that patient. One in 11 years. When we switched to Del Nito, I saw 5 in 1 year. That's concerning to me. And 2 of them were Stoneheart. And they all 5 went on ECMO. That's worrisome. Is it the modification of it? Is it the delivery of it? Why did that happen? And is it just coincidental? What's your view?
To be honest with you, stunning, I mean, after bypass, I mean, as you know, there's like a million reasons. I mean, are you delivering correctly? Are you sure you're delivering? Are you sure you don't have AI? I mean, these kind of situations, I mean, to be honest with you, our Del Nito situation has been very surgeon specific. Some of them love it, some of them can't stand it, as you know very well. Yes. Yeah, some of them can't stand it. Some think they're the best thing in life. Some say, I'm not gonna do anything new, I've been doing fine before. Mm-hmm. Mm-hmm. So, I mean, the thing about it, you're not getting too much hemodilution. So, I mean...
you get massive hemodilution with Del Nito. It's massive.
I'm gonna tell you, I'm gonna have to jump a little to the back. I'm gonna tell you one thing. I am a fan, my old might wanna hit me. That the only reason, the biggest determinant during bypass, how things progress after, is your pressure during bypass. What you've been taking your mean pressure at, not your hemoglobin. Well, that's how your kidneys fail. That's how your brain fails. It's pressure you've been taking on bypass.
Well, I think that's part of it. I mean, so you dispute or you disagree that hemoglobin is an important component to perfusion? Are you disagreeing with that?
Yeah, I think, let me tell you something. I'm very comfortable, and I'm a critical care also. I'm very comfortable running anybody hemoglobin of 7. I'm very comfortable with 7. 7 does not keep me awake at all. I think 7 is super great. Because you're also looking into viscosity, and you start doing device surgery, viscosity is a big deal. People underestimate viscosity and its issues. And I'll tell you, that's a controversy we have in the OR.
But that's a device. What if you have a patient
7.
who's starting off with an ejection? We're going to change topics.
Yeah,
with an
sorry.
ejection, that's okay. With an ejection fraction of 20%, and they're on some pressors, they're on some inotropes, they're kind of limping along. You're still happy with 7?
I'm gonna pick on men. I'm gonna pick on men because I know him. I can pick on. He's not gonna hit me. Okay. I'm gonna tell you something, and you might hit me, Joe, later, but I have protection. I'll tell you, I want to flow high. Okay.
But if the heart can't flow high, if the heart is compromised, so I have no problem with the hemoglobin of 7 if I have a mechanical circulatory device. But we're not talking about that. We're talking about weaning this patient now off bypass with a weak heart, not an LVAD. They're not getting a VAD. Their own native heart that's recently been revascularized, that you use Del Nito on. You have a lack of good distribution. You've already got a compromised ventricle, now even more compromised with ischemia because you chose Del Nito over just regular old Plegisol, which makes more sense with multiple doses, in my opinion, humble opinion. And you still feel that O2 content, therefore O2 delivery is 7 is fine.
Because remember, O2 delivery, the biggest determinant you can change is your carpet output, carpet index.
But if your cardiac output is compromised.
But you're going to have to optimize it. You have to optimize it. If you cannot do it by drugs, then you have to use, there's balloons out there and there's impellers out there. And if you keep whipping your heart with chemicals, then you are doing the wrong thing. I'm sorry.
So you would rather put an impella in than give the patient 2 units of
Absolutely.
blood?
You know
really?
why? Because the impella is going to get him through the post-op period into the ICU without much drama, and we don't have to titrate up the drugs. I mean, he said something that's amazing. When you go to the ICU, things run crazy. If I go to the ICU with that epi of 5, I know that's a very dangerous situation because that's going to run away epi to 8, 9, 10, 11 later. I have no room for error. You have to always allow room for error after you take the patient to the ICU. So you have to come with basically have a little room that you can move in. If you have max drips and you have no room to move in, you are really asking for trouble. Whether you have put this patient hemoglobin from 8 to 7, or 9, whatever you want, you need a device. You need to have room. So
true. Robert Parchman says, and I asked him to call in, and this is our knock on, and we love you. We love our anesthesiologists.
It's okay. It's okay. I'm ready for the bullets.
All
I am ready. I have a cavalry coming.
Yes. Robert Parchman from Shreveport, Louisiana, Shreve Patch or whatever. I've found that no matter how hard you work to get your hemoglobin to an acceptable point, and they use 7 as our trigger, you get off pump, patient looks great. The first dip in blood pressure, the anesthesiologists go wide open with their drips instead of maybe just a little pharmacological support and a tincture of time. And then, of course, that 7 is 6.
No, I don't think you should open fluids. Any anesthesiologist is going to open fluids, I will. That's crazy. I'm a very. If you put the CVP up and up, you're cursing my mother. So that's for me. CVP going like out of control. That's crazy. We had a rule, and again, it's my device world. My device world is CVP can never go above 15, which whatever that number we came up with from Germany. It's not like a magic number, but it was just we had to come up with some number. I'm very sensitive to CPP. I'm very sensitive to the right heart. I will never push the right heart over the edge because you can never come back.
That's right. It's like the kidneys. It's
Yes.
the most underappreciated half
It's
of the heart.
It's the orphan organ. It's the orphan organ.
Yeah, the orphan organ. I like that.
It is the orphan organ. So I'll tell you, the right heart really, you really have to baby it and treat it very nicely. And I will again pick on Min because he cannot hit me. You know, I was obsessed, and he will tell you, and you can be honest, with the return volume line. I'm obsessed with the return volume line. Why? Because I want to get every last drop of blood from the patient.
Yes, the plasma, what platelets there are, everything.
Right. You know,
and so did you hear our discussion about ultrafiltrating our post-pump volume so that we don't have to give as much volume back, but we're giving concentrated volume?
He can testify to that. I believe in that 100%, and I believe in giving every last drop. You have every last drop. I want the return volume line hooked up until every last drop because you're forgetting about the plasma and everything else. People think because the line is clearing out, it's fine. Well, you know something? Well, it's better than giving regular fluid from the IV bag.
Yes.
Because there's something else in it. So I get that volume line in, and then do some pharmacological agent and tincture of time. I do not believe in opening IV fluids. That's just crazy.
But it is something that happens.
You know, we are trash talking and say we'll start abdominal surgery. We're not doing a belly case today. And you know, I never believe in that. I would never open volume in a heart case. I mean, that doesn't get you anywhere except in trouble. Okay?
Agreed.
Yeah,
I mean, I think we agree with you. So back to Del Nito cardioplegia. Back to Del Nito. Bottom line, what's your opinion about it?
The opinion, any stunned heart is because of how you're delivering the cardioplegia and the frequency. And did you forget or not? And you have AI or not? Are you really watching the pressure line? Are you really knowing that you're delivering the right? And when I tell you the pressure is high, I'm not kidding. It is high. You need to maybe pull back a little. It's going against the wall.
That's if it's in the sinus.
Yeah.
So
I mean,
do you believe then everyone has to get retrograde as well as antegrade?
Absolutely.
And that's, I think, a problem. That's where that's a big problem. And if it's in too deep, then your right heart is going to seriously get compromised because we're not going to perfuse it. John, you had something?
So Joe, let me you bring up a very interesting topic. These patients that you're talking about with the stunned myocardium, were these coronary bypass patients?
Coronary patients.
Okay, so right off the bat, Del Nito for adults is supposed to be used on valves.
Yep.
Only.
Right, but I've got a paper right here.
That's true, actually.
I have a paper right here.
No, I'm not saying people.
I'm
not saying people aren't doing it. And let me tell you what happened. Just to throw this, because you bring up a very interesting topic. In 2017, when I was at that small hospital, the surgeon came to me and said, "I want to look into Del Nito cardioplegia." So I called them because I didn't know much about it. I called them. I think they're out in California.
I don't know where they are.
And they put me directly in touch with their clinical expert, and he was a perfusionist. And he told me, what kind of cases do you do there? I said, well, we pretty much do all CABGs. He said, right off the bat, absolutely not. I would not want you to use it. And I said, well, tell me what you're trying to say. He said, this is what happens, the danger of using Del Nito with CABG patients. The formula is very powerful at keeping the EKG flatline, although your preservation may be poor. And so he said, once you give Del Nito, and if you have blockages, the reason the patient's in the OR is because they have poor perfusion past the blockages. The same is likely to occur with the cardioplegia, hence the reason why you're going to get retrograde.
So you may not see electrical activity, but you have subendocardial
right. And he said
mechanical activity that you're not seeing or appreciating. It's a very fine fibrillatory, and you're just chewing up all of your ATP.
He said with Del Nito, a flatline EKG is not indicative of myocardial preservation, where most of us sort of look to that as a big indicator. He said, to me, he said, once you've given Del Nito, you may be okay if you've gotten an adequate amount past the blockages, but you may not. And he says, you just can't unring that bell. Yeah. You may look fine, but you're going to find out when you come off that you're not.
And if you're going to keep redosing, then you may as well use traditional cold, high potassium cardioplegia, like St. Thomas solution or Plegisol or whatever other version you give. And I think that's where the advantage of our traditional approach makes more sense. Because what do you do every time you do a bypass graft? You give your initial dose of cardioplegia. Let's say you don't use retrograde. You do a bypass graft. You give it another dose down the coronaries, native coronaries, and down the graft. Then you do your next graft. You give it down that graft too. You start increasing, your time is 6 to 10 minutes, depending on how fast your surgeon is or how slow they are, before you're giving another dose. So with wide open coronaries, for a minimally invasive valve, so you don't want to have to keep giving, and it's problematic, and I understand that. Yeah, it makes sense. But for a routine coronary bypass case, the extra minute or two it takes to give another dose of cardioplegia is inconsequential and not worth the risk, in my opinion.
The premise was you're going to give that one shot and you're covered for the whole case and you keep going.
Yeah.
That's the premise.
Right.
But, I don't think that premise works with what kind of blockages you have and what kind of AI you have. I'll tell you something. So I think you're taking a chance by giving that one shot, thinking you're covered. And your mind's at peace. You know what I'm saying? So.
Does it make the job of, and I have to admit this, God, I hate to admit this, I've never actually been the perfusionist on a case and given del Nito cardioplegia. I've only ever given intermittent, regular cardioplegia. Does it really make your job easier to not have to give another dose?
You don't have to think about that. The thought is you not have to think about every 20 minutes you're like, the 20 minutes are up. You have to remind the 20 minutes are up.
Perfusionists love it. It's one-time shot and done.
Exactly.
You don't have to worry about, it's been 20 minutes and, it's been 25 and we have fibrillation. It's like you go on pump, you give and you're just, wow. And then
you're not bothering the surgeon.
That's the beauty of it.
It's like they don't want to hear from you anyway.
But I enjoy bothering them.
Yeah, well,
and I do too, don't get me wrong. But, I'm sitting there and I'm like, oh, okay, I'm looking at the EKG. If I see a little atrial, activity, I'll still say something. You see something, you say something. So, it actually happened to me. It was we'd had an aortic valve with a thick myocardium. I gave my 1300 of del Nito, and I said something, and he goes like, well, it doesn't look like it. Maybe it's just, pump chatter or, some artifact. We actually looked. I turned off all my pumps, and it was real.
Sucker vent, turned everything off, and it was an artifact. It was real.
Not an artifact. He actually took an osteocannula and went down the left, did not change it, went down the right, knocked it right out.
Yep. And the right coronary is the one that always seems to suffer the most.
It's exactly it.
Always seems to suffer.
Well, going back to what these two gentlemen just said, when Dr. Del Nito developed a technique on infants and pediatrics, there's no blockages in the coronary.
Right.
There's no AI. And the myocardium is vastly different. So those three things is why he, I think, is trying to pull the reins back on the adult usage, but the adult usage is exploding, actually.
Oh, John's on the phone? Oh, go ahead and put him on. Hey, John.
Hey, Joe, how are you guys doing?
I'm doing great. It's good to talk to you.
This is brother again.
We just got through talking to your brother. Are you guys?
I got in a little late. I forgot to sign up for the CU this morning, but I'll just do it right afterwards,
Sure. What's up?
Oh, no, I was going to comment on you guys' Del Nito conversation.
Please.
So we've got one guy that started here not too long ago. He uses Del Nito for all his cases. It's going pretty well, but I agree with what you guys say as far as if you have AI, then that could be a major issue. Or if you've got make sure you've got complete myocardial preservation. With the CABGs and stuff, it might be an issue.
Yeah, I think that's been our consensus.
Yeah, we haven't had any issues with ours, even in our CABG patients. But we're really fast here, So I think that has a big advantage as well, even though it's good for up to an hour.
So are you guys using retro with your CABG patients in Del Nito?
No, our straight CABG patients are integrated only.
One shot, yeah.
Oh,
One shot.
So the technique of your surgeon, is he doing distal procs, or does he complete the whole graft, and how does that work?
No, we do all distals, and then
okay.
Then the guy that uses Del Nito for CABG, he'll do the proximals under one clamp. The other guys will do partial clamp.
Yeah.
But we only have one guy with Del Nito.
Yeah, I only ask because if you had to redose, you could still give that 400 or 500 of extra Del Nito, and it actually goes down the actual bypass graft. So that's
right.
my question.
Well, I think they put the syringe. The syringe has Del Nito because you still, you know what I mean, that they test the grafts with.
Yeah, because that's how Harrington used to do it. He used to do all his distals and proximals, and then he'd give his cardioplegia, and that's how he got away with not using retro. If you remember back in Detroit.
Yeah. Oh yeah. And he was fast. So.
He was fast.
A lot like the guys here.
But that's another conversation. Single cross clamp makes, more sense to me than putting a partial including clamp. The less times you clamp the aorta, the better off you are for neurologic protection, don't you think?
I agree. But
you're crunching much less.
Yeah.
But then you go with a conversation with less ischemic time.
Right.
Well,
that's the reason.
Not if you have occluded coronaries.
True.
And you haven't connected the proximals yet.
Yeah.
So I don't know if I buy that, but or hook up. I guess you could hook a pigtail up to it. One of those octopus, and run continuously through the coronaries while he's doing the proximal, each individual one. So there was a question here, and I can't answer it at all. Dr. Samir or anybody else on the panel, Rodell, John, Min, maybe you can. Brian said that he can we include custodial in this talk?
Right, I agree.
He says, I am new to both, but our surgeons prefer Del Nito for CABGs, but custodial for valves. And personally, he feels it's a bit less in touch during a case when not using normal cardioplegia. In other words, not having to stay aware. You give that one shot and forget it. He feels like that it disengages him somewhat from the procedure. But let's talk about the first part of his. And if you know anything about it, John, please add to this conversation. Custodial versus Del Nito. I don't know anything. I don't know enough about it.
I think custodial is good for longer distance. You get a lot longer time on it. And there was a talk here. I think it was presented by the custodial guy, so I think that was a grain of salt. And it was showing that custodial is probably better than Del Nito. But of course, I missed that talk. It was like I had work that night, so I don't know a whole lot about custodial. Never used it, but from what my colleague said, that it seemed pretty good. It was very similar to Del Nito. It gives you a longer, ischemic time, let's say, safe time, and with similar results. But I'm not 100% sure because I've never actually used it or really read up on it that much.
What do you know?
I've never used it, but it was originally used for organ transplants, and that's what preserves the organ during transportation.
Okay, so when you do a heart transplant, you use custodial before you do the explant.
Correct.
And so that's because that gives you the longer
preserved.
duration.
Yeah, it's preserved. I believe they just give a shot.
What's the difference in the formula? Do you know?
I don't have it, and I'm not as experienced on this as well, but I can tell you I did go to a meeting. Sounds like maybe John was at the same one about a year and a half ago, where the company rep did stand up and talk about it, and taking it a little bit with a grain of salt that it was the company rep, the ingredients and what each ingredient does in the HTK is pretty impressive. It really is very impressive. If you want to really...
HTK is the custodial?
It's custodial, yeah.
Yeah.
If you look at what those ingredients are doing independently and synergistically, it's very impressive. And it almost makes you think, wow, we should really consider looking into that. Where I'm at, we use all of these things, depending on the surgeon preference. But if you think about it, you're up to about a 4-hour ischemic time with your heart transplants with a single dose. What other solution can you get away with that? Not any. And that's what happens with. So it's a pretty powerful formula.
Yeah, kidney transplants, liver transplants, that's what they were using it for.
Really?
Yeah, for preservation.
Well, now we're going to get away from preservation because now there's a couple of pumps that develop to put the hearts on to transport them.
Right, keep it beating.
Right.
Keep it beating and perfuse.
There's two pumps, and actually we're starting to use them, and that's what the plan is, to use them so you can fly organs from Hawaii, fly organs back and forth. So
That's right. That's right.
So we're starting to work on that.
Exactly, and I think we've seen several of those, even heart and lung in block, where you're ventilating the lungs and perfusing the heart
Actually, yeah.
all at the same time.
And one of the pumps actually is using the donor's own blood, and you put it, and you're running it, you're flowing it, and it's really amazing.
That is amazing. That is amazing.
Yeah, you're basically, and you're adding, potassium, you're adding electrolytes, but you're using a donor own blood as the volume.
Okay, so you're actually allowing the heart to stay in diastolic arrest, but perfuse. So you need a mechanical pump, not necessarily beating.
No, you need the mechanical pump, yes.
Okay, that makes a lot of sense. YouTube comment, okay. And then with custodial, he says, switching topics. Thanks, Brian. You must ultrafiltrate immediately because custodial is a 2 liter dose on everybody.
There's no blood.
There's no blood in it at all.
Blood.
It's 100% crystalloid.
Straight 2 liters.
Mm-hmm. And of course, that's been the big deal with whatchamacallit? What's that stuff called? No, the microplege. That when you give that much fluid, that much crystalloid into the coronaries, you get significantly more histologically being examined, much more myocardial edema. And that is going to give you perfusion deficits later and make for contractility problems. So is the osmotic pressure of custodial and del Nito so high that you don't have that as an issue? Has it even been explored or looked at? I just don't know the answers. I tell you this. You know what we're going to conclude from today's conversation? That we don't really know.
We don't know.
We don't know.
There's so many arguments.
The old-fashioned 20 minutes, nothing wrong with it. Well, I'll tell you that. Nothing wrong with it, and you're always assessing. I think 20 minutes gives you a chance to assess, reassess.
Right.
Yes.
And you're not depending on things you don't know. Anatomy, AI, you are, even if the cane is not 100% the right place, you're able to deliver some more.
Yep.
I think that lack of that 20 minutes more and more, it gives you you're relying on something. That's the problem with Del Nito. It's relying on a perfect anatomy.
Mm-hmm. Yes.
And you're relying on it. You cannot rely on that.
And that's what kids have.
Yes.
Because they have they have an anatomical deformity, but it's not coronary circulation.
Right.
Generally speaking.
And I think it was John earlier, or still on, that said he has one surgeon that he gives it antegrade, Del Nito antegrade only, because I guess he's very fast, doesn't feel like putting in a retrograde coronary sinus in, right?
Yeah, that's correct.
Right. So, one day you're going to have this problem, and I would keep that in the back of your mind, so it doesn't come back on you. That, what Dr. Samir just said. It depends on a perfect anatomy. None of your coronary artery patients have that perfect perfusion anatomy, and you're going to get a total blockage somewhere where your retrograde would have been necessary for your Del Nito, and you may have a stunned heart that you're dealing with. Mm-hmm. You're getting away with a lot because you have a fast surgeon, and you will probably for quite a while. But I think, Joe, you've seen enough cases now, and this is one reason why you brought this to the controversies topic when we talked about this, because you're seeing some now that doesn't always work out.
We have I think 2 surgeons now who have abandoned the use of, certainly one for sure, but I think the other is on the fence. They're and I'm gonna push them to go back to regular cardioplegia, much to the chagrin of my colleagues here, sitting here with me. But Min's my favorite, so I don't need to worry about it. He's on my side. He's always on my side. Okay. So I think that wraps up this one, and it really dovetails well because perfused organs makes so much more sense. But John has a controversy, so we're going to let's throw up John's next slide on the potassium levels. Yep, there we go. And
so this is the...
this is just so interesting to me that this is even an issue.
This is the only slide I put together because, get some water.
Yeah.
When you Google or search...
that's your tea.
Oh, okay. Oh, that's it. When you Google or search or look in different textbooks or go to different laboratories at different hospitals, ask them what their normal potassium level is, the normal potassium range. You'll get anywhere from 3.0 to as high as 5.5 as to what your hospital's laboratory considers a normal potassium. This was one particular article that I found, and they define it as 3.5 to 5.0. But mild hyperkalemia is actually as high as 6.0. Moderate is as high as 7.0, and it doesn't even get severe in this one particular category range until you're above 7. But the reason that I wanted to bring this to you, Joe, which we talked about a couple months ago, as why this is a controversial topic, and maybe, men, you go to different hospitals and you guys go to different hospitals. As somebody who goes to different hospitals around the country, something that I've noticed in the last 10 years, and that didn't exist, I would say, back in the 80s and 90s anyway, was there seems to be a very, very high sensitivity that didn't exist long ago about coming off pump with potassium, even as high as above 5.0, where they hold coming off pump, have the perfusionist treat the high potassium in one form or another, whether it's just give bicarb or Z-buff or whatever, and then they'll come off. And I see this a lot, and I've seen it where some surgeons are just absolutely adamant. If you sell them, it's 5.3, well, you have to get it down, or you have to do something before we come off. So backing up to many years ago, we talk about cardioplegia, it was always Plegisol. You did 2 or 3 liters of Plegisol during the case. And back then there was no low potassium, everything was high potassium. So you came off pump almost daily with potassiums well into the 5s and easily into the low 6s. And some days you even had it higher than that, and nobody even discussed it. We just came off pump. And quite honestly, I've seen thousands of cases where it just didn't have any issue coming off pump with an elevated potassium. And we talked about this in one of the previous sessions when this came up. When you're on pump is a different environment than probably anywhere else in the ICU or even in the hospital when the patient starts to elevate their potassium. But just so we can recap from a perfusion standpoint, when you're on pump, all the drips are off, all your inotropes are off, everything is off from anesthesia. You have elevated potassium, usually because of high cardioplegia, so that's going to be something you're going to deal with. And you also have a non-pulsatile flow. So the fact that you have no inotropes going and you have a non-pulsatile flow, the moment that you return the pulsatile flow, and I mean literally within seconds or 1 to 2 minutes, when you return the pulsatile flow, your cellular level sodium-potassium pump regulatories kick in. They don't work very well with a non-pulsatile flow, the sodium-potassium pump on the cellular level. But when pulsatile returns, your body automatically sees a little bit of a high potassium, and the sodium-potassium pumps across the cell immediately be able to begin to bring high potassium into the cell, and it self-corrects literally within 1 to 2 minutes of coming off pump. I've sampled this blood before and seen it drop a half a point to a point within 2 to 3 minutes sometimes, most of the time. Then you also have positive inotropes that are going to be turned on. Potassium basically, first of all, is a negative chronotrope. That's what it first of all is. It slows your heart rate down. It slows the QRS complex. Eventually you don't have any flat line altogether, right?
That slows depolarization.
Right, so but eventually it's going to be a negative inotrope. It's going to be a negative inotrope, but first it's but first it's a huge negative chronotrope, which is easily correctable. So think about what happens on perfusion. I would say 80-90% of us out there, what do we do before we come off? You give a gram of calcium. A lot of times the anesthesiologists give another gram of calcium. Right. They don't tell us, but they give another gram.
But we don't tell them either.
We don't tell them, they don't tell us. So
works out good.
But calcium is a very powerful positive inotrope.
Yeah.
The little bit of a negative chronotrope effect that you have from, let's say, a mild or even in the moderate range on this slide of potassium is quickly counteracted, in my opinion, by a gram or 2 of calcium. Now they're also going to give, there are other inotropes that they're sitting on, right? Your epi and all the things that they have up there. Dopamine.
We try not to have to do that on our cases. I mean, I don't know where you're doing cases, but we don't routinely have epi.
Right,
but we might have a little dobutamine or something like that.
Whatever you're.
Yeah. We try not to, start drips unless we really need it.
You're doing good preservation of your hearts, I'm sure.
You go a lot of different places, though. So you go a lot more places than we do.
Yeah,
and that sometimes, we forget. We think all of these. We think heart surgery is heart surgery is heart surgery, and it is, but it isn't. A heart surgeon and a perfusionist and an anesthesiologist is not always the same level and capability everywhere you go. And it only takes one within the system to mess it all up. In some places, it's all 3.
It depends on the pieces of the puzzle that are coming together. Sometimes you have traveling surgeons and a traveling perfusionist, and you may even have
Don't even know each other.
I did a case one time, never met any of the people in the room. Never saw a case, never observed a case, didn't know anybody in the room, and fortunately it went well. But you don't know like the expectations of that person. You assume where you were at, it's automatic that certain things were going to happen. You better not think that way when you're in a strange environment. You better think, I'm not sure what's going to happen next, and vice versa. And so it's easy to have problems.
So funny, the Blue Angels would never do an air show like that. They just all, different pilots from everywhere else just show up and all of a sudden take off in these complex aircraft and try doing all of these maneuvers. Even though they all know how to do them, that team is so important to understand what the other person is thinking in order to do this kind of operation, I think, because it's kind of like an air show.
Right.
To do this operation safely for patients. I just find that to be so lacking the respect that what we do deserves, frankly. But that's fine. That's an opinion. What's your thoughts on this potassium issue, Dr. Samir? We're going to go down the line.
Potassium is like insulting me. I can't stand potassium. I hate, for me, 6-1 to 7, I will start to moderate to treat. I will not come off bypass above 7.
But you would come off at 6 at 5.9.
I would come on 5.9, yeah.
Well, just to recap this, you nowadays you can't even get out of 5.5. Forget about getting into 6 and 7s. You hardly ever see that at places that are concerned about potassium. So it's a little different though. It's totally different when you're in the ICU, right? Now your inotropes are running. Your pulsatile flow is happening. And if your potassium is getting away from you, the potassium is getting higher because your renals aren't working or whatever, people aren't going to sit around and wait till the potassium is 6.5 or 7 before they do something about it. They're going to do something about it way into the mid-5s because the trend is going the wrong way. But again, you have the return of the pulsatile flow. Your body's functioning normally, hopefully. Sodium-potassium pump is working, and your inotropes are on, and your potassium's still getting away from you. On perfusion, none of those things are the case. So my point from a perfusion standpoint was we're hyperventilating about these high potassiums, and we've not even let the body take care of it or let anesthesia do some things that are going to negate the effects of a little bit of high potassium.
Well, you just answered the question. You can cure the minor hyperkalemia with a little hyperventilation. All you have to do is raise the pH. I mean, this is pretty easy to do. I'm not even sure you can give an amp bicarb. You can give a little bit of insulin, a little glucose and insulin. It's such an easy thing to treat. And there's reason I brought this up. I'm so glad he brought. I mean, this is his topic.
Yeah.
I don't go to these places, thank goodness, because I can't imagine somebody getting exercised to be a little bit to get that exercised over a potassium of 6. But we are doing cases, and they just did one on Thursday, I believe, minimally invasive mitral valve. And how we do it, I think you know our little technique, we give the patient 400 milliequivalents of potassium in a single shot. For a minimally invasive mitral valve, right anterior thoracotomy, the potassium is 13, 14, 15, and we leave it there until we CVVH it all off, and we get it down, and we come off bypass on those patients with it at 6.5. We're happy, the heart's beating, and we'll come off for 6 minutes, as long as it's going down.
Yeah, that actual patient had some renal issues. I think their creat was actually fairly high. So we actually got it down to 4.7.
Oh, okay. Well, that's good. Yeah, you want to do that.
Yeah.
But the first time I ever did that hyperkalemia technique, believe it or not, was on a patient who was a renal failure patient. And the reason I ended up giving so much is I couldn't stop the heart. That heart was still beating with the potassium of 9. So if you have a patient who is conditioned because of chronic kidney disease, you'll find that those hearts won't stop with whatever potassium you give them. You got to get it to some extraordinary level to stop the heart. It's just amazing. They become conditioned to it.
No, I did have a conversation with our ICU nurses before I came to this lecture, and they have seen patients with severe dysrhythmias at potassiums of 6.0 and 5.9. They get concerned. They've seen patients that didn't have any effect. Then they have seen some that do.
Yeah, but that's in the ICU. You're talking about two different phenomena.
Right. That's why I want to make
clear.
That's why I want to make clear that we are talking about two different things.
Of course we are. Yes, and I think that's reasonable. That's fair.
So I guess when you, or let's say you're at a potassium of 5.5, you're on pump, and you're having to Z-buff 2 or 3 liters of saline just to get your potassium from 5.5 down to 5.0.
Which is one of the worst things you can do,
Right.
because you're going to dilute now your bicarb. You're going to become acidotic. You're going to flux more potassium intracellular to extracellular because your pH is low.
What are your thoughts about sodium chloride in general as an IV solution?
I mean, I like it to a certain point, but too much of it, you're going to have that problem.
So Dr., I think his name's Dr. Kelly, is one of the top nephrologists in the country, does a lot of lectures. He started calling, and there's others that are calling for a complete ban on normal saline as an IV solution, period. This global ban on it, because he says your normal sodium intake, your what is it, the FDA normal sodium intake for a person is supposed to be 2,500 milligrams, which is actually a lot. You can get away with far less than that and feel a lot better. I think there's 9 grams of sodium in 1 liter of sodium chloride.
Yeah. Well, I mean, if you give enough sodium chloride, your sodium goes up to 148, 154, 160. You have to use half normal. You got to think about what you're doing.
Right. You just look at the trend and you just follow the trend. I mean, you're following the trend of your labs.
Yeah, sure.
I mean, you can switch to LR, you can do whatever. Just follow the trend of your labs.
If you see the K starting to go down, then you may Z-buff maybe just 500 of saline.
And if you try, and if like you're having issue with your K, you can start early taking care of it.
Yeah.
And hyperventilating is nothing wrong with it.
Right, absolutely.
I mean,
transiently. And if you have to give a little glucose, I mean, it's really kind of,
and
look, I mean, to be honest with you, I think
or
this
a little
is...
Atrovent, and there is actually, in the market is coming a new potassium binder. There's going to be making life much easier. You know, the IV potassium binder. It's coming to market in the next month.
Oh, really?
Yes,
I don't know anything about that.
I will get the information for next time for you, boss.
Yeah, that's a good one. I like that. I didn't know they had that. A selective potassium binder.
Selective potassium binder, IV. Huh. No more K-exhalate, there's dramas and all that.
Yes. Yeah, I was thinking about K-exhalate. We could do that intraoperatively. It'd be tough.
I'm sure that the OR nurses would love that. It would be the highlight of their day.
The highlight. We love our OR nurses. Yeah. You want to throw Jeff online? Hey, Jeff, sorry about that.
That's all right. Hey, I wanted to chime in on the Nito topic. I'll first start with this potassium topic since we're on that.
Say that again.
Generally, we don't treat. Yeah, I'll talk about the Nito after I talk about potassium. So with regards to potassium, I think, again, that could be just like the blood transfusion, patient-specific. I've seen some patients, particularly your chronic renal failure patients, are able to tolerate a little higher potassium levels than non-chronic renal patients. So usually, you know, we don't treat potassium coming out bypass if it's up to 6, unless we have EKG changes and some other, you know, cardinal signs that it needs treated. Once it gets 6 or higher, though, we won't let it treated before we come out bypass. You know, with that said, there's a place I cover per diem across town. So again, it may be institution surgeon specific, but I do think it's also patient specific, and if you're having any EKG changes.
Yeah, I think that makes sense.
With respect to the cardioplegia, so we've used microplegia with the Quest for years. I've used it for 20 years, whatever. We never had a problem with it. And then across town, they use Nito for everybody. Valves, CABG, integrate only. I've never used retrograde over there. And I've noticed they do single cross technique, but I have noticed that many times we've had to remain on bypass for an additional 15 to 30 minutes for that heart to recover prior to coming off.
With which technique?
The clamp comes off, and 10 minutes later we try to wean, and the patient's not really looking too good. We got to go back on full support and rest that heart for another 15 to 30 minutes. I've never really seen that with microplegia, unless it's a real sick heart, low EF or complex procedure.
So, Jeff, let me just ask: you're saying that you see that with Del Nito, or you don't see it with so you see on Del Nito where you're weaning, you're a little slower to wean than when you use the microplege.
Yeah. So my main place of employment, we always use Hyperkalemia, and we really never had any issues. Again, the small tight dose, we have doses every 20 minutes, 20 to 30 minutes on cap on valves, and then after each graft on cabbages. That being one doc did distal procs, other guy did all his distals and all his procs.
Mm-hmm. I mean, I think
and
the
I cover
concept.
per diem at a place across town, and they use all Del Nito on everybody.
Mm-hmm. Yeah.
All antegrade, never gave retrograde. And I have all single cross stamp techniques. They'll go up to 90 minutes without redosing.
Mm-hmm.
And I have seen extended periods of reperfusion post cross slam in order to wean seminal bypass.
Mm-hmm.
I mean, we may be on for 30 minutes after the clamp comes off, after like trying to come off 1 or 2 times or whatever, with and the heart's just not ready to come off on its own.
Mm-hmm.
I haven't seen that with microplegia.
Mm-hmm.
Well, Jeff, that might not be just washout of the Del Nito. That may be stunned myocardium coming back, and it takes you that long. Usually,
well, I think that's caused from washout of the Del Nito.
Or poor preservation, because he's saying they don't do any
poor
it could be a
preservation.
combination of that.
Yeah.
I don't do enough cases over there to really know how often it happens, but in the limited number of cases I have done over there, I have noticed that.
Mm-hmm.
Well, there's definitely a truth to if you have given the Del Nito within even 20 or 30 minutes as a repeat dose, you're going to have 5 minutes or so, sometimes 7 or 8 minutes, where your EKG looks very funky before it normalizes. But once it does, usually the heart, if it's been preserved, is pretty healthy, ready to come off. If you're having to go on
I've
and
never
off,
redosed there. I mean, they've gone 60, 90 minutes on a single dose. So I've never redosed there even at 90 minutes.
right? So you're probably pushing a stunned myocardium that's taking 30 minutes or so to recover.
Well, unlike the pediatric heart, and anyone correct me if you're being kind of quiet. I need to get you into this. Okay, you're not saying a whole lot.
Everybody has good comments. I'm just listening.
Yeah, well, I need you to jump in on this. But what does an atherosclerotic heart diseased heart have different from a non-diseased, especially pediatric heart?
I mean, I don't really have any experience in pediatrics, but I mean, I would imagine, I mean, some of these pediatrics, they probably don't have coronary disease, right? Not like.
Well, they don't have coronary disease, but when you have coronary disease, what do you develop? What do you have more of?
Clogged arteries. Right?
Well, yeah, but you have more.
Perfusion.
You have more non-coronary collaterals that develop into the heart.
Right.
Therefore, when you give this single dose of cardioplegia, you may have the cross clamp on, and the native coronary ostia are not being perfused, but the non-coronary collaterals that have been developed are feeding that heart, washing that cardioplegia out.
Right, that makes sense.
That's what I think. I see you shaking your head over there, Dr. Samir. You're agreeing with me.
Yeah.
That makes sense.
I mean, I said something smart today?
Always. You always say something smart. I think, going for that long period of time with one single shot,
is a mistake.
Yeah, with the kind of hearts that we all see, and the kind of valves we all see, I would be very, very concerned.
I think at 60 minutes,
I think that when you have to rest the heart, like on bypass, for 30 minutes before coming off, that's an indication of that situation.
You've done something wrong.
Yeah.
90 minutes is too long. You have to redose at least 60 to 70 minutes if you think it's going to be another 20, 30 minutes of ischemic time.
So you think 60 minutes is more reasonable than 90 minutes?
I think 60 minutes.
Right. 90 minutes is way too long.
The standard guideline is for 90 minutes, but I think you're putting the patient at risk, and your preservation is going to be reduced, obviously.
Jeff, you need to send this video to that hospital so they can hear what our comments were. All right?
They can come and attack us.
But I'm just per diem there, so I just go through and do as they do, and don't ask any questions and whatever,
Exactly. I know. Sometimes
I do have another question. So this new surgeon we have, because they got rid of our two main surgeons and they brought this new guy in from the University of Miami. We use Hyperkalemia on all of his CABGs, and the valve he wants modified Del Nito, which is the same ingredients as regular Del Nito, with the exception of the potassium is 40 milliequivalents instead of 13. So we give this out of 4-to-1 blood to crystalloid ratio. So my question is, why don't we just use Del Nito for valves, whatever? Because that's what seems to be good for valves. It's like, why don't we just give the one dose? I never asked him this, and maybe I should just ask him myself. It's like, well, if we're using modified Del Nito, why don't we just use regular Del Nito and give one dose versus just 4-to-1 modified and do a multi-dose cardioplegia with it,
Well, I'll tell you, and I can't answer your question. I don't know if anybody else here can either, but
yeah, I was just wondering.
But I mean, I don't know if anybody can answer. Please just go ahead. But my view on what you're saying to me is when somebody takes a formula and then they have zero academic laboratory research experience, start modifying it willy-nilly because they think something is probably synonymous to somebody saying in deep Louisiana, watch my beer and hold this.
Yeah.
That's good.
Yeah, so that's what I think about that. Okay, well, I think we're going to go to break. I think we have beaten this topic to death.
Yeah.
Jeff, thank you for the call. John, thank you for the call. Brian, thank you for your questions online. Also Nestor, and to Robert Parchman in Shreveport, and anyone else who I forgot to mention or didn't find or see. Thank you so much. We're going to be back in 15 minutes, and we're going to be talking about metabolic alkalosis, definition, etiology, and treatment with John Ingram, and then we're going to be talking about long-term outcomes after off-pump versus on-pump surgery by experienced surgeons, and it's going to be an article review of the latest ACC journal article on this topic, which again still seems to be being debated. So if you'll give us 15 minutes, take a break, we'll be right back.
Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing. Passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality-packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And welcome back, everybody. Okay, so we're back live with you after our break. Hope everybody got a good opportunity to get something to drink and eat maybe and all that kind of stuff. Listen, I wanted to put this picture up. This is a very famous picture. This picture has been circulated around many, 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 many times. You've seen this before, right, Dr. Samir?
Absolutely.
Very famous picture. Well, so happens that's Dr. Religa, and unfortunately he has since passed, and that's the surgeon that's there sitting on this chair. The patient in this particular case also didn't have the opportunity to make it. It was a heart transplant operation, and it was done in Poland, in Zabraza. How you say it? Zabsha. That's right, Zabsha, Poland. But does anybody see the guy that's sleeping in the corner?
Yeah.
Okay, you see the guy in the right corner?
Right.
You see him sleeping?
Yeah, I see it.
Without
A lot
hat.
of people miss that guy, okay? That's Dr. Zembala, Marian Zembala. And he now currently has what was Dr. Religa's position. He was his assistant, passed out in the corner. He now is the chief of cardiac surgery and transplant at this very same hospital. So why do I show you this picture? I want to tell everybody out there in web world, you want to make sure that you keep an eye out for when we do this. But we are going to Poland, and we are going to interview that guy about this case and that particular day. And I think it's going to be a powerful and riveting broadcast. But we're planning the trip. We've reached out to them. And so you guys keep an eye on perfweb.us for when this notification comes out that we're going to be doing this, because we're going to go on location and do a broadcast from that operating room. You want to come with us?
I was just going to ask.
You coming too?
Are we going in private jets?
My passport is
Your private jets?
Yes, in my private prop.
Yeah.
We're gonna have to do some in-flight refueling.
Right.
Okay, so no, I'm flying. It's gonna be United. Okay, United,
Right.
Doc, United.
Right.
So keep your eyes open for when we do this. All right. John is going to be talking to us about something that I don't really think much of us think much about. But apparently you're having, again, some experience out in the world, the places that we don't go, where metabolic alkalosis is either an issue or a misunderstood phenomenon or problem. So with that said, John Ingram.
Well, thank you so much, Joe. And you're right. When we talked about this 6 or 8 weeks ago, coming up with this topic, I said, this is something that I run into not too frequently, but occasionally on bypass. Even you have a patient that's just metabolically alkalotic, and nobody seems to do anything about it. You also see them occasionally in the ICU, and occasionally, more than occasionally, on ECMO. And we had one recently where the patient was probably about 7.59, 7.6. And I asked the attending physicians, and they were doing rounds, does anybody have any idea why this patient is alkalotic? No. Are we gonna do anything about? Are we gonna treat it? No, we're not gonna do anything about it. So I found that to be something fairly common in my career, is that we just seem to have these occasional patients that are metabolic alkalosis, and nothing seems to come of it. We just seem to sort of ride with it until what? And as perfusionists, we're probably detached from this. So this is really not about perfusion. This is about this topic, which I hope to learn a lot about in doing this. I'm not so sure I'm an expert on it.
Isn't that what they say, that the person that learns the most from a lecture is the person that's giving the lecture? Isn't that what they say?
Mm-hmm. I feel that way.
Mm-hmm.
One time I was told an expert is someone from out of town with slides.
I like that.
That's even better. I like that.
I like that.
So here we go with this. So metabolic alkalosis is defined as a disease state where the pH is elevated above 7.45, secondary to some metabolic process that's causing that. This disease process results in a primary increase of the sodium bicarbonate concentration, either due to a loss of the hydrogen ions in your system or a gain in the bicarbonate ions. Why is this important? The biological effects of metabolic alkalosis are a direct result of hypovolemia, hypokalemia, and hypochloremia. So kind of keep those three things in mind. And they usually all tie in together. And that's a decrease in your circulating volume, decrease in potassium and chloride depletion. Well, this is important because it can lead to changes in arrhythmia changes, confusion, decreased myocardial contractility, which is going to translate to decreased blood flow, cerebral blood flow, increased neuromuscular excitability, and all these things are linked to this dysregulation of the potassium and chloride and or the volume. But here's the important thing I discovered, Joe. We talk about acidosis a lot, but in alkalosis, it shifts the oxygen dissociation curve to the left. It impairs peripheral oxygen unloading.
Wait. I'm sorry to interrupt you. Did you say if for alkalosis it shifts it to the left? I thought it shifted it to the right. If it shifts
right?
left,
Yes, it shifts to the right.
you release it more readily.
Okay,
If
so
it
it's to the
shifts
right?
To the
It's to
right,
the right.
to
It's
the
the
right.
opposite.
So
sorry, I don't. It's probably just a typo on
Yeah,
your
it's a
slide, but I
typo
wanted
because-
to correct that before we got too much further.
okay, so I apologize for that. So
Okay,
it
shifts it to the
impairs
right.
your peripheral oxygen unloading. So it shifts the oxidation curve to the right. Then I'm sorry. So what happens is when you have this alkalosis, in addition to shifting the curve to the right, there's a compensatory increase in your arterial PCO2 through hypoventilation. Well, hypoventilation is also going to decrease your oxygenation. So you have a double impact there, which basically leads you to an overall net effect of systemic hypoxia. And this is not something I think most of us have thought much about, is that metabolic alkalosis is really leading us to a systemic hypoxic state. So when is metabolic alkalosis life-threatening? Well, the mortality associated with severe metabolic alkalosis is actually quite substantial. An arterial pH of 7.55 has a mortality rate of 45%, but arterial blood pH greater than 7.65 has a mortality rate of 80%. So this is why we care about this.
Wait. I don't want to interrupt you. Independently, or
when you look
associated with, like, I mean, you're saying just a metabolic acidosis uncompensated with a normal CO2, or are you saying there's other confounding factors?
Yeah, I mean,
why would it have a mortality rate of 80%? That's just trying to understand.
It's going to be the affiliated metabolic dysfunction that we're going to talk about.
Okay.
There's so much going on. In order for you to have a pH like that, now remember, pH is a logarithmic scale, right? So a small increase in pH is an exponential increase in actual. So what happens here is that there's a setup or a phase one or a cause or etiology of how you became alkalotic in the first place. So in order for the metabolic alkalosis to become established, there's basically 5 known etiologies, or what some people call precipitating factors. This precipitating factor is just a term that I read about that particular people use. It's not scientific, but it's one of the etiologies that sets up, and what they are is gastrointestinal hydrogen ion loss. In other words, vomiting or diarrhea. You can have a renal hydrogen ion loss, usually through diuretics or our aldosterone levels being high. You can have an intracellular shift of hydrogen ions on the intracellular level, exchanging with low potassium, hypokalemia. You can also just have an administration of bicarbonate ions, like people who take a lot of antacids, or we can self-administrate to the patient too much bicarbonate in the hospital. But most commonly, it's what's called a contraction alkalosis, which is really a fancy word for patients who become dehydrated. So one of these 5 etiologies almost always is one or more of what sets the person up and becomes alkalotic in the first place. But what maintains the alkalosis is what's important, because those first phase 1 can be easily corrected lots of times. But what maintains the alkalosis on patients when you see they stay in metabolic alkalosis for days at a time is that there must be one of these maintenance factors in place also. And these are hypovolemia, reduced intravascular blood volume, decreased potassium, hypokalemia, hypochloremia, decreased chloride, or renal dysfunction, which in this particular dysfunction is going to reduce the ability of the bicarbonate ion to be removed. Or hyperaldosteronism. Anything that increases your aldosterone levels is going to have a double negative effect, which decreases your potassium and your hydrogen. We're going to talk about all of these here in a bit. So the premise for metabolic alkalosis is, in order for it to be created, there must be one or more of these etiologies, or what I call precipitating factors, in place. In order for the metabolic alkalosis to be maintained, there must be one or more of the maintenance factors in place. The reason for this is that the etiologies are the ones that increase the serum bicarbonate concentration in the first place, and the maintenance factors maintain the alkalosis. And how do they do that? They maintain the level of bicarbonate ions, the circulating bicarbonate ions, either by decreasing bicarbonate excretion or through increased bicarbonate reabsorption, which is sort of the same thing. Either way, your kidneys are not excreting the bicarbonate ion properly. So back to the causes or the etiologies, phase one of this. Those 5 things at the bottom there are actually easily rectified as long as renal function is maintained. Excess bicarbonate is excreted in the urine fairly rapidly. Like a lot of us have had vomiting or been dehydrated, and we don't go into metabolic alkalosis. Our renal function is normal, and we excrete the excess bicarbonate ion fairly rapidly. Well, in people that maintain their alkalosis, the metabolic alkalosis will persevere because these maintenance factors that are also in place reduce the kidney's ability to eliminate these excess bicarbonate ions. So that's how you stay in metabolic alkalosis. So looking at these 5 causes and the etiologies again, we're going to look at each one and what they do and how they cause the alkalosis. So first of all, the gastrointestinal or GI hydrogen ion loss. Well, you have upper GI, you can have an upper GI factor, which is either vomiting, or we can also see this in the hospital, we have excessive GI tube suctioning. Or you can have a lower GI, which is usually diarrhea, or people who use excessive laxatives or enemas. So let's look at the upper GI one. So one of the important things to know, a lot of us probably have forgotten, is that the pH of your stomach fluids are 1.5 to 3.5. And what I was saying earlier, because it's a logarithmic scale, imagine how incredibly acidotic that is and how much hydrogen ions are actually present to produce that type of pH. So hydrogen secretion enters the stomach through the cells in the lining of the gastric mucosa, but when you lose these gastric secretions, you lose a lot of hydrogen ions. Well, in order to maintain the normal gastric pH, the hydrogen ions will make their way from the blood, will be replenished back into the gastric mucosa, leading to an increase in the concentration bicarbonate in the blood, right? Because you're losing hydrogen ion. Thus is driving your alkalosis, okay? In the lower GI situation, diarrhea, excessive laxatives, so chronic use of excessive laxatives or enemas or any form of diarrhea really are most commonly the cause of low potassium levels. So on the upper GI was a loss of hydrogen ions, but in the lower GI it's largely a loss of potassium, and we're going to see how that affects it. So the laxatives and enemas at high doses can cause a loss of potassium in the stool, especially if they result in diarrhea. So excessive diarrhea will trigger alkalosis because the low potassium causes a decrease in hydrogen ion concentration. So I want you to hold that thought because I'm going to show you why and how low potassium causes decreased hydrogen ion. So you can have a GI hydrogen loss, you can have a renal hydrogen ion loss. So now, what's an important key to remember? That hydrogen is used within the kidneys as an exchange ion to maintain the electrical balance of other ions. That's what you have to important to remember. The reason hydrogen comes into play when all these other ions become depleted is that hydrogen is used as the exchange ion. Number 2 key to remember is aldosterone, which is an antidiuretic, causes retention of sodium and water, therefore it's an antidiuretic, to be reabsorbed in exchange for hydrogen and potassium. So therefore, conditions or pathologies that increase the level of aldosterone or the effect of aldosterone lead to hypernatremia, low potassium, hypokalemia, and decreased hydrogen levels. So just to give you some example, Conn syndrome is one such pathology, which is hyperaldosteronism. And just having low blood pressure, low blood volume, low blood pressure, will also increase your aldosterone production because your kidneys are going to try to increase your blood pressure. We're going to talk more about those. Now, diuretics cause increased excretion of potassium through the urine. Loop and thiazide diuretics are capable of inducing aldosteronism production just by the fact of what they're doing. They're decreasing the volume and therefore can decrease your blood pressure, but then the kidneys respond to that and stimulate the renin, angiotensin, aldosterone system, which then produces aldosterone. So, you know, what's interesting, even though you give somebody diuretics, which you want to lower their blood pressure oftentimes while you're doing that, your body counteracts that by producing aldosterone, and this can also tend to bring you towards maintaining metabolic alkalosis. So now there's two genetic defects that are out there. They're pretty rare, but you see them whenever you read something about metabolic alkalosis. This came up in every article I read. Bartter and Gittleman disease are genetic defects. They're rare, but they're genetic defects that lead to decreased expression of these ion transporters in the loop of Henle. But these syndromes have the net effect of the loop and thiazide diuretics respectively. In fact, Bartter syndrome almost mimics what a loop diuretic would do, and Gittleman disease mimics what thiazide diuretic would do. It's just interesting. So now let's look at intracellular shift of hydrogen ions, hypokalemia. The key to remember is anytime hydrogen ions are shifted intracellularly, it creates a relative increase in the bicarbonate ion concentration, right? Which increases your pH. So basically, your bicarbonate ion is increasing, not net, but as a result of a lack of hydrogen being present. So here's what I said about hold that thought earlier. Shift of hydrogen ions into the intracellular space is caused by a low potassium, hypokalemia. Due to a low extracellular potassium concentration, potassium shifts out of the cells, so the body is going to try to correct this low potassium, and it's an intracellular ion, right? Potassium's intracellular, there's tons of it intracellularly. It's just going to shift some extracellularly to try to bring your potassium back up, but in doing that, it has to exchange for something. There's a price to be paid. It has to exchange with hydrogen. So in order to maintain the electrical neutrality, hydrogen ion shifts into the cells, raising the pH, maintaining alkalosis. So what you see here is, just for an example, if there's your cell and you have low potassium, and let's just say 4 potassium cells exit the cell, you have to have 4 hydrogen ions enter the cell. And this, in order to maintain the electrical neutrality of the cell, well, this is what's driving your alkalosis. Now you can have number 5, which is, or number 4, administration and retention of bicarbonate ions, right? So we can just have etiologies that lead to increased bicarbonate. Well, the most common one, Joe, you mentioned this when we were talking about this, is that we see patients that are COPD, right? And they've naturally compensated. So what you have is, in COPD patients, a patient hypoventilates, retaining their CO2, and this subsequently produces the acidosis. So over time, the renal system compensates by retaining bicarbonate to balance the pH. But if we take this patient into the hospital and we correct the hypoventilation, such as when they're on a ventilator, the CO2 levels will decrease, but the bicarbonate levels still remain, and they're very slow to reduce. And this is why it's very challenging. I'm sure Dr. Samir can talk a lot about this, is when you have a COPD patient on the ventilator, you try to get them off very quickly, correct?
Absolutely.
Because of this problem. So this is going to cause post-hypercapnia metabolic alkalosis, which is slowly self-correcting. Or you can have just a consumption of oral antacids. Sometimes people take a lot of antacids, but commonly you see it with people taking calcium bicarbonate with osteoporosis conditions. You can also have, believe it or not, an alkalosis due to overconsumption of milk or an overconsumption of black licorice. You have to consume.
I love that. I love black licorice.
If you consume a lot of it over a 3-day period, you could have this condition. In fact, the FDA, if you Google this, the FDA had released a statement about the warnings of overconsumption of black licorice.
Yes.
So,
you can get, in fact, you can get severe hyperkalemia. Actually, there have been
that's what happens.
People who have arrested.
Right.
Yeah, from it.
Yeah. So,
they have.
We'll put you on ECMO, don't worry.
Well, okay. All right. Well, since you broke the ice, I have to make a very quick announcement. It was a test. And I want you to all know that you've all done poorly on this test.
Oh.
Alkalosis shifts the oxyhemoglobin curve to the left.
I was right.
You were correct. You should have stood by it. And all of y'all, when I said it, were like, oh, yeah.
Okay.
See, I led you right down the path. But JCAM pointed it out to me. Vicky has pointed it out to me. Everyone has pointed out that it was a test, though. See, I was only exploring your veracity.
Now you're exploring that we're following the leader.
Don't follow me to the abyss. John, go ahead. I'm sorry.
Well, I think I deserve a free cup then.
You do. You get John gets a free PerfWeb cup.
I
So
thought
does JCAM.
you know that
So does
saying.
JCAM.
You know that saying, Joe, right? I thought I was wrong once, but I was mistaken.
You know what? I'm frequently wrong, but never in doubt.
I knew John was right, but I had to get your back because I'm thinking that.
Thanks, bud. Thanks, bud. Thanks, bud.
Okay.
John, I'm sorry. Go ahead, please.
So
Good job, John.
So, Joe, you know, in European countries, there's one or two countries in particular where they do consume an enormous amount of black licorice, and they do see patients come to the ER with metabolic alkalosis. I'm not so sure we see that too often in our country. But. So you can have a person can overconsume alkaline substances, or just in the hospital, we can overdose somebody with sodium bicarb. So the last one is the most common one, apparently, which is contraction alkalosis or hypovolemia / dehydration. This phenomenon basically occurs when you lose a large volume of sodium-rich but bicarbonate poor fluid. It causes chloride depletion. And what this does, there's a chloride bicarbonate exchange in the renal collecting duct, and this causes that collecting duct to fail and dysregulate. So you end up retaining far more bicarbonate than you normally would. So this is going to occur so your contraction alkalosis or hypovolemia occurs with vomiting, sweating, diuretics, cystic fibrosis, and I put the note here because people put that up there to scratch their heads. In cystic fibrosis patients, they have a dysfunctional regulators in their sweat ducts, correct? As well as in their GI tract. And this dysregulation causes excessive chloride and sodium losses, okay? Diarrhea, talked about, and then this is not an all-inclusive list. There's many others, but most of them will involve renal dysfunction or some type of aldosterone level, high concentration of aldosterone. The net concentration of bicarbonate increases as a result. Normally, these pathologies are easily offset by the release of hydrogen from the intracellular space to balance the pH in most incidences. But people who continue with metabolic alkalosis have one of these maintenance factors also. And these are the 5 we talked about earlier. So we look at each one of these. So reduced intravascular blood volume. Well, your low blood pressure causes aldosterone released by your kidneys, which is trying to retain volume and increase your blood pressure back up. This increases the sodium and water reabsorption, but it also increases your bicarbonate ion reabsorption. So that's number one, as well as the excretion of potassium and hydrogen. So this is a double whammy. Whenever you have an increased aldosterone level, you're retaining bicarbonate and you're excreting hydrogen. And that's the price that's paid to try to get your blood pressure back up, but it's driving your alkalosis. In the case of low potassium, intracellular potassium shifts out of the cell in exchange for hydrogen going back inside the cell, which we talked about earlier. This then causes a decrease in concentration of hydrogen, again driving alkalosis. But it also activates the potassium hydrogen HEPase pumps in the renal tubules, which then reabsorb potassium and secrete hydrogen ions in the urine. So that's a double whammy there of low potassium. Hypochloremia, which is generally as a result of loss of vomiting, excessive GI suctioning, and some diuretics, this causes the kidneys to increase its reabsorption of bicarbonate ion, maintaining alkalosis. When you have certain renal dysfunctions, not all, but certain renal dysfunctions, you have a reduced GFR, but in certain renal dysfunctions, you have reduced removal of the bicarbonate ion. So renal insufficiency, whereby the kidney is not excreting the excess bicarbonate ions, as it normally would, therefore, again, maintaining your alkalosis. And this one, hyperaldosteronism, which is a very powerful one, usually it's a condition like chronic condition, but doesn't have to be, but Conn syndrome, adrenal tumors, adrenal hyperplasia, or any condition that's going to cause a hyperaldosterone state is going to increase your sodium hydrogen exchange in the kidney, resulting in hydrogen loss, bicarbonate reabsorption, and that's going to definitely drive alkalosis. So how are we going to look at a patient? How are we going to manage the patient? Patient history. First question, are we having any upper or lower GI losses? Vomiting, diarrhea. Is the person taking diuretics? Does the person have any renal disease or renal insufficiency? Did they ingest anything, alkali ingestion? This might be antacids, calcium bicarbonate, which is for osteoporosis usually, excessive milk and excessive black licorice. Then you want to do a physical exam. Vital signs, because again, signs of dehydration, muscle weakness, these are all going to your loss of potassium, your hypovolemia, fatigue, of course, muscle cramps, low potassium. So if you do these things, most of the time you're going to be narrowing in on what the cause is. You can also do some laboratory tests. If you send out a blood test, if the patient is alkalotic, you should see a high sodium, you should see a high bicarbonate, low potassium, and low chloride. If you do a blood gas, you should see a higher pH greater than 7.45. Usually, almost always compensatory. The body's almost always going to compensate for this on the respiratory side with CO2 greater than 45 and usually a bicarbonate level greater than 35. Most commonly by now, the diagnosis will be clear. Vomiting, GI suctioning, excess, low blood pressure, diarrhea, laxatives, enemas, dehydration, electrolyte imbalance, person's poor nutrition, or just hypovolemic. I would say 9 out of 10 people that come into the ER that are alkalotic, they're pretty much going to get diagnosed right there. Cystic fibrosis patients talked about earlier, their sweat glands are dysregulated, their GI is dysregulated. And then the one we see a lot with COPD patients where there's a metabolic compensation and then alkali ingestion. So the treatment for all of these common ones would be basically to immediately correct the volume deficiency. You're going to correct the blood pressure and you're going to correct the electrolyte imbalance. Then you're going to see about addressing the actual cause. If the person is having diarrhea or vomiting, you're going to treat that. If the person's doing something to ingest alkali, you're going to do something about that. So usually you can correct the situation here. But for example, for me in the ICU and for some of us, we see patients sitting in the ICU 3, 4, 5 days, or they were even alkalotic before they came to the OR. Why are they maintaining their alkalosis? It's not a simple case of walking into the ER and being dehydrated. So if at this point the diagnosis is not clear, we need to do a renal panel blood test. Look at their BUN, creatinine, GFR, and look at their sodium, potassium chloride, and calcium. But here's where it starts getting a little more complicated. And this does get complicated, actually. Far out of the wheelhouse of my level of knowledge, for sure, as perfusionist. But we do a urine chloride test. If the chloride is less than 20 milliequivalents per liter, it takes us in one direction. If the urine chloride is greater than 20 milliequivalents per liter, it takes us in another direction. You have to see if the person is hypertensive or not. That's going to play a role. Let's look at their renin activity. If the renin activity level is high, it's going to increase their aldosterone production. Or you can just have high aldosterone without a precursor of renin being elevated. So look, this is where it starts getting more complicated. I'm going to try to keep it simple. But this is the algorithm to look at why is our patient staying in metabolic alkalosis and what can we do about it? Because there are things that should be done about it. So you're going to do your physical exam, your metabolic profile, your arterial blood gas, and if you still can't determine the cause, we need to look at urine chloride levels. Like I said, less than 20 milliequivalents is on one direction, greater than 20 it leads us to another direction. On the less than 20, these should be the main things you would look at. loss of gastric secretion, diuretics, post-hypercapnia, villainous adenoma, which is going to increase your aldosterone, and congenital chlorodia, which is really a birth defect. It's a congenital chloride wasting diarrhea. These people have diarrhea all the time that depletes their chloride level. If it's greater than 20, now you have to ask the question, are they hypertensive or not with this greater than 20 milliequivalents per liter of chloride? If they're not hypertensive, it takes you down to diagnosis as genetic defects like Bartter and Gittleman's, if they're on certain diuretics, or they could be depleted of potassium or magnesium. If they are hypertensive, you have to look at what's driving the hypertension. First look at, is their renin activity high or low? If your renin activity is high, they can be on diuretics. They could have renal artery stenosis. They could have a renin-secreting tumor. They could have accelerating hypertension. If their renin is low, then you have to look at just their aldosterone levels. Maybe that alone is driving it, and you have a low and high there as well. If it's low, you can look at black licorice intake, something called Cushing syndrome, taking exogenous steroids, Little syndrome. And then if their aldosterone is high, it's some type of usually chronic condition that's driving a high aldosterone level. So getting back to how we would manage a patient like this. Patient comes in, pH higher than 7.45, CO2 greater than 35, clinical exam, hemodynamic monitoring, renal function, EKG, blood gases. And if the condition is not life-threatening, it's a lot of what I just talked about. But what if the condition is life-threatening? In other words, patient comes into the ER, we don't have all this time to run a urine chloride level and then find out, what else is going on? Is their renin activity too high, or is it their aldosterone? They have a life-threatening condition of metabolic alkalosis. So if it's life-threatening, what does that mean? Well, first of all, a pH should be greater than 7.55, and you can look for the presence of hepatic encephalopathy, cardiac arrhythmia, digitalis cardiotoxicity, or an altered mental status. The mortality associated with, and this is going to be repeat what we said earlier, Joe, the mortality associated with severe metabolic alkalosis is substantial, what I said earlier. If you have, mortality rate can be as high as 45% and over 7.65 as high as 80%. So you're going to have these metabolic dysfunctions going on, Joe, with these. So correction by the appropriate intervention should be undertaken with urgency when the arterial blood pH exceeds 7.55 because of these high percentage of mortality. So everybody's always asked, well, if the patient is acidotic, we give a base, we give bicarbonate. If the patient is alkalotic, no one ever thinks, are we going to give the patient some form of acid? Well, you actually can in severe cases. Hydrochloric acid, sodium chloride, which as you know is very acidic, potassium chloride. If sodium chloride and potassium chloride are contraindicated and you need an immediate correction, you can consider HCl. And it just briefly, how would you give the HCl? And it's actually a simple formula, 0.5 times the weight times the desired amount that you want to decrease your bicarbonate level. For example, if you have an 80 kilogram patient, your bicarb is 35, and let's say you want to reduce it 10 points down to 25. So that would be 10 points reduction. It would be 0.5 times 80 kilograms times the 10 point bicarb reduction. You would give a total dose of 400 milliequivalents. The administration rate is 2 milliequivalents per kilogram per hour. So 2 times 80, you'd give it 160 milliequivalents per hour until you gave the 400 milligrams. So that's how you would go about giving somebody HCl in a severe case. You can also give somebody acetazolamide. I'm not going to get too involved with this, but this basically produces diuresis of the bicarbonate ion, which is one of the things that's failing due to the disease process. So condition is not life-threatening. When you read up on all the metabolic alkalosis articles, well, you'll read this and they can put so many different perspectives on it. But one theme that runs through it is when you look at somebody with metabolic alkalosis, they either fall into a chloride responsive category or a chloride unresponsive category. And the chloride responsive category happens to be where the chloride level in your urine is less than 20. Whoops. And this could either be due to excess alkali loading, which you would just discontinue the bicarbonate or any of its precursors that you ingested, or you could have the hydrogen ion loss. Okay, the digestive hydrogen ion loss that we talked about, vomiting, excessive gastric suction. You could also, so in that case, what you would do, you'd give antiemetics, discontinue the GI suctioning. You could give the H2 blockers or proton blockers, ATPase, hydrogen potassium inhibitors. If you have renal hydrogen ion loss, this is usually due to diuretics or low potassium, discontinue those diuretics that are causing the problem. Use spironolactone. That comes up a lot. Spironolactone is a potassium-sparing diuretic, and discontinue any drugs that are increasing or driving the patient's aldosterone. So, in either one of these, what are we going to do at the bottom? You're going to administer sodium chloride and/or potassium chloride to correct the potassium, the hypokalemia, and the hypochloremia. And you're going to do volume replacement therapy. If that fails, then you can go to these more severe measures of hydrochloride administration, sometimes dialysis also, or acetazolamide. Now this side of the algorithm gets even far more complicated, but when you really look at it, this is your chloride resistant people, which have a greater than 20 milliequivalents per liter chloride in the urine. And what this is chloride resistant metabolic alkalosis is due to an increased effect of the aldosterone. So treatment of chloride-resistant metabolic alkalosis involves correction of the hyperaldosteronism, and there can be so many of those things. So when I showed this earlier, you're looking at the right side there with greater than 20 milliequivalents. You have all these things that can cause high renin activity, which ends up increasing your aldosterone, or direct contributor to increased aldosterone. And you can go through all kinds of diagnosis getting to what the real cause of driving your high aldosterone level is. The problem here is it's not going to respond to the simple administration. So here's the key points in conclusion of everything we've talked about. Metabolic alkalosis is bicarbonate accumulation due to acid loss, due to hydrogen ion loss. Alkali administration, or an intracellular shift of hydrogen ion, or renal bicarbonate retention. The most common causes of volume depletion involving loss of gastric acid, potassium, and chloride due to recurrent vomiting, GI suctioning, or diuretics. Those are the most common causes. Metabolic alkalosis involves a loss of chloride, is called chloride responsive. You can treat the cause and give the patients chloride responsive metabolic alkalosis, 0.9% saline IV and other electrolytes as needed. But in the chloride-resistant metabolic alkalosis, you need to look at what is the condition or pathology causing and driving the increased aldosterone level. Treatment of this chloride-resistant metabolic alkalosis involves correcting the hyperaldosteronism and using potassium-sparing diuretics like spironolactone. All right, that's all I have. Gives you a headache, huh?
Wow. Yes. Yes. Okay. Dr. Samir, I'm turning this over to you.
I mean, to be honest with you, we see it a lot in the cardiac patients because they're dehydrated, because they're coming in failure, and they diarrhea, and they come till they become alcoholic, and people are scared to hydrate them. But unfortunately, the only thing, I can correct anybody's pH by Diamox. Diamox for over 2 days can correct pH with no problem, but that's not really fixing the problem. They are dehydrated. You have to drop some fluid in them. And then we talked about saline before. You have to drop a couple of liters in them. Once you hydrate them, their fine pH is fixed. They will fix themselves. The kidney will respond. They'll fix themselves. You just have to be concerned about their respiratory status. To some of them, it's going to sound weird. You need to intubate them, secure the airway, because they're going to flood their lungs. So, but you have to choose.
Yeah.
And you're not hyperventilating them. You just intubate them. Normalize, keep the pH normal, which is a little difficult with those patients. But if you do that with Diamox, you'd be good.
I mean, doesn't really, I'm assuming it really matters whether or not it's a chronic alkalosis versus an acute situation.
And John is correct. I mean, you can do the studies, the chloride studies, but the problem is those chloride studies, they get very altered by the diuretics. and so you run into, becomes like really a very mass picture. So I have to get somebody much smarter than me, endocrine/renal, involved in these stories. But to be honest with you, Diamox is a great drug, and I'm used to it because it's a very cheap drug, and you can use it a PO or IV, whichever way you want, will correct the pH. But you really not treating the problem. Hydration. That's it.
Right, when you get back to the bottom line, it's so much to do with hydration. But see, that's what's interesting, Joe. You have almost probably 90% of our ECMO patients on CRT. We're constantly trying to dry them out, right? To dry their lungs. And we see metabolic alkalosis in the unit, right? Sometimes because of that. Not always, but occasionally we see.
Well, your CRT solution can be driving that because you have two choices of fluids. You have the 32 bicarb, which is much higher than what 24 being more normal, right? So you're adding, and then you have the lower bicarb solution, which is I think 24, 26.
Yeah, 24.
So it really depends on which solution you're using, which is going to have an effect on that. Yeah. You feel the same way? It's really your fluid selection that you're using, and you can dilute your CVVH fluid, your CRRT solution. You can have a bag of that on one scale and a bag of normal saline on the other, and this will counter your sodium load from the saline, but the saline will dilute out the bicarb from the CRRT solution if you don't have the low bicarb solution. So you can mix and match if you really understand how the CRRT machine works.
And to be honest with you, a good renal guy can balance it and make so you really have to depend on them a lot.
But based on, my error, which I'm again, it wasn't really an error, it was a test. And I want to make sure you understand that. But
understand is the best.
But whichever way you shift it, alkalosis increases the affinity of the oxygen for the hemoglobin, meaning it's not going to release it to the tissue. So perhaps, and I'm assuming this, because I've really never thought much about it. I've seen alkalosis before, really didn't think much of it, because usually you go on pump and it sort of corrects itself because we're creating a environment, maybe a little hypoperfusion, who knows what. But I've seen it just sort of correct itself. I've really never dealt with somebody who had this chronic alkalotic issue, but or persistent, let's say that way, rather than chronic, persistent. But if it does decrease or increase the affinity for oxygen to hemoglobin, which means it decreases its release to the tissue, do you get a relative tissue hypoxemia associated with that? Can that happen? Dr. Samir?
Yeah, I think that's the concern. I think
That's
what I learned. That's what I learned from this.
I mean, you really can correct that easily, to be honest.
It's easy to fix.
Yeah.
Just give some saline. So here we're talking about using saline to correct alkalosis, but yet how many people, I don't mean to change the subject, advocate the use of pouring saline in for resuscitative measures? So does that make sense then? So you have a patient who you're resuscitating and they're not alkalotic, you're resuscitating them, their fluid volume, and you give them something that you would use to correct alkalosis. It seems to me that's somewhat counterintuitive. You're causing quite a bit of acidosis.
I don't think you like saline that much, but I love saline.
You do?
I love saline.
I hate saline.
You know why? Because too much LR is not good for you either.
Yeah.
Well, a lot of
my
it.
buddy here,
Agreed.
Yeah.
we're going to be against you now. I'm sorry. I'm not against the leader now.
You're going to be against me?
Yes, because forget the leader situation. Too much, I don't like the LR. Too much LR is uncontrolled.
Well, I don't like ractated lingers either, but I mean,
Because I'll tell you, John, one
yeah.
thing I don't like for sure is giving HCl.
Yeah.
HCl is not, there's no good thing about giving HCl.
That sounds a little dangerous.
I hear.
Yeah, it is.
A little risky.
And now you can, if you give it fast enough, you can go demyelination and all kind of brain issues. And it's just like the opposite of the other situation.
Yes.
And you don't want that.
Yes. Yeah, that's right. A rapid, well, that's like sodium too. You get that demyelination from a rapid correction of hyponatremia.
And I don't have much brain left to demyelinate that quickly.
I understand. Okay, fair enough.
Yeah, so HCl, really, I'm not a big fan of HCl. And it actually gives bad phlebitis. I mean, you have to have a central line. It's like a whole other drama.
Yeah.
You know, so-
You're better off just. I
Yeah.
mean, just put them a Herker catheter in, and just put them on CRRT, and just use them. You know, if you
But-
really wanted to. If
but
you
you
didn't
know
want to
something,
just
Jim?
give. If you had a fluid management issue, so you didn't want to give saline to dilute it or something else to correct it, you could just give just put them on CRRT.
But Joe, you have to remember, I cover hospitals that they have to call a special person to come in at night to do CRT. So the easiest thing for me is to drop.
How does that
into,
make sense? Are you kidding me? How
No,
does
I-
that make sense?
Sir, the world is very.
The nurse at the bedside should be able to
not
set
every,
that up so quickly.
Not every nurse.
I've been to a place where they
Yes.
don't even.
Thank you, John.
They're so painful for them to call in somebody from the outside to do that they set up a hemoconcentrator and they do poor man's CRT.
pitiful.
Yep.
All
the time.
I tell you what I do.
We're spoiled.
Yes.
Well, no, we encounter that at a couple of hospitals too. I'm not going to say any names. But
First of all, it takes the company
CRT.
day or two to respond.
Yeah.
They come. The equipment is expensive. The people, I don't know. It's
You have to get a renal consult for them to come
Yep.
in. And I'll tell you, so for me, I would see the patient respiratory status. I either intubate them prophylactically, a couple of liters of ANS, and give Diamox around the clock, and then like a full 2-day doses, then I'm good, safe. In 2 days, I'm good. Like I know that's gonna be okay.
Well, I'm going to go out on a limb here and be.
You're on your
something
own
that
now,
I'm
for
not
sure.
I'm not normally provocative, but I'm going to be provocative.
Really?
Right now.
you're not
Yeah.
normally.
I'm not going to be. I normally am not provocative. Can we close that door so we keep the heat in out? Yeah, thanks. Thank you. Why is it necessary to have a renal consult to order and utilize CVVH, which is a form, I understand, of CRRT, for patients? Why? Is it just because the word renal is in CRRT? Because to me, I love nephrologists. I get along very well with most nephrologists. I think some nephrologists are great. But I don't believe you need a nephrologist to order and run a patient on CRRT if it's not being used for primary acute kidney injury or acute renal failure.
I will answer that for you. That in any cardiac surgery OR, that sounds very logical. But for you to do a liver transplant and need CRT, you need to have a renal person covering that. Because the problem is, there's nobody like me or like you that's gonna handling that situation. So you will understand the pump, you understand electrolytes. They need somebody responsible to be handling that situation for the hospital itself.
That
And
should be the intensivist.
The hospital will gonna want a renal person that's gonna handle that and part of their privilege coverage. The intensivist does not have CRT privileges. They can put a line in and they will manage, but it's all about privileges. And I know it sounds a little weird, but you have to have privileges for it.
It's counterintuitive.
I understand. But,
Because that's what we do all day in the operating room.
Yeah, an intensivist who can ask to initiate CRT. And for you, in the operating room, there's no hesitation because you're
In the ICU, we do it all the time. Our department teaches the nurses, and now the nurses, they just do it, they teach themselves now. But in the early days, we taught them how to do CRRT. That what do you do when you're handling a patient in the ICU? You're administering fluids, you're maintaining you're making the decision whether the patient needs a run of potassium or not. You're deciding whether they need some bicarb or not. You're deciding whether or not they need a fluid challenge. You're deciding whether they need a diuretic. So again, I'm not trying to stir the pot here, but why do you need a nephrology
Because
consult
some hospitals
just
wanna
to hook
cur-
somebody up to a fluid management system, which is what it is, simply because it has this term CRRT, continuous renal replacement therapy. That's what's killed the whole practice.
Curb the usage, and by making sure that the renal person thinks that it's needed. There's resources, mobilization, and there is also budget issues. You know that. So getting those resources, I mean, getting a renal person in the middle of the night. So whatever John and I are talking about, it's not easy and it's expensive.
Exactly,
So-
but that's to the detriment of the patient and to the detriment of getting the patient out of the hospital faster, which would be ordinarily then a less expensive model for the hospital. So why do we continue to allow for a system that's dysfunctional to pervade? Not that I want to be provocative, it's just a question.
Okay, can I ask you one question since I'm going to get more controversial? I can do that. How many hospitals do you work in that can get a stat echo in the middle of the night? Echo done and read.
Oh, echo done in red?
And
Okay.
now here, I have here my buddies now ganging up now.
Yeah.
All right, all right. Ro,
What's
how
that?
many?
Ooh, not a lot.
And
Not a lot. You have to call that specialist.
And that I think an
Yeah,
echo for our business is a standard.
Oh, it is standard.
Yeah.
So, especially in Impella.
Yeah.
Like, you know your Impella's out and you got to call that echo, and it's, almost an act of God. It has to be done, but, that could be 2-3 hours.
See, and that's what I remember, and Vicky remembers this. I was in Mexico. We were down in Querétaro, Mexico. Heart surgeon down there, Dr. Angel Gamboa. And what a great guy, super guy. And we had this patient, we were doing some work down there. I won't describe the work, but we were down there. And we had a patient we needed to get an echo on. And he left the room and he came back pushing this cart with the echo on it, and he started turning everything on. And I said, you know how to run this thing? And he said to me in Spanish, Joe, I am a cardiac surgeon. I can do everything. There you go.
There it is.
So,
There it
Dr.
is.
Gamboa, shout out to you out there if you're watching. I think your wife is watching. I saw his wife was on. So it's good to see all of you. Anyway, Metacruz. Yeah, hey. Okay, good discussion, good talk. Not sure where it got us, but good talk.
I think take-home message is when you get alkalotic, we can become hypoxic.
You have a phone call?
And I don't think that most perfusionists have ever actually considered that you get hypoxic as you get further and further more alkalotic. That's not necessarily the case with acidosis, right?
You need to fix. I mean, you really need to fix that. The fix is easy if you fix it early.
It's early.
You have to fix it. Yeah, you have to fix it. Yeah, I mean, and don't hesitate fixing it. So, I mean, you're gonna give a patient additional volume. It's okay. You know what I'm saying?
Right. Yeah, it seems to be linked to the original slide. I was low volume, low potassium, and low chloride, which are almost always fixed in hand anyway when you give the.
Here's a question from Facebook. How do you handle dysoxia issues?
In which context?
I'm assuming in this issue of what we're
Well,
talking about.
well, that's what I was just saying. The reason why I did this talk and the reason why it became important, when we talk about acidosis all the time, we treat it, but that's not causing hypoxia. Alkalosis causes hypoxia.
Right.
And we should care about that. And at some point,
tissue hypoxia.
Right.
Tissue hypoxia.
So you might
everything looks good.
Right.
for the
Everything's
blood
going to look
gas.
great. Your SVO2 is probably going to look wonderful because you're not releasing the hemoglobin as well.
But then won't you eventually then develop more hydrogen ions and become
Well,
more?
if you have tissue hypoxia, you can have high lactidemia. Then you go to the, So I think I tell you, you do not hesitate. If you're in the OR, I mean, just give volume.
Yeah.
If you're outside the OR, secure the airway and give volume if you're concerned about respiratory status.
Mm-hmm.
A lot of people are worried, they're gonna flood their lungs. It's okay to flood your lung. We can intubate you.
Mm-hmm.
Don't hesitate.
Treat it.
Yeah, treat it.
So you don't end up with
Exactly.
with some end organ system which ends up with a relative hypoxemia that causes a dysfunction later.
And don't hesitate to start Avida-Mox. Avida-Mox does work. It's very, very cheap and it does work.
Okay. Fair enough. Okay, very good. Excellent. That was just, I wasn't sure how this was going to go, but it went really well.
Well, let me ask you this.
I think it's an ignored topic, so I appreciate you, John, a lot.
Real quick, let me ask you this. So if you have, let's say we're on perfusion, and you have good oxygenation, and your SVO2s are great, let's say better than normal, which if you're running an alkalosis. I see this the other day. Base excess was 8 to 10 the whole time on pump, and I looked at the perfusion and said, Why is a person alkalotic? I don't know. That's just the way it is. That's how he came in. Well, now we find out the person could be hypoxic. How do you know they're hypoxic? How would you know that? If you don't run lactates, but a lot of people don't. A lot of people do, but a lot of people don't run lactates. You should because the iStack cartridge has one.
Yeah.
But if you have,
or you could just wait until your pH starts to normalize because of the relative acidemia secondary to the hypoperfusion.
Sometimes it persists though. If you have persistent, so if you have good oxygenation and a better than normal SVO2, and your lactates are rising, you're not releasing the oxygen because of your alkalosis.
That's true.
In the setting of a metabolic alkalosis.
That's true.
So that's something we can take home as perfusionists.
But I also think
I think lactate should be measured really. I mean,
yeah.
If I want to say routinely, a lot of people attack.
Yeah.
Lactates are really a good measure of what's happening, and it will tell you if you're doing the right thing or not. I mean, it's a simple number that will tell you if you're
tells you a lot.
Yeah, if you're going the right way or not. I mean, right now the government mandates if you come to the ER and your lactate is high to be treated aggressively for sepsis. And I'm not saying about septic, but it tells you about tissue hypoxia.
Right,
absolutely.
So if your lactate is high, there's a problem. I mean, and the government did not go that far, except because the lactate, I mean, measuring lactate trends are very important.
I think
it's all about the trend. It's not just
and
absolute number.
It's so unappreciated. And how many times do I'm on the phone with you guys about something. You guys are doing an ECMO. What's the first thing I always ask? I ask it all, what's the lactate?
What's a lactate?
Has anybody run a lactate? And so many times nobody has yet.
Right.
And it's just amazing to me because it is very, very important. Because next, I think in October, one of my talks is going to be on incident dark field imaging and looking at the microcirculation in the sublingual area, which is a great opportunity to see it, and I'll talk more about that. But with these septic patients, but also septic-like syndromes that you see from inflammatory responses, you have this hyperdynamic macrovascular system, but the microvascular perfusion is horrible. And you see this, like he said, lactated. You have to treat that urgently,
Absolutely.
or you end up with a patient who just isn't going to make it.
Let me tell you, I had the fortunate luck to be a physician in one of the marathons, and we had we signed the runners before the marathon. We got a release that we can measure lactates on the Medant. And you'd be amazed at those high lactates. These are healthy guys.
Yeah.
Healthy as can be. You're amazed at this high lactates.
Really?
Some of them had to transfer to the hospital and
Yeah.
hydrate.
Yeah, because they'll go into ARDS.
Exactly. And I'll tell you, you would be amazed at those high lactates, how high they can get. These are healthy people. Okay?
Yeah, you taught me that.
So I'll tell you, I think lactate's an important measure. And you just measure that trend. It's a cheap test.
Yes, absolutely, totally agree. Okay, let's go to my talk, and this is another topic that is very near and dear to my heart, and it is. It was going to be a review on the one regarding left main disease, but I decided that I was going to do this different article, so because I think it's just a little more comprehensive, frankly. And you have the clicker? Thanks. Merci beaucoup. Sure. Okay, so long-term outcomes after off-pump versus on-pump coronary artery bypass surgery, grafting by experienced surgeons. That's okay. Thank you. Our vast studio audience had their sound up on their recording device. You can watch it live. You don't even need to see it. But thank you. Yeah, I appreciate it.
I'm trying to send the link out.
Oh, thank you. So this is out of the Journal of the American College of Cardiology in 2018. So it's actually less than a year old. So let's go to the abstract first. So the background, long-term benefits of off-pump versus on-pump coronary artery bypass grafting are controversial, to say the least. And I'm not going to go over this entire abstract. I'm only going to get to the objectives. The authors sought to compare long-term survival and morbidity after on-pump versus off-pump CABG. So let's look at the study design. It's a retrospective cohort analysis. CABG patients on or off pump between January 1st, 2005 to December 31st, 2011. So roughly 6 years, or 6 full years. So the registries that they used actually are from New Jersey, and New Jersey has a mandatory registry of cardiac surgery that started in 1994. This is very important because I think it's much more, because the STS is voluntary.
New York and New Jersey, they have mandatory registries.
New Jersey is mandatory,
Both
okay,
have
very
mandatory
important.
registers.
It's maintained by the New Jersey Department of Health, and the registry collates data collected by trained clinical staff at each participating hospital, conducts data audits quarterly, and employs external medical auditors to verify data annually. All licensed state hospitals are required, this is very important, required to submit data on each cardiac surgery patient without exception. And therefore, this clinical registry captures all CABG surgeries occurring in the state. Again, I have to say, the STS, although they have a great database, it's voluntary. Not every hospital is part of the STS database. The study population is isolated CABGs, no redos, exclusion, in fact, redo, any hemodynamic instability, need for inotropes preoperatively, or emergency status. So those are all excluded from the pool. The only thing that's in there is elective, isolated coronary artery bypass, first operation, no redos. So the surgeon criteria was designed to reduce the effect of differential expertise bias that you see in expertise-based randomized controlled trials. The surgeons must have performed at least 100 cases of the relevant procedure on pump or off pump CABG. 49 of the 83 off pump surgeons were selected, and of those, the median number of CABGs those surgeons completed was 905, so that's a fairly experienced surgeon. And at least 79, or I'm sorry, a median, not at least, 79 median within the last 365 days of the study period. For the on-pump, 71 of the 86 were selected with a median number of 935 CABGs, and within the last 365 days, the median was 137. Study endpoints were the primary endpoint was all-cause mortality. The secondary endpoints were stroke, MI, repeat revascularization, and new renal failure requiring dialysis. The same criteria we see on every study. These are the things that are important to us. Did the patient live or die? Did they have a stroke? Did they have an MI? Did they need re-intervention? And did they have renal failure requiring dialysis? Of course, the STS, their definition of acute renal failure, I think is extremely tight. You know, to say that a 0.5 jump in your creatinine level, I think that's what it is defined as renal failure. I think it's a bit much. But, you know, they're pretty tight on it as far as I know. So I think it gives a skewed number of actual renal failure. You don't need dialysis or you don't need some kind of intervention and it corrects itself. I could see calling it AKI. I have a hard time with it being called acute renal failure or new renal failure. So we can look at the demographics here. This is all of the case matching. We don't have to go over it. It's a very busy slide. I just wanted to show it to you, but they looked at socioeconomic and sociodemographic factors, comorbidities, functional and New York Heart Association class, if they had had a previous stroke, if they had renal disease, diabetes, smoking history. They basically matched all these patients up, and you can review that at another time when you'd like to. Here's the meat of the matter, however. Long-term outcomes following off-pump or on-pump surgery. Mortality, and this is with a 95% confidence interval, 10-year cumulative event rate. Mortality, off-pump 33.4%, on pump 29.6, with an adjusted hazard ratio, again with a 95% confidence interval of 1.11, with the range being 1.04 to 1.18. MI, basically no difference, no discernible difference. Stroke, no discernible difference. Repeat revascularization, 15.4 to 14. That is a discernible difference. And that repeat revascularization was directly contributable to the increased mortality. Here's the graphs. You see ABCD, myocardial infarction, stroke, repeat revascularization, new renal failure requiring dialysis. I would focus my attention, obviously, on the lower left C, and you see the divergence of the various lines favoring off-pump versus on-pump. Long-term mortality following off-pump or on-pump CABG displayed are unadjusted cumulative mortality rates among off-pump cumulative mortality rates among the off-pump solid blue line and on-pump dashed orange line cohorts, as well as 95% CI. For the confidence interval for cumulative mortality, the shaded area, is calculated by these various Kaplan-Meier analyses. The point here is you can see clearly, focusing in on the years, that for the first 6 months, probably pretty close. Even 1 year still favors on pump. But at year 8, 9, and 10, there's a significant increase in survival when these procedures are done on pump versus off pump. And a lot of the reason for this has to do with the quality of anastomosis and its ability to stay patent. Incomplete revascularization was a huge problem, and those things contributed, in other words, the need for reintervention because of either incomplete revascularization or the grafts going down, were significant contributors to patients' mortality increase in the off-pump group versus the on-pump group. So some key points. Risk of late mortality was higher in the OPCAB group. We saw that. OPCAB had a higher risk for repeat revascularizations, either reoperation surgically or PCI. OPCAB had a higher risk of incomplete revascularization, which was an independent predictor of late mortality. No significant differences were seen between the two groups for stroke, new renal failure, or MI. Survival effect with off-pump was consistent, or actually survival lack of good effect, it's a mortality effect, if you will, was consistent irrespective of as treated or intention to treat across all surgeons regardless of experience or preference. And what that means is, was the patient treated on pump or off pump, or intended to be treated on pump or off pump and then converted from off pump to on pump? And it was consistent across all patient groups, including elderly and patients with low EF, because I hear this all the time. Surgeons say, oh, the patient's got a real low EF, and I just don't think it's a good idea we put this patient on pump. That's the patients you should put on pump, so that you don't beat the heart by obstructing it, obstructing flow, doing all these manipulations with it while you're trying to do the anastomosis. You don't have to clamp it and plege it, but go on pump, support the circulatory system, let the heart relax, be beating and empty, and then you can manipulate it all you want and do really good grafts. Beating heart, on pump beating heart, I think is a great alternative to off pump. I just simply do not think off pump CABG surgery is a good idea, period. And that is not just because of my bias of being a perfusionist. I really simply do not believe in it. I think it is a bad idea, and I've seen it too many times. So there's been 3 large multi-center randomized controlled trials, the coronary, the Roby, and the CABG. The survival advantage consistently associated with on-pump over off-pump CABG has been attributed to the higher rates of incomplete revascularization. Again, it's consistent with these other studies. And worse graft patency with off-pump compared with on-pump CABG observed in randomized trials and other retrospective studies. Thoughts and questions? It's not a provocative talk, so don't say it is.
It is a provocative talk.
It's not provocative.
All I'm going to answer these, and I'm going to take the pen on my side. Look at the exclusion criteria from the study. I mean, look what they excluded. Reduce the multi-vessel. One just exclude the whole patients.
Well, the whole point is, the point is that you want to compare on-pump to off-pump, and when you don't exclude those cases, then the argument is, well, you didn't adjust for these other comorbidities. Let's take just virgin, first-time coronary bypass surgeries and compare those. So, I mean, are you telling me you're an advocate for? Don't make me decide that I can't like you anymore. Ben, what is going on with this is your stepdad. I'm your dad. I'm adopted dad. This is your stepdad.
What I'm telling you is, I'd rather do an off pump on a one vessel redo than a one pump fresh virgin chest. If you're like your patient is sick on a balloon pump, I'm okay with doing balloon pump gives you support. So with mechanical support, and I like what you said, beating heart, pump case, much better than just a pump beating the heart, giving 20 syringes of norepi. I know how we sustain this patient's pressure.
I've seen it.
Yeah.
You can create, anesthesia has the unique skill to create an acceptable blood pressure when there is absolutely no perfusion.
And that's the problem, is people lose the differentiation between blood pressure and perfusion. And so I'm okay doing a one vessel on a 90-year-old guy with a balloon pump. I'm okay doing that, one vessel. But doing a single vessel on a 45-year-old who has long to live and a healthy heart, take your time. Do a one vessel, do it the right way.
Put them on pump.
Put them on pump.
Now, in that case, without any kind of aortic disease, you probably even want to clamp and stop that heart, because I think, and I wish I had the video. I got my computer stolen. I wish I had this video, but you remember? Where's Vicky? She left. I used to have a video, and it was the same surgeon, the same assistant team. Everybody was the same at the field, even the same perfusionist. Everything was the same, but 2 different patients. But the coronaries were the same size. They were basically matched patients. They were just different. And I filmed him doing a Lima to the LAD off pump and on pump on the 2 different cases, and put the videos side by side. He stopped doing off pump CABG surgery after he saw what it really looked like. And the camera was zoomed right in on it.
You have a moving target.
I highly recommend everybody do that, because there's no way you're going to convince me doing a right while the blood pressure's tanked, your cerebral oximetry numbers, even though I think that's voodoo too, are in the tank, and nothing looks good, and the patient is just suffering, and you're going to sit there and try to fight getting this PDA done. I'm sorry, that anybody thinks that graft has the same opportunity to be patent in 10 years as does a still quiet, dry field that you can hold over and take your time and do that in osmosis. You're not going to convince me otherwise.
I agree with you 100%. And it's the same thing like minimally invasive or maximally invasive. You know what I used to say when I want to go to the pool? Let's show everybody my scar.
Yes.
I want maximally invasive. I want everybody to be proud of my scar. I want to take your time, have maximum exposure, do my coronaries, right?
Mm-hmm.
And it's okay, you know what I'm saying? If I have a little pump head outside like that, it's okay. I'm a pump head already.
I have pump head and never been on pump.
See? And what's a little pump head that makes you take things lighter?
Yes.
You take things in perspective.
Well, what people
Yeah.
think is that you're smart. When you
Exactly.
can't get your words out, they just think you're. It's like, have you ever noticed that these people who are in Hollywood, they started off basically talking normal, like we do, basically normal, and then they become superstars, and now all of a sudden, they're like contemplating every last word, and they talk like they're Stephen Hawking's. It's like, look, you haven't changed, okay? Your brain does not get bigger the more Emmys you win. It doesn't work that way, So, thoughts on my talk?
Well, again, I'm.
You have a call? Check my phone.
Can you go back to a couple slides where you showed the
graphs?
Yeah.
Yes, and so yes, Nirman Chatterjee. How can lactate be unappreciated? Mainstay for microcirculation. I totally agree, but I think that we have become macrovascular thinkers. We're not thinking at the microvascular level as perfusionists. Our flow is good, the pressure is good, everything looks good. My gases look fine for the short time, but the microcirculatory flow is terrible, but I might not see that until after this case is over, and then it's not my problem. Out by noon with no balloon, that's why.
Out by noon, I like the case.
Out by noon with no
You
balloon.
have to have a sticker. Out by noon with no balloon.
Joe, he makes a good point, and I don't know his first name. What was his first name? But he, when they do surveys, only about 20 to 25% of perfusionists, Nirman, 20 to 25% of perfusionists are doing lactates on pump, and I would tell you that I've done years of it without, and I've done years of it with doing lactates. You will become a better perfusionist if you simply order the right iStack cartridge that has the lactate on it. It's the same amount of work, and you get your lactates every 20 or 30 minutes. You'll become a better perfusionist. You'll learn some things about what's going on. And as far as microvascular perfusion, if all you're thinking about is macrovascular perfusion, you're stuck in the 70s, because you should be thinking about microvascular perfusion way long ago.
Do you not think that is a common phenomenon with a lot of our colleagues today?
Oh yeah, absolutely.
Or am I? You think I'm just being overly harsh?
No, you are not.
What do you think?
You're right. You're absolutely right.
Mm-hmm. The thing is, on pump, and this is what I will caution everybody about, and this includes in the ICU when the patient's on CRRT, is masking. You can have a rising lactate, but based on your fluid administration at that time that you draw it, will have a profound effect on masking a potential problem because you're diluting it out. There's in the ICU, a decreasing creatinine is actually an indicator of renal failure, because what you're doing is you're flooding the patient and it dilutes it. So CRRT will clear it. Ultrafiltration will clear small molecules, and lactate is very small. So if you're doing any kind of zero balance ultrafiltration, you will clear the lactate and you think all is good, but it isn't.
But you see the lactate, you look at the trend. Single number in lactate is not good. You have to look at the trend. And you actually, there's some equipment, not sophisticated, very easy programs that map it out for you. And you'll be amazed with the trend.
Yeah. That's right.
Very important. I think it's the window into the microvascular perfusion, and what's important is that's what we really need to be looking at.
And I can tell you too that people who use a fair amount of neosynephrine on pump, whether it's a drip or boluses or sometimes both, if you run your lactates, you will see that as you use past a certain threshold of neo, and as you get past it, your lactates will begin to climb. And nothing else changes on perfusion, except you'll notice that as you give excessive amounts of neo, your lactates will also climb, which is telling you something. So I was saying before, if you want to become a better perfusionist, run your lactates with every blood gas.
I agree.
Joe, can you go back a couple slides to the...
Yeah.
Because I wanted
Can you go back a couple of slides?
It showed your graphics, and I was not sure what the...
And Nirman says that he's a consultant intensivist. Dealing with ECMO and lactate helps him tremendously. I think every patient on ECMO should have lactates done at least Q6. Maybe you could do, if it's stable, Q12, If you have an issue of any sort, Q6.
Just add it to your labs. It's not that expensive
Yeah,
test.
it's true.
Add
too.
it to your labs.
I agree.
So you're saying that 15 point, maybe it's the one before, but repeat revascularization, off pump 15.4, on pump 14. Maybe it's the one before this.
Go before that?
I don't know. But
Oh, here.
What
I've
were
got
the
the
units?
clicker.
What were the
Hold
units
on.
of measure?
You mean here?
That percentage? What is that? Yeah. Repeat revascularization 15.4 and 14. What is the unit?
Yeah, it's a percentage.
So 15.4% of off pump patients had to be revascularized.
Right. See, 10-year cumulative event rate percent.
And only
Right.
14% on pump.
Right.
Okay.
So your need for some type of reintervention, if you had it done off pump, was 15.4%. If you had it done on pump, was 14%. And that reintervention was mostly, if you look at the next line down, PCI, which was 14.7. In fact, it was all of it, to 13.3. CABG was 0.9 on both arms. So you actually had operation for your to redo the graft. Most of them were handled in the cath lab, and probably what they did is what you see a lot of now, which doesn't make sense to me, but they do these hybrid procedures. They'll do the LAD off pump single vessel mammary, and then they'll go to the cath lab and they'll do the stent of the right and maybe the circ or the OM or something like that they can get to, or diagonal possibly. I don't know how that makes sense, because then you look at the data and PCI
Is inferior to.
is much inferior. And your 5-year need for reintervention with PCI is incredibly higher than that for coronary bypass on pump. And I think that's a delineation I think that is, look, off pump CABG got up to 23%. It's maybe down to, it's under 10. It's down to maybe 7, 8% now. There's a few holdouts that are still doing them. I know you know one of them. And every off-pump surgeon believes wholeheartedly in their heart of hearts, deep in their soul, that they do it just as well as anybody else that does it on pump. And, again, I'm not trying to be overly provocative, but I would be happy to have any discussion with them. I'd be happy to film their procedures. I'd be happy to look at the data with them. And there's just such a cornucopia, if you will, of data that just starkly says otherwise. And that's my concern. Why are we still doing this? Should have been one of the controversies.
One thing I've always wondered is when let's say you're off pump, and you're doing an LAD distal graft, what is the ischemic time and what is the ischemic effect post where you're working? Because a lot of people have a probe occluding the flow, right?
Mm-hmm. Well, sometimes they put shunts in.
You can put shunts in, yeah.
Yeah, sometimes they put shunts in. Of course, if you got,
Yeah, there's. I'll tell you, interesting. This is not off pump necessarily, but I worked with a guy, elderly, very experienced surgeon, and what he would do is go on pump with beating heart and use the off pump retractors.
Yeah, that's what I said.
And do what he could do.
Yeah.
No, I heard, but I thought you meant totally off pump and then go on pump later.
No, go
he would be on pump. Yeah.
And do it with the stabilizers.
Then the difficult
so you're
vessels,
doing on pump
he would
beating
go
heart.
ahead and cross clamp and plege and do the difficult vessels as a regular cross clamp. So what he could get away with beating heart, he would do all the same procedure, and then he would, like back of the heart and things, he would call up and plege. So your cardioplegia time was much less.
Give Del Nito.
So
you don't need to worry about it anymore.
But the thing about that is you're spending a lot of money because the expense for the retractor of the off pump.
Oh, and I know. Well, you know what?
And you're still on pump.
It costs more than more than the pump.
Yeah.
Yes. the off pump retractors cost more than the pump the oxygenators.
Oh, I think they're a lot more.
You know what I
many
like to
times
teach
more.
the residents sometimes? Once you put the heart down after it has been up and pressure is 0, get an ABG right away.
Yeah.
See how bad it is. That teaches you how acidotic you are, how you're not perfusing.
Yes.
And the magnitude of drama. Then get an ABG right away so you can see that I'm not making this stuff up. It's real.
Yeah,
Absolutely.
yeah.
But to your point, John, wouldn't it be great if you could do it? You know, if it was, I mean, I'm sure somebody has done it probably, but stick a catheter, stick a retrograde into the coronary sinus, and while they're doing that off pump, draw serial coronary sinus gases and see what it is.
Well, that's what I was saying. Shunt or no shunt or whatever, you have to think that if it's 12 or so minute distal, that the area there working is
absolutely
probably hypoperfused, if not, But
not to mention, I'm telling you, I've just, you got to look at the video. You got to really watch somebody doing an off pump.
What was the key difference? I'm curious. I didn't.
Everything, precision. You know, the
location of the stitches,
the depth of the bites, the spacing, you know, I saw him go in and then out, in and then out, in and then out, and then finally get it. I'm like, what the heck are you doing? I mean, you're chewing that poor vessel up.
Was that because of the movement, or because of the flow? There's always
movement, blood. They're blowing with the blower,
and it's distorting.
And actually, it was at your place. I think it was Dr. Garami who they were doing an off pump CABG, and with your off pump surgeon, who I like personally, he's a true gentleman, but I disagree with his philosophy on surgery. I wouldn't go to him and have it done off pump. I don't care how good he thinks he is or how many he does. I'd go someplace else. I'm getting put on pump. That's it. But
as controversial as you want
they
right
were,
now, you're really controversial.
I'll go right out there. I'm going out there. So he would use he was using the CO2 blower to clear the field, and the the transcranial Doppler was going off like crazy. And they finally realized, well, move that thing. They moved it. It went away. Put it back. Put it back. More bubbles go into the brain, CO2 bubbles. So, you know, these things are just not without consequence. And you don't even think about that. But it can do that. You can shoot it right up the coronary, out into the aorta. The heart's beating, goes straight to the brain. That's problematic, even if it is CO2. Okay, I think we're ready for one more break before we come back. We have 15 minutes, and then we're going to be going to Dr. Samir on when to call for ECMO. Then we're going to have Christine. How do you pronounce that name? Perme is going to be talking about ambulating the ECMO patient. And then Dr. Samir is going to finish us up with when not to call for ECMO. To me, that's going to be the best talk, because there are times we just shouldn't be calling for ECMO. Okay, 15 minutes, everybody, and be right back. We're going to start right on time.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat, because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive 2-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
We'll be back in 2.5 minutes. Everybody, Welcome back, everybody. So we're going to jump right in to our next session. Now, Dr. Samir had told me this earlier, and of course I messed it up. But he's going to give both parts of his talk at one time, right? So you're going to do
absolutely
when to call for ECMO and then when not to call for ECMO, followed by Ms. Perme talking about ambulating the ECMO patient. And I think that's going to be another controversial topic because there's a lot of people who think, Christine, that you can take a patient who comes in with sepsis and they're sick as hell. They have severe ARDS, all kinds of other issues. They're just really bad. And you somehow put them on ECMO, and in a few days you're walking them around.
Correct.
No, you're not doing that. Not going to happen. And I think there's this idea people have, and they're not thinking this is more for transplant. But I'm looking forward to hearing your talk because I think this is going to be
give
both
them an open
very...
chest and make Chris walk. What's wrong with that?
I don't know what's wrong with it.
There's nothing wrong with that.
Nothing.
No.
You should leave it open.
Leave it open with the zipper and let Chris walk them.
Exactly. Okay. Dr. Samir.
Okay, we're going to talk about patient selection today. And this is quite a controversial subject, and I know there's going to be a lot of attacks on my right and my left, but I can handle it. Bring it on. And maybe you guys can agree or disagree, and please stop me and tell me. I have no financial, I wish I had financial relationships. My life would be great. And so it's not enough to do your best, but you have to know what you're doing. So you can do, I hate to say this, I was telling my wife I was driving here, there is an enormous amount of lack of thinking in the world. And I didn't use the lack of thinking, I always use some other word, I don't want to use it now. Different kinds of ECMO that we all know about, and venovenous, why we're doing it. Here's what an ECMO situation looks like. I wish we could show this picture to families, so understand what the end result are going to be. This is a typical situation, not an exaggerated situation. And the different configurations, VA. One statement I'm going to make right now, controversial from this picture right here. And I know I'm going to hit from both sides. You decide to put the patient on ECMO. You want to do VV or VA, Joe?
Well, it depends on the problem.
Okay, well, I'm sorry to tell you, Joe, I disagree already. You put somebody on ECMO, put them on VA, you have to go max, and then you can de-escalate as needed.
What?
Do not do a journal crop, Joe. No time for a journal crop.
No, you're not serious. You're not
I'm that serious.
You're not saying to take a patient who has normal cardiac function.
Hypoxia kills your cardiac function.
Well, it'll eventually affect the
hypoxia kills your cardiac function, Joe. I'm telling you, Joe, you're assuming everybody is dose perfusion like you. That's not true. Put somebody on maximum therapy, and you can de-escalate if needed. Save the patient's life and then de-escalate.
Okay.
Don't go step up. Getting the OR to put VV and then switch to VA. You know what that leads to. I'm very that serious. In an emergency, and that's my cardiac surgeons who will be watching this because I'm going to send the link. Some suggest you agree. I have gangsters behind me. Some serious gangsters behind me.
I can't. I don't know, Doc. I'm going to let you keep going, but I can't say that I agree with this, and I'll tell you why very quickly. I don't want to belabor the point too long, but had a patient. In fact, Patrick's case. It was Patrick and Nate, and she was a 7-month pregnant female who developed severe ARDS. She was grossly hypoxic. She was having cardiac failure, LV failure, secondary to the hypoxemia. And if you look at the various algorithms, the surgeon made the decision, because he was varying back and forth what he was going to do. He said, we're going to do the section, get the baby out. I'm cannulating at the same time, and immediately put the patient on VV ECMO. And as soon as they got the patient on VV ECMO, baby out, actually she had severe preeclampsia, right? But she went into ARDS, pulmonary edema, various different things. She had a lot of problems, but they got the baby out, VV ECMO, and as soon as they oxygenated her, Her LV function went back to normal with a 60-70% ejection fraction, completely normal, did just fine. And the right decision in that case was the V, because a lot of times when you do VA, yes, you support the circulatory system, but your risk of differential hypoxemia, if you cannulate fem is so high, that's scary. So I can't agree with you. I'm sorry, I don't agree.
It's okay not to agree, but I'll tell you one thing, doing a journal club in the middle of the night is not a good idea. And how old is this patient again?
She was, well, how old?
27.
27
Thank
years
you.
old.
That's the answer to my question. Thank you so much. Have a great day. But moving along.
Okay, back to the slides.
Okay, back to different ECMO configurations. And here's for Chris to ambulate ECMO patients. The patients that with a respiratory dysfunction, we'll put them on VV, and then Chris can walk them around, and they can get back in condition and get back to their lung transplant status. So what's our agenda today? Look at patient selection and what not to do, who not to touch. And there's a whole list from everywhere. I have a very short list. And what's our exit strategy? And that exit strategy came from one of our political leaders who's alive right now, but is not one of our current political leaders. It was not an ECMO exit strategy, it was a war exit strategy. And what you have to look at your institution before embarking on ECMO. Before anybody thinks of ECMO, what should you think about your hospital and your referring hospital and your relationship with that hospital. Patient selection and contraindication. Patient selection is, you have to realize ECMO is not a simple situation. And what it entails, what's going to happen. You have to look at the ethics of the situation, palliative care. And I'll tell you something, it says ethics and palliative care consultations, that sounds great. I think ethics and palliative care do help a lot. And right now our heart failure program has been mandated to be enrolled in a heart failure program to get an ethics and a palliative care consult. But sometimes I learned some new word which I use all the time. There is no time for a journal club at 12 a.m. These guys are not going to be available. I think the family needs to know what's going to happen once you put the patient on ECMO, and what's going to go from there. At the time of the ECMO is very important, whether it's respiratory or cardiac. Letting the patient struggle on the vent and hypoxic, and the heart struggle, beating the heart with 20 mics of epi, being hydrated with 20 mics of epi, 20 cc's of vaso. The other day I got called about a patient on 100 mics of epi. And I was like looking at, is this IV hydration fluids? And respiratory situation is, what's irreversible? The question is, are you vaping? Is irreversible? Now you have all these young people are vaping. Are you going to put them on ECMO or not? And now you're going to say, oh, they're vaping, they're doing it to themselves. Vaping is going to be like the smoking situation now. And maybe, are they transplant candidates or not? And one thing I'll tell you, I'm going to repeat this over and over. If you are not, don't have an exit strategy, do not go on ECMO, regardless of where you are. Heart, lung, or whatever the situation. If there's no exit strategy, there's no plan, putting somebody on ECMO is not the right thing to do. And this is the short end of it, to be honest with you. If you don't think, not everybody has to die with cannulas, not everybody has to die with a heparin drip running wide open on them. So, and that's what we mean by palliative care. I think you guys disagree or agree with what I'm saying?
I think you're right, but I think because there's no time for the journal club, that sometimes we put them on ECMO and let's see where the ECMO strategy is. You know what I mean? We say, we have to buy time, and then they'll see, let's see if we can find an exit strategy in the next few days if one emerges. Not always does that happen, but certainly that happens to some extent.
I like that. And at that point, I would definitely say you have to get ethics and palliative care, doctor of family, and see what the exit strategy is.
Mm-hmm. So I think we end up talking. I need to use this. I think we end up talking about exit strategies after we're on ECMO. So I'm agreeing with you. Right. We put it in because we're trying to save the patient generally. But within, I would say, 3 to 4 days, all of us, the perfusionist and probably the other doctors involved as well, we know if this is going to work or not. And I bet you we predict 90% correctly. And then there's that 10% where that patient actually really does recover when nobody thinks they're going to. But I think it's in my opinion, I guess, I think we put it on and then we develop an exit strategy. But are you against that idea?
I mean, I'll tell you one thing.
You can leave it on.
One of my surgeons right now says something that's very good. If you evaluate a patient for heart failure, this patient is not going to get a VAD for multiple reasons, and it's going to decline. If this patient comes in the ER today crashing, what are we going to do? We have to let him go. Because we already decided this patient is not a candidate. MRB, he failed MRB already. You see, and that, I think those kind of patients, if you said no from now, don't get emotionally, you know what I'm saying?
Right.
And then say, well, okay, we have to put you on ECMO right now. I mean, and there's a patient, again, I learn from smart people because I'm not that smart. Our lung transplant program director says if you're not compliant by your medication at home, you are pulmonary hypertension. You elect not to take your medication at home. You elect not to be compliant. You elect to get pregnant when you're told not to, and now you came crashing through the double doors. And now, because emotionally you are 20-something, we're going to put you on ECMO. And this, I mean, you already proved to yourself you're going to fail. And are we going to improve your quality of life? That's what I'm saying. Maybe that's a little harsh, but it is. I mean, you have to be honest and realistic about it.
Mm-hmm. And those are hard calls.
Absolutely.
Those are very hard calls to make. But you're absolutely right, because if we don't get a handle on this, and this is what I fear, is that we will spend our way out of a therapy that can actually help people. Mm-hmm. And that's what I'm concerned about.
Absolutely.
I mean, that's a great point, because, you know, there are a lot of patients that, you know, we see in all these satellite supporting hospitals that the surgeons or the, you know, intensivists or the cardiologists or whoever are seeing these patients, they immediately want to put them on ECMO when they know the underlying diseases and conditions and the possible outcome that this ECMO is not going to save them. It's just going to buy them time for the latter.
Mm-hmm. Exactly. Mm-hmm.
And then if you get the amount of occurrences of these patients not doing well, then eventually, you know, like you were saying, Joe, that, you know, that's going to hurt us more than help us, because for the patients that do really need it, you know, we're wasting these resources putting them on.
Absolutely.
Right. And so really ECMO would be for acute injury or acute disease that we think is
that just
recoverable.
Something recoverable.
Yeah.
Or you have an exit. Like I went to a meeting in France, and there was a patient listed on the lung transplant list, but he had antibodies, and they were waiting and waiting and waiting. This guy, and I'll tell you, we think we're crazy. I mean, I was surprised. In France, they put the guy on ECMO, and so he can take his daughter to the wedding, and he went to his daughter's wedding on a portable ECMO and danced with her, a portable ECMO.
Wow.
And about 2 months later, he was able to get his lung. So, I mean, again, that was extreme, but I'll tell you, that there was an exit, so there was a plan. He had high PRAs, and they needed to work towards that.
Right. And you have to, like you said, you have to look at your patient. And is the patient a good candidate? Are they compliant? There's a lot of factors, but I think you can distill this down into essentially three categories. The first is you have a bridge. You put the patient on ECMO. You don't know anything about them. You're going to have a bridge to recovery. You're going to have a bridge to a VAD or some other long-term device, or you're going to have a bridge to decision. And when that decision gets made is where I think we have a very uncomfortable environment of we put this patient on ECMO and it is obvious that they are not survivable. But until they declare themselves, if the family doesn't say we want to withdraw care, if short of that happening, they have to declare themselves. Our job is to inhibit their declaration as long as possible. It's not to facilitate it.
Exactly.
So there's a very big, that I think is the issue. Mm-hmm. The transplants, there's a strategy, there's a plan. The person who comes in who's 35 years old and should be survivable, you're going to throw everything at the kitchen sink. But I've been fooled too. 75-year-old grandmom, I was sure was going to be gone before the turkey came out on Thanksgiving, and she walked out of the hospital.
But if you're 35 years old and you're declined for a transplant because you're not a compliant candidate, you're not taking care of yourself, you're not taking care of meds. I mean, you get my
Right.
point to say
You
you are
have to-
declaring yourself already.
Yes.
Yeah. So I mean, and you're gonna lose that organ. So put your ECMO, you're gonna lose an organ, which is something not right.
And especially since they're in such short supply.
Exactly. Absolutely.
On the transplant patients, yes.
One subject I'm very sensitive about because I've seen a lot of drama with it, anticoagulation. So if you cannot anticoagulate, you cannot go on ECMO, obviously. I mean, that's a big situation.
Mhm.
So really,
I've seen them do it.
Absolutely, and the results have been. We've all seen
Yeah, we all-
holes are leaking. Every stick is leaking blood out, and it becomes a big drama.
And the LV is full of thrombus.
Exactly.
Well, there's a big trend about not anticoagulating. You've seen a lot of movement towards, the VVs are largely not anticoagulated, and now we're seeing VAs not anticoagulated, provided a flow above about 4.5 liters. But
And I agree
I
with
don't
you.
know
and
how I
have a-
feel about a lot of those, but
I have a big lecture on that. I'll tell you. It depends on the flow. It depends on your patient. And people also don't understand one thing, which I don't want to divert on a different subject. If you're weaning off ECMO, you need to anticoagulate higher because people don't understand that. They think, oh, you have to wean everything off. No, you're weaning off means you have to get the blood thin enough so you're not clotting. They don't get it. What can I say, sir?
But what other people don't think about too is that the outside, the exterior surface of the cannula, not just simply the blood path of the ECMO circuit, but the outside of this cannula that's this long, and the other one's maybe a little shorter, but in the arterial circulation it's higher flow, I get that. But on the venous side, the outside's not anticoagulated. It's gonna clot.
Sir, I don't know what to tell you. There's a lot of, issues. Anyway, indications for ECMO and ARDS, and you can look at different indications. For me, I'm not that smart. I'll tell you. You have ARDS. You are a candidate for a lung transplant, and and there's a cause we can identify. We should go for it. And you don't have any contraindications. You should get an ECMO. There's no problem with that. And this one, Joe, VV, I agree with you 100% right there. Okay? As long as there's no cardiac compromise. For pneumonias, obviously, and it depends on the age. Aspirations, patients that go to the OR for unknown reason, they aspirate while being intubated. Alveolar proteinosis is a very bad disease, and you have to get a lung transplant. Okay. Extracorporeal system for thymus obstructing the lung, and now for me, thymus obstructing the lung, you need to have cannulas in the groin before you start to induce the patient. Smoke inhalation, the whole vaping situation we're talking about. Pulmonary contusion, I'm not sure I agree with that much, because when you're going to anticoagulate, you're going to have a problem.
Yeah, if you have massive hemoptysis, you're
Exactly.
in trouble. I mean,
You're
pulmonary hemorrhage is really it's a contraindication.
Absolutely, because unless you're gonna go coil the pulmonary artery, then you really do not. You get what I'm saying?
Yeah.
Our friend would go through a stent in the pulmonary artery.
Yeah.
Or coil it, and then you can forget about the lungs. Now, the one thing I'll tell you, people should not hesitate if you do lung transplants and putting people on ECMO if the lungs are not working pristine. You should not have any hesitation. Nobody dies from a run of ECMO for 24, 48 hours after lung transplants. I think I've seen patients survive so well now after a run of ECMO for 24, 48 hours.
Yeah.
And instead of beating them with the vents.
you want to know something that we do at our hospital? The perfusion bypass machine that the lung transplant patients are put on is a cardio help, routinely. And then if they need ECMO, they just stay on it.
For us, it's surgeon
That's a tremendously expensive cardiopulmonary bypass machine.
Your surgeons complain that they don't have sucker bypass. They don't have suckers.
They use a cell saver. They use a cell saver.
Our surgeons want to use this.
But the lung transplant surgeon puts every person on a cardio help as their cardiopulmonary bypass machine, and probably 10% or so of them end up just staying on it right out of the OR for what he just said.
Yeah.
It's a very expensive,
$13,500.
probably about 50-fold the cost of a regular, but apparently
just for the
But can I tell you, think that that's money well spent because you just got a lung transplant. I'm gonna put you on ECMO for a couple of days, help you survive that situation. I think it's worth spending.
The patients do well when that happens.
They do very well.
Yeah, but you don't have to spend $13,500 for the circuit. They're
No, you
just
don't
choosing
have
to
to.
use a more expensive iteration. I don't have a problem with the ECMO part of it. I have no issue with that. I just don't think it's necessary, you know. And again, we start running into this same issue that we talked about. We're going to spend our way out of, you know, you don't need a $13,500 ECMO circuit for you to exercise your patient. They can push a little if they move things, or somebody else can move the cart for them or whatever, a small cart, little trolley or something like that. It doesn't have to be the iteration that, because I mean that cardio help, I mean you could put it on the IV pole, but they make them already like that, and it's 13 times cheaper.
The best thing is get your patient strong enough to push the ECMO cart himself.
Yes.
You know, so I'll tell you, people should not think, my point is, should not think that the lung transplant has failed if you're coming out of ECMO. You're just helping the lung. You're just buying some time. Tincture of time, we're talking about that.
Yeah, and avoiding whipping it.
Exactly.
And barotraumaing it,
I mean,
and giving it high O2, you know, inspired O2 content, and all the things you're going to talk about.
Now for diaphragmatic area meconium aspiration for little kids, for sure. There's no question about that. And like Joe and I said, massive hemoptysis, forget about it.
We had that happen just the other night. Yeah, it looked like a fountain of sangria. It was bad. It was bad.
Stents asthmaticus, I'm not sure because maybe I'm a little cocky, but I'm sure I can break somebody's stents asthmaticus, put them on anesthesia. Isoflurane, full induction, breaks status. You just have to convince people to take the patient to the OR. And you know, a lot of people don't think the OR is such a taboo. You don't want to go there. You have to intubate, take the patient to the OR, put them on isoflurane, you know.
So we put a number of them on ECMO, actually.
I didn't know you could do that. So isoflurane
breaks
breaks
is a huge bronchodilator. Huge bronchodilator.
Ah, okay. That's
So you put them on isoflurane, they break their asthma, they're very happy. And I'm old, so I still use theophylline.
Okay, yeah, Theophylline. That is old.
Old school.
I didn't even think they made it.
That's wrong.
I have a chat question. How can you justify cost of cardio help for CPB support if ECMO is not needed? Good question. We'll discuss that in the discussion period.
That's you, John.
Yeah.
Dial the administrator and ask them.
Okay, we'll get you the number. Dial the administrator. Go ahead, Doc.
I like that. Now, ECMO for my biggest pet peeve, ECMO for cardiogenic shock. Post-cardiotomy ECMO, how successful is it, Joe?
For post-cardiotomy, it's very well. For post-cardio, you're talking about coming off pump, weaning from bypass. I would probably say the appropriate percentage survival prediction would be 10%.
I mean, I'll tell you, I have biases, and post-cardiotomy, if you cannot go on Impella and survive and come out, the chances of you surviving if we put you on ECMO are next to zero. I mean, for me, the maximum support post-cardiotomy is an Impella support.
I don't know why you love Impella. I do not like Impella.
I know you don't, but that's why I'm pushing the button. I'm pushing the button for a reason.
I think Impella, no, see, you did that on purpose.
I know, I've told you that. Right?
Yeah.
But must be careful. I will be careful what you're going to say. That's because I'm there for you.
No, I'm going to be careful. I mean, certainly. I mean, I'm politically sensitive. I think it has
Really?
I think it's a good device, and I think it has good utility in the proper circumstances, but like many other devices, the company has an interest in selling as many as they can, and they overmarket it, and it's overused. So I think in the appropriate setting, it's a good device, but it has limitations. Placement, insertion first of all.
So which
migration.
Impella we're talking about?
It doesn't matter. It could be
No,
the
it does.
Impella,
That
the
does
CP.
matter for me.
It could be
5.0.
the
If you have
5.0.
the 5.0 put through a graft, you're good. Everything else is moving around. I agree with you. But now I'm going to pick on my other guys because you're a little biased. So do you think do you need an Impella with an ECMO for myocardial drainage? I mean, what do you feel about that?
When we put a patient on ECMO who has does.
Mike.
Oh, yeah.
I'm sorry.
Yeah, just
I
leave
think-
it on.
Yeah, but then
That's what I keep telling you.
I think that when we put somebody on ECMO post cardiotomy because they've got LV failure, then the way we're cannulating and the direction that we're putting more stress on that ventricle because we're flowing retrograde up through the aorta. And so I think Impella helps in that sense because we're going to unload the ventricle, along with giving perfusion to the brain and everything else. And so I think they work well together.
I agree with you 100%. I think people don't underestimate the importance of drainage. The drainage helps with myocardial recovery. When the heart is not distended, it's not swollen like we said before. I mean, it does help myocardial recovery. So it does really, they work. That I agree. They work very well together. So I mean,
I thought you were going to pick on me.
see, well, I let Joe decompensate, and I pushed Joe's button for a reason because I knew that's his button.
Okay.
Okay.
Yeah, it does bother me a little bit because I think that having a patient on VA ECMO, and if you have a concern about LV distension and LV wall tension and decreased coronary perfusion and all the things that are associated with that, then I think having either an Impella 2.5 just to vent the LV isn't a bad idea, but you can mostly accomplish it with a simple left atrial vent. Just do a septostomy. If you have the chest open, you can just put it in the right pulmonary vein. But if you're right superior pulmonary vein, but if you're already in the ICU, you can easily do an atrial septostomy and just drain the LA that way, and usually works pretty well.
I have to tell you, I'm a fan of the ECMO and Impella combo.
And that's not a bad idea. It's not bad. I have no problem with it. I don't. But I think VA ECMO. I think in most circumstances where you have frank LV dysfunction post cardiotomy and they're really needing a lot of inotropic support and pressure support, VA ECMO is superior to Impella, I believe.
Well, if you need a lot of pressure support and you have IV failure, you need ECMO for sure. I do not believe that on the RP. I do not believe in that at all. RP takes so much to put it in, and people lose so much blood. And anyway, with the other items, so let's say you're 25 years old, you did a hit of cocaine, heroin, and now you're in full cardiac arrest. Your respiratory, you're intubated, and you're good. So the airway is secure in the first 2 minutes, but you're in a full cardiac arrest. And you're very young. Are you gonna put down ECMO or no? But you did cocaine, heroin hit.
Right. I would say we would probably put that person on ECMO.
You, should you?
Yeah. Should we?
In your opinion?
I think 25. That's a very philosophical question, almost. Really. I mean,
That's
at
a very
25 years
philosophical
old,
talk.
people make mistakes, and I think that we should try to save them. We had a young man come in who got stabbed in the chest with a very long blade and went all the way through his pulmonary artery and out the back of the pulmonary artery and almost hit his spine. And that happened to him because he was, cheating on his wife, and he told the girlfriend that he was married and she had a knife.
And
so,
the girlfriend didn't know he was married.
Right.
So he's cheating on his wife, but the girlfriend is who he told he was married to that didn't know he was married.
And we know how violent women are.
But I don't want to get, there's lots of details. I'd love to tell you what really happened. But the thing is, we we saved this guy, and he did not end up on ECMO. But we didn't just say,
But
he
this
was
guy,
stupid. We're not going to do anything for him.
Stupidity, you know what I'm saying?
Yeah.
This guy says somebody stabbed him. For PE, for a massive PE, this lecture is turning into something else. Okay, massive PE, I agree 100%. Massive PE, put the patient on ECMO, go to the OR, do a thromboendarterectomy. I think it works very well. We have an amazing surgeon that he does an amazing job with underarteries. Really,
McGilvery?
He's my best friend, so I don't know. Yes,
Yeah, he's a
W.
good
Crook.
guy.
He's an amazing guy. Not
Yeah,
good
he
guy,
is.
amazing guy. Okay, post cardiotomy, we discussed that already. Now heart transplant, and that I'll agree 100%. Because you have to do 2 steps. If the heart is not working, we have a philosophical discussion. Look, go to HEB. Not everybody's heart is going to work when you get a heart transplant. This person gets shot right now, their heart is not going to be the best. But I'll tell you the best thing is that you have to go to put the patient on ECMO and list the 1A status. So the nurse not put the patient on ECMO. Put the patient on ECMO after heart transplant and just forgetting about it, it's not going to recover. List the 1A status. The heart recovers, you're very lucky, then it's good and well enough. You list 1A status, you give the patient another chance. That would be my utility for ECMO in this situation. Okay? So you cannot go back to the shelf and say, let me use BiVAT, let me see what's in the garage. You cannot do that. So, peri-procedure support for high-risk percutaneous cardiac intervention, I agree with that. High-risk PCI with ECMO, what do you think?
High-risk PCI with ECMO, I think it's a great idea.
I think it's an amazing idea.
Yeah, much better. Again, I think it's much easier to do and a lot less cumbersome than Impella. They advocate Impella for those cases, but I'm a big believer in using ECMO for it.
No, I've done that in multiple institutions. High-risk PCIs with ECMO.
Yeah, makes sense.
Absolutely. And then now here's the more indication, contraindications. We discussed disseminate malignancy, that's for sure. Immunosuppression issues. I mean, I'm not sure even what that means. If you have a bleed in your head, I'll tell you, neurosurgeon has been clearing patients right now with bleeds in their head, and I have to tell you, I disagree with that 100%. Because what happens in veterinary, you're going to have to anticoagulate those patients.
Yeah, it doesn't make sense.
Doesn't make sense?
No.
And those patients develop a massive blow up in their head.
Yeah.
And they have to give a craniectomy and really prolonging the pain of the family and the patient. I'm actually more concerned about the pain of the patient. You have a bleed in your head, and now I'm going to put an ECMO and give you more heparin or Angiomax, whatever it is. So I'm surprised neurosurgeons clearing them, but I don't understand it, sir, but I'm not that smart, remember that. So now there's a big movement for lung transplant, and it goes back and forth. Put the patients on ECMO, extubate them, make them walk around, make Chris get them stronger. Chris has to get them stronger and ready for lung transplant. So, what's your guys' thought about that? And now even the cannula has a nice little headband, tennis headband. It's so fancy, so the cannula doesn't fall out. And I'm sure you've seen the cannulas fall out.
No, we have not.
You have not seen the cannula fall out?
I have in all of my years, I have never seen accidental decannulation.
Unfortunately, I have. It looks like a snake.
I have too.
Yeah. Maybe we said the same one. It falls off, and the pump is going, so that thing is spraying all over.
Yeah.
Well,
and you try to get that hose under control.
Okay.
You push the nurse in the room. Go get that hose.
I take that back. Okay, we did have that one case. Who was?
Well,
with
it was me, and it was not ECMO, but it was.
No, it was
on
me.
bypass.
It was at that hospital where that other guy who's no longer here was. Remember, that 22-year-old that we had. That was not the same. We're talking about in the ICU, an unintended decannulation I have never seen.
I mean, with Avalon, that's a long
cannula.
So
No, it was the person, the surgeon who put it in, actually was the one who accidentally pulled it out.
Wow.
Yeah. But that surgeon isn't here anymore. I don't want to say anybody's name.
No. But so are you worried about walking those patients? The cannula is going to fall out.
Well, I would hope that it's well secured. Mm-hmm. I mean, we do, external, the bands and all that, but I would also hope that it's stitched well. And sometimes they reinforce those stitches just for safety.
And I think that's a problem when
we
it's
mobilize
not stitched
everybody.
in.
Yes, then
it can become problematic.
A huge
but,
safety
not
issue.
femoral artery, I don't think. I would see that.
I would love, femoral arteries.
So there's a question for you,
yes,
Dr. Samir.
Yes, sir. A controversial question, I hope.
Brian Crawford says, how do you take exit strategy, in quotes, into account when the receiving facility is 45 to 60 miles away and not on site to evaluate the situation? We have to ship all of their ECMO patients to them because of a lack of their resources. They don't have the resources to keep the patient.
Actually, I was going to come to that slide, but Brian, I'll answer that question right now. You have to prepare from the beginning. You have to have a good relationship with that receiving facility and discuss the criteria together and have a plan together. You cannot just be calling them out of the blue, I put an ECMO right now. These are long-term relationships that have to be established. I have multiple lives. In my other life, I have to call Penn and send them patients from a small hospital. And I know Penn's criteria. And before I decide to do something like that, I will make sure that Penn is going to take that patient, not call them, tell them, you're going to take the patient. Long established relationships and meetings together and CMPIs together and case reviews together. And you have to have a good collaboration with that hospital. It sounds so like warm and fuzzy. It's not really. You have to just see those guys and talk to them all the time and see what their criteria are. So I think you have to know what your receiving facility is going to send when you get to that. And that's a very important thing before you think of putting an ECMO on someone. So more contraindications on ECMO. One thing, I see a contraindication to any, I'll tell you, unwitnessed cardiac arrest. I don't call anybody for unwitnessed cardiac arrest, something like that. Unwitnessed cardiac arrest, we have to accept death sometimes. Like one of my cardiologists, a good friend, he says asystole is a sign of death. We need to accept it sometimes. So now one big subject which a lot of people don't understand, ECMO or Impala or whatever, with aortic regurgitation, that you're just making a nice good circle. Circle is going around and around and around and going back. People don't understand that. AI is a very bad thing, whether you have a balloon pump, whether you have Impala, whether you have ECMO or whatever, you have AI is a really bad thing. A lot of people don't get that, don't know why. Now, another question here. Do you think you should put patient on nitric oxide if you have a patient on ECMO? And I'm not DV, I'm going with AV. You have BIV support now. Do you think you should put a patient on nitric oxide? I'm asking that question.
Yeah, you're asking. I mean, let me think.
Think, boss.
No, I would probably say if they have pulmonary hypertension and you've probably already tried the nitric oxide before you made the decision that failed that already, then in that case I would probably say, you're going to mechanically relieve their RV obstruction. So I'd probably say no.
To be honest with you, for the reason you just said, I feel like I'm going to relieve the RV obstruction by putting on nitric oxide. I'm giving the patient the best chance to come off.
So you would say leave it on?
Leave it on,
okay.
Yeah. Leave it for the best chance to come off. I mean, a lot of people don't want to do that because of the money part, not because of anything else. I think you need to leave it on, for giving them the best chance to come off.
So leaving it on because they were already on it before you put them on ECMO.
No, I want to get the pressure off the right heart as much as I can to help them come off later. Because it's all about I believe in my cardiac conditioning. You get the heart used to get the obstruction in front of it off, and I think you'll be okay. You know what I'm saying? So I would like you to be okay that you have a better chance of coming off, than just staying on ECMO.
Yeah.
So I want to give you the best chance of coming off. So that's for me. I think nitric should be misted in the air. I would love to inhale some nitric in my house.
I agree with that. I mean,
yeah.
Unfortunately, at some of the places we
they don't have nitric oxide. Right.
Available.
So that's right, exactly right. So how do you feel about cooling your VA ECMO? So you have, let's say you have a cardiac event, could be a PE, could be whatever. You have some kind of witness arrest. You've done CPR, so you've got ECPR. Do you automatically go to therapeutic hypothermia protocol and drop their temperature down, 32, 34, whatever it may be, or do you want to keep them normothermic as long as the circulation is being supported?
No, I believe in hypothermia, but not 32, 34.
34, you'd stick with 34?
Moderate hypothermia. Okay, because severe hypothermia, I really worry about bleeding a lot. The metabolic deranges.
Yeah, cold blood don't clot, that's true.
Metabolic deranges are really bad for you when you get that cold. And there hasn't been much benefit shown between 32 and 34. And obviously it has, like you said, witnessed. If it's unwitnessed, no, that you're done. Unwitnessed, you're dead. I'm sorry. I mean, I know it sounds harsh, but it's that. You know what I'm saying? So you really have to think about that. And again, anybody, what's your cutoff for age? You guys have a cutoff for age for ECMO?
We do not, but
No,
I
we
have
do.
seen people in their 80s, recover, right?
No, we have a cutoff. We have a cutoff age.
What's that?
I think it's 75.
Well, we haven't followed that. I know we.
No, but we have it. It
Okay.
is in the. We do have it. There is a protocol, and I do believe it's 75.
And I believe that protocol is there because we do have the same. But to be honest with you, I'm not too much concerned about the cutoff IH, except about your situation.
Yes.
What's happening and what your exit is. If you are 80 and you aspirated in the OR because some guy who's whatever made you aspirate when he's trying to intubate you, and then I'm okay with you going on ECMO for a short period of time to get you over that hypoxemia part. So I'm not beating your lung up with peak airway pressures of 60 and things like that. Or you're gonna give him like a lung lavage to see what's gonna happen.
Yes, yeah.
So I mean, if you have, I don't care how old you are, as long as there's something I know I can get around, we're gonna get done with it.
Right.
Yeah.
Right.
Well, I don't think you can go with an absolute age. I think
That's
you have to look at
the
the
circumstances.
relative age, right? You have to look at the body habits
Yeah,
of the
and there are
person.
other
and the-
comorbidities.
yeah,
And
all that
you're in the
stuff.
cath lab, somebody dissected your LAD, and now I'd rather put you on ECMO, take you to the OR, fix that LAD, and hopefully you can survive. There's a good, I mean, if you're not downtown, you might survive. You know what I'm saying?
Yeah.
So,
Look, I've seen 82-year-olds that are still got a lot of life left in them. They're out playing golf every day. You know, I don't think you can go, or 78-year-old. You can't go by a relative. You can't go by an absolute age. But I think it's there for a reason. It certainly is it's a way for you to say, look at the patient and go, oh my God, this person is just so frail and looks grossly decompensated, and they're 76. Okay, we don't have to do anything. I think it's a lot of these protocols are there for the
because there was nothing else, Joe. They had to
legal
put something else.
protection
Exactly.
than anything else. Yeah, sometimes.
To be honest with you, there was a patient 2 years ago, he was 85 years old. And when we went to MRB for his VAD, he wrote a statement that all what he wanted to go to his son's bar mitzvah. Also what he wanted out of life, okay? And this guy, when he sees me in the hospital, now gives me a hug every time. That he went through that. He's still alive. Not that he's gonna live much longer, but I mean, he's getting a little older. But again, he achieved the goal that he wanted. Is that something which, economically? But I'll tell you, that was, for this person, that was his goal in life. So you have him achieve something that he really wanted out of life. For me, that gives me satisfaction.
Right. Yeah.
I mean, that's like the French people when the daughter had her dad dance with her, and in France they don't spend money like we spend. You know what I'm saying? And I was very surprised that in France they did that. So
They have the ambulance with the ECMO. Are you
Right.
kidding me?
Yeah,
they
they do.
are spending the money. But
okay.
speaking of France, I don't know if you saw this or not, but they had that big sale, the gun show of all of those French war rifles. They were selling them by the crates. They were never fired, only dropped once.
I'm telling you, I keep asking my wife to buy me a drone with a Hellraiser missile, and she doesn't want me to buy one.
I'm
All I
kidding.
want is a drone with a Hellraiser missile.
I have a drone back there
Yeah.
with a mini Hellcat missile on it.
See,
Yeah.
he has one. I want one.
We have one. I'm gonna let you fly it today.
That sounds great.
I know exactly where you can take it.
I know to what I can take it to.
I know exactly whose house you're taking it to. Okay.
So I'll tell
Exit
you.
strategy.
So I'll tell you, really. I'm sorry. I went back at a moment.
Go back. Okay, sorry.
I'm sorry, sir. I got distracted. So here's the punchline. If there's no there's no exit strategy, then there's no exit. Now, we'll talk about the question before about the hospital resources, and that are very important. It's a very important question. Your blood bank has to be alert and oriented. I know, and I'm not here. Some other facility, the facility is located in one hospital in one state. For me to get platelets, I would have to get from another state. So if somebody needs a lot of platelets, I have to transfer them out. And this is not a unique situation. This situation exists all over the country. So we need to understand that. We're spoiled here. You need to have good perfusionists, good CV surgeons, good vascular surgeon for distal limb perfusion. So do you guys believe everybody who gets fem echo needs
Yes.
a catheter? You agree?
They all get DPC, yes.
Exactly.
And a vascular surgeon is called a lot of times, not for that, but for repairs of femoral artery
Exactly.
cannulations and difficulties later.
Exactly. You need to have 24/7 intensivists. You need to have good pulmonologists, hematologists. One of the biggest issues with ECMO's anticoagulation is a big controversial subject. I know we're going to have a lecture about it at some point. And really, a good hematologist is needed to help you. You need an interventional cardiologist who can perforate the septum, like Joe said before. Heart failure cardiologist to put the patient, list the patient. ECMO trained and certified nurses. Good PharmDs to adjust the drugs for these patients is very important. And if you don't have any of that, you need the ECMO telemedicine support, which is a new happening movement for hospitals that do not have this kind of backup support. And ECMO telemedicine actually can help you a lot. You put a patient on ECMO in your hospital, ECMO telemedicine person will have a relationship with the other hospital to be transferred to. They will know their criteria. It will help you in placing the patient wherever we want to put the patient for wherever they're going to get a heart or lung transplant. So I think that's a big thing that's coming up and happening. So I'll tell you, you have to have these things in place before you decide to embark on ECMO. ECMO is a very expensive, endeavor. Here's a digital technology tele-ECMO. For all this equipment, you need to just have 2 laptops to take care of that patient. How about that? And know where to put with them.
So,
tell me, sir.
This is somebody that is running their ECMO from home? Is that what you're saying? Through their...
No, they're not. They are. See, this big word is running. How about monitoring?
Okay,
managing.
Right. Mm-hmm.
So here, I mean, and I don't make it. I want to simplify it, and don't throw the mic at me, or you can. It's okay. So ECMO really, what's the parameters we can change in ECMO? The flow, FiO2.
Right.
Okay. And the volume, and the anticoagulation. Anything urgent surgical intervention. It cannot really happen at the bedside, or it can happen at the bedside, but the surgeons are not always available. Mm-hmm. So that tele-ECMO person, I'll tell you what he should do. Have good relationship with the nurse. The nurse calls him and says, "Oh, I have this is kind of happening with the flow. This was happening with my gas,"
mm-hmm.
and then we'll help manage the situation. This is what's happening with my anticoagulation.
Right.
And help manage that. Patient needs to go to the OR. That ECMO, tele-ECMO person should be able to call the surgeon. You need to take your patient back to the OR. That's happening. And then call the perfusion service, and this patient needs to go back.
Mm-hmm. Well, that's interesting. That's something we've been talking about
It
around here.
is.
So,
it is.
Yeah.
Let me ask you this, Patrick, and Dr. Samir, and you probably will know as well, Christine. John, you do a lot of ECMO. Min, in the community hospital that is not an ECMO center, where you have 12 ECMOs going on all of the time. You have the one here, one there ECMO. What is the single greatest cost associated with delivering ECMO to that patient?
Perfusion.
It's one of the top. Standing at the bedside.
It's one of the top ones, if not the top one. Yeah.
Yeah. It is unfortunately, this is the top one.
Mm-hmm. It is the top one.
And that's why we discuss this from a healthcare professional's perspective, even though I'm also a business person and we all work to make money, right? None of us work for free. I mean, that's just life. We shouldn't. But there is a definite problem. And that is there are multiple hospitals that do not want to even offer ECMO as an option because it will essentially break their bank. That's not good for patients. So our first responsibility, in my view, is to patients that are in need, whether they're ours or anybody's. It doesn't matter who it is. That's why we share information. That's why we do these lectures. We have these discussions. And that's what we do. And we do that because we're here to all help each other do the best we can for any one patient, whomever that may be. If we don't find a solution to having a perfusionist standing at the bedside, sitting at the bedside by the ECMO pump 24/7, then patients are going to fall through the cracks. Hospitals will stop providing ECMO service because it's too expensive, or hospitals that should have an ECMO option and a relationship with another facility who could receive them, whatever, not to keep them, but they won't do it either. We have to make ECMO more like what balloon pumps are now today. What they used to be, perfusionists were there at the bedside, inflating and deflating with the millisecond delay from the R wave and the P wave, all of that stuff. CRRT machines were at one time, you know, oh my God, you have to have some specialist do this. Now nurses at the bedside do that. ECMO has got to become that type of a therapy if the therapy is going to be utilitarian to more patients that need it. So that's my philosophical thought.
Well, what happens at the center that I'm at, and you came down there, Joe, we have a very large ECMO
much more
center.
efficient.
The head cardiac ECMO surgeon has networked himself through dozens and dozens of hospitals, all in our state and out of our state, where he's networked himself and endeared himself, I think, to the cardiac surgeons there at those hospitals who are willing to put an ECMO patient on, but they are not, with all the list of the specialists you listed there and the undertaking that it is involved, are not willing to say, I'm going to put this patient on ECMO, and now what are we going to do? Well, what are we going to do is we're going to come and get them. Our facility will come and get them. Or we'll go there and cannulate them, or we'll pick them up, either way, and cannulate them at our facility. So phone calls are made right away from that cardiac surgeon to our cardiac surgeon. This is what I have. What can we do? Can you take the patient? Do you want us to put them on? Do you want to come get them? And everything's coordinated, and we do it very quickly, and we do it all every day, so it's very efficient. But he's established a network where all of these centers, small centers, are willing now to put a patient on. And they know we're going to come and get them that day or the next day. And they've made what money they can from the insertion, which is significant. But the long-term cost of having that patient there and not survive, they don't have that. And it's shown that the survivability and the mortality and morbidity is much less when much less when a patient comes to an experienced center.
Survival is higher volume, higher survival.
The mortality,
that's common.
Yeah, so
in everything.
So that has been a solution that I've seen, but the thing that some hospitals make a mistake is they read this thing, well, ECMO buys people time so they can heal, recover from whatever. So some can. So they take that and they set it and forget it. If you do that with ECMO, you will never be successful.
Correct.
It involves a 24/7 intensive, eyes on, hands on, every minute of every day with multiple specialties looking at what the trends are.
And what you're talking about, which goes against the economic philosophy of this country, including in medicine, is centralization of services. That's what you're talking about. But we don't have that. Not every community has a hospital like yours that goes and takes all these patients. And then what about the patient who's just a little further away that's in a community hospital that does 400 hearts a year, that should have a heart surgery, an ECMO program, but doesn't? I know two right now, not far from where we are right here, that do not have the ability to provide ECMO, that are doing between 300 and 400 hearts per year, and have patients who end up getting put on either a balloon pump or maybe an Impella, and they don't survive that part of it. They needed more, and they just didn't make it, but could have. So the other problem is your in, if you just keep moving that ring out, your in can be full. You can have a no vacancy sign. You just got to keep building. I understand that, but it takes a process. You got to fill all the beds and be at capacity for a certain period of time before anybody's willing to now spend another couple of $1 billion to build yet another wing to your facility. And this is just a big problem. So centralization of services, I think, is really good in terms of improving survival through volume experience, and of course having all those other ancillary services. At the same time, not having the ability to take that model and put it over here in these other community hospitals means that you can't still manage all of the patients that need to be managed.
Well, what's happened is you start off with a community hospital that just puts them on and we come and get them that day.
Mhm.
Then it happens over time that they stay there a day or two before the arrangements can be made. And now they've had to experience the patient 2 or 3 days. Eventually they have more and more and more experience. We have a hospital like that now that has gone from 1 ECMO machine, 1 cardio help, to 3.
Mhm.
They do all their VVs and they keep
I
them.
wish you'd stop marketing for that company, okay? ECMO, just say ECMO pump.
And they send us all their VAs.
Mhm.
So if you establish people that will, hospitals in your area that are willing to launch an ECMO insertion come and get program, they will eventually grow to be more and more of that. It'll take time. And then you'll have more business at those places where they're going to say, you know, this VV, we did this for 2-3 days. It wasn't as bad as we think. Maybe we can hold on to it 4 or 5 days and see what happens.
Mhm.
And then they had one do well. And now we've have a hospital not far from us. 100% of their ECMOs have all been successful. All their VVs, they've all survived. Now they figure they can have 2 or 3 going. So
that is. I think.
But if
that's
you never
fantastic.
launch the insertion,
do they use perfusionists at bedside or nurse ECMO
perfusion is
specialists?
24 hours. Yeah, now
24/7.
They're so difficult to go beyond perfusionists. You have to have a busy center. You have to train ECMO specialists. They have to maintain their training. There's a turnover.
Unless
it's hard.
You have somebody like Dr. Samir who's monitoring the patient for you via telemedicine, because now he can watch 4, 6, 8 in various different locations and maximize that efficiency like you do at your facility. 1 perfusionist and you've got 8, 10, 12 ECMOs going at the same time. So it becomes cost effective.
So maybe we should open Dr. Samir's call center. You know?
I think we
And
need
he'd
it.
just be there, have
Okay.
operators answering
Now,
the phone
I'm
24
gonna-
hours a day.
now
What's-
That's my little call center, and because I mean I do that ICU, and I'll tell you, critical care experts are not that easy to come by.
yeah.
So critical care have to go by that way, and I think it's working very well for us. You can have a very fancy center with the, like it looks like a space center, but that's not cost effective. Or you can have a simple setup. We have a camera, I can see, look at the room, see what's going on, and talk to the patient, the nurse, the family, and it's very, I mean.
If you're talking to the patient, they don't need to be on ECMO.
Can I be controversial now?
Yes, we've been waiting
I'm
for
just,
you.
Yes, well, I'm going to be very honest with you. If I have to walk somebody who is on ECMO, I want the perfusionist right next to me. I do not want a perfusionist sitting in a computer 1,000 miles away. How do you feel about that?
Well, what's the perfusion going to stand next to you, hold you? See, I
No,
mean,
but if there's an emergency, I am a physical therapist. I'm not trained to work that machine.
What's the emergency in ECMO that you're going to need a perfusionist in?
Well, if anything, if
Like,
problems with the flow or problems with the, I mean, who is going to be adjusting the machine?
nurse.
Okay, maybe a nurse, because I wouldn't be doing that. I'm not
The
trained
nurse.
for that.
The nurse. It's not that complicated, but the thing is, Christine, catastrophic events that occur, massive air embolism, circuit disconnection, inadvertent acute decannulation, we can't help you. We can go get a tag and put it on the toe, but that's about all we can do. There's not much we can do. It's over. The ball game is over. 9th inning, 3rd out, done. Okay, we have managed all day to stay on time.
Except now, because it's my fault.
You have derailed us, so
I'm sure.
That's it. We need to focus on your talk, and let's drill down.
Okay, so again, I mean, so this is how, I'm not sure, is this going to play? It might play. This is a live demo how we're managing
Yeah,
our
can you
telephone.
play that video?
I don't know if, does it play from here? Let me see. Does it play?
No, they'll play it up there.
Okay.
They got it. There.
So this is a live call. Are we all okay? Are we okay? Okay, I would give him a liter of LR now, okay? A liter of LR. Okay, please, yeah. So the input is coming in my headphones. Okay, thank you. So we're going to be giving him a lot of boluses tonight, okay? Whenever his pressure drops like that, give him a liter, okay? Open belly with pus in the belly, local, and use Let me know his hemoglobin less than 8, okay? Over his belly. And so he's basically... hemoglobin less than 8. Okay? Thank you. That's the subject we're talking about, hemoglobin transfusion.
And what you should have said was, and Christine, if the cannula comes out, put it back in.
So, I mean, really, so you're able to talk to a nurse, assess the patient, and manage from there. I put all my orders. I have Cerna computer, another computer, and that's it. Thank you all.
You got us back on time.
See?
That was your last slide.
Yes.
Can I address what Christine, is that what
Yes,
she was
Chris.
just saying about?
You can call me Chris, that's fine.
Okay, your point is well taken, actually, because I say this all the time, you know, it runs well until it doesn't.
Exactly.
It runs for days and hours and days and even weeks at a time, sometimes with very little hiccup, and then all of a sudden something's happening and somebody who really knows what is happening needs to be there and needs to say, we need to do such and such. And a lot of times that's a CCM, sometimes that's a perfusionist, but it's usually somebody who's perfusion related when it comes to circuit hiccups and volume, different things like that. So unless you have someone who's working with perfusion almost day in and day out, who's not a perfusionist, it's going to take a very long time for them to diagnose even the simplest hiccups with the machine alarming, all kinds of pressure alarms and different things that it's saying, what's important, what's not, and what to do about it. And if you do the wrong thing, it can go downhill, you know, that much faster. And you know, walking a patient is a scary proposition, even though it becomes routine sometimes. It's a pretty scary proposition if something goes wrong, because it's going to be very ugly very fast.
Yes, I mean, there's, you know, if something catastrophic occurs, there's nothing anybody can
even
do.
the patient falling, like
even the surgeon standing right there can't save them.
But I'm going to turn the tables around on Christine now. You remember when we started your walking program in, you know, where we work, and there were objections on the program that people are going to extubate, and we're going to log roll them when they fall down and intubate them on the floor. Remember all these discussions that we had in meetings we had that I wanted to kill myself listening to that. And how many patients that you have walked have self-extubated?
None.
Thank you very much. Have a great day.
Handheld, massive.
Yeah.
Okay.
They do a good job of suturing and securing in. However, if you have someone for weeks or months, the tissue where the sutures are erodes, and it can become a bigger problem. Although I still have never seen one walking come out, but I have seen cannulas come out when we were turning the patient.
Turning the patient.
That I've seen.
But I'll tell you, John, you know my issue is when Chris is walking a patient and she has her help with her, they're paying attention to the patient. They're all focused on one thing, is that patient. She's her only focus on one patient. And the drama we had to go through to approve Christine's project, that was her project. To walk patients was, oh, we're going to log roll people, we have to have the airway card. I've never had to intubate anybody on the floor that she has self-extubated. So all this drama, people are self-extubating on the bed. How many people self-extubate on the bed? 1 million. Why? Because nobody's paying attention. They're trashing around, nobody's paying attention.
I'll tell you something funny I heard about cannulation and decannulation just the other day. A surgeon said something. We had a scare where somebody we thought was going to decannulate from the neck. They were, you know, on what was it? It was a Avalon, yeah. And he said, if there's skin on the cannula, it's the nurse's fault. If there's no skin on the cannula, meaning there was a suture problem, it's the surgeon's fault.
Well.
Gross.
I know.
Okay.
All right.
So with that said, finally,
my turn.
Last but not hardly least, we have Christine. And am I saying that right? It's
Christiane.
Christiane Perme. Is that how you say it?
That's correct.
Perme. Okay. You're a physical therapist.
Correct.
And what is a CCS and an FCCM?
I am a cardiovascular and pulmonary specialist by the American Physical Therapy Association, and I'm also a fellow of the Society of Critical Care Medicine.
Oh, okay. The SCCM.
Correct.
Okay. Is that okay. Very good. And you're currently working at Perme ICU Rehab. Is this a private company?
Yes, this is my own business.
Oh, okay. Here you go.
Yes, I teach classes for physical therapists how to mobilize patients in ICU. And I also work at Houston Methodist, where I am a clinical development specialist.
Very good.
Okay. So basically, First of all, thank you so much for including me in this program. I'm very excited to have an opportunity to be here and share my clinical experience with all of you. And I'm going to start by saying that the reason I'm here is because I have been doing this for a long, long time. So basically, just for you to have a little bit of idea, I started walking patients on mechanical ventilation in the 1990s. Like Dr. Samir just said that at the time that was crazy. I have to be transparent here and say that I had absolutely no clue what I was doing there. And I did not want to be doing that because the only thing that I thought about is just that I was going to kill that patient, just because at that time there was not really any kind of support for that. So basically, a couple of physicians that had a vision that if I only what they would tell me, if I only did my job and got those patients up and walking around, that they would not die and they would do better. So I started doing that little by little, and look at the kind of ventilator that I used at the time. I mean, that was like an SIMV with 100%, very hard to ventilate patients. And then I even walked patients when they were on the T-collar, on the T-tube. I don't even think they do that anymore, but there were some patients that if they could be on pressure support of 5 or some, that we could just take them off the ventilator, walk a little bit and go back. And I continued to do that because when I started to see the results, I realized that as a physical therapist, I didn't really want to do anything else because it was really fascinating. And I continued to do that until it got to the point that I was able to successfully walk somebody who is mechanical ventilated also on the ECMO. So basically, before I talk about the patients on ECMO specifically, I'm just going to give a brief overview about the early mobility in the ICU because, again, this is a very hot topic right now. So this is nothing new. We do have some reports in literature in the 1970s in the Physical Therapy Journal and also on the Chest Journal about mobilizing patients that are mechanically ventilated. And in these two reports, they are really talking about the amazing benefits of they had by such practice. Interestingly enough, I have spent a tremendous amount of my life looking at literature because this just fascinates me. I was not able to see a picture of a patient walking on a ventilator or even mention. There were a couple of textbooks, but not necessarily published in medical journals until 2006 when I published that article about mobilizing patients with LVADs that were ventilator dependent, and nobody knew what to do with those patients. So I started mobilizing them, and that's in 2006 was the very first time that I saw a patient that showed a picture of somebody walking on the vent. After that, it was in 2007 that the whole initiative about mobilizing patients started with this publication on critical care medicine by Bailey. So basically what you're looking right there, those 4 articles are the whole initiative that started mobilizing those patients. And that was kind of determined that it was safe, feasible, and improves physical function, also can reduce delirium, and it can also reduce the length of hospital stay and cost. But like I told you, I started doing this in the 90s. None of those articles were published. So the only thing that I had, it was to read about research on bed rest. And I'm going to be honest that the more I read about bed rest and the horrible things that caused to the patients, the more I wanted to get those patients out of bed. And as far as what's going on right now, I don't know that everybody's already familiar with the PADIS guidelines that from the Society of Critical Care Medicine. So what they did, thankfully, they added the immobility to the guidelines, so as well as the sleep disruption. So now I'm sure that not only in this country, but throughout the world, professionals in ICU are going to be a little bit more aware of the risks of, having patients in bed and not really mobilizing them. All right, so now let's go to the topic that I'm here to discuss. So we're going to be talking a little bit about ambulating patients on ECMO. So basically, these are some of the important considerations that I would like to address. So I'm going to go to each one of them kind of briefly, and then hopefully we have some kind of time to discuss the topic. So basically, I'm going to start with the goals. First of all, we have to have a reason why we are doing this, because in my opinion, it's just not because we can do it that we should do it. So we do have to have a reason. So basically, some of the goals when we are able to ambulate these patients is to minimize the harmful effects of the bed rest. Also, to promote bronchial hygiene. We all know that the best position for lung function is up and moving. So we have to also think about how that's going to help as far as airway clearance. Minimize the loss of functional mobility, maximize their functional independence, facilitate ventilator weaning, and also promote cost-effective prevention and treatment interventions. So these are the goals for us to take such responsibility of getting those patients up and walking. Are there risks? Absolutely. Like you just mentioned, despite all the benefits, we know that all of this is really going to help the patient, but there are several concerns that we should be aware, and they are related to safety. So we have to determine, if you're going to be doing this, that some patients are very high risk and others are low risk. So there are several factors, and first of all, before we make a decision if they should walk or not, we have to kind of decide if they're high risk. And at the end of the day, it's all about risks and benefits. So we can have the best benefits, but we also have to look at the risks because, like you said, if something goes wrong, there's not a whole lot we can do. So we have to be very careful on the patient selection for this practice. So who are the high-risk patients? I'm going to tell you that the first one is that a patient that does not want to walk. Because even if I have, as a physical therapist, if I have a patient that is not on ECMO, if they don't want to walk, I mean, those are the patients that can hurt you and can also hurt themselves. So the patient has to be willing to put in the effort for that activity. Altered mental status is also very high risk because you never know how those patients are going to react. Patients that have significant hemodynamic instability with position change. If they do not tolerate turning in the bed, I can tell you that they're not going to do well walking up and down the hallway. Not the highway, I'm sorry. The hallway, not the highway. The hallway.
Oh, it's going to be a highway.
It's going to be there, exactly.
It's going to be a highway
Absolutely.
somewhere.
Another very important high-risk patient are the ones who have a significant weakness on the lower extremities. And how do you know that? Very simple. If you ask your patient, can you raise your legs up in the air? If they cannot raise the legs, it's very unlikely that they're going to be able to safely bear weight and walk. And also the patients that it needs 2 staff members to stand. If you need 2 staff members to hold them up, right? I don't think those patients should be walking anywhere. Then you have the low-risk patients. Those are the ones that they want to walk. They are medically stable. So by that, I say that they are hemodynamically stable and they have stable oxygenation and ventilation. In addition to that, they are alert, they follow commands consistently, so they really understand what I'm trying to do. They have at least minimal functional strength. Again, when I just mentioned that, if I ask them to lift their limbs against the gravity, they are able to raise the leg and also keep the knee straight, because if they do not keep the knee straight, they may not be able to bear weight and the knees are going to buckle. And also, the low-risk patients, they are able to stand and walk with minimal assistance of 1 staff member. So this is it. Very important that we kind of look at that and make a decision. The second thing is that it requires an interdisciplinary team for ambulating these patients. I hope you noticed that I did not say a multidisciplinary, because the way I look at it, a multidisciplinary is just, you can have all of these professionals, but they're not talking to each other. When you talk about interdisciplinary, that means that they're collaborating, that all of them are, have a part on this. Mm-hmm. So this is the team, and I put the patient at the very top of the list because they must be part of the team, they must participate, they must understand the benefits as well as the risks when we do that. So those are all of the professionals that are going to be involved. And I also include family members and friends. They like to be around because it's an important thing for them to do that.
It's encouraging. It
is encouraging.
Progress.
Yes, absolutely. Now, if we are going to walk away from the bedside, those are the members that must be present in order to ensure safety. So the physical therapist, the perfusionist, and an ECMO specialist, if that's the case, that there's one around, the ICU nurse, and a rehab technician or a patient care assistant. So there's quite a bit of people around because we need to have that team, everybody aware that we are really doing something that it's high risk and we have to be ready to take that responsibility. And other team members that they have to be readily available is an intensivist and also a physician trained to place the ECMO. Because again, if something happens with those cannulas, I know it's going to be a catastrophic event, but maybe if it's just a little catastrophic, something they can fix it. You know, somebody who knows what to do, you know, could do that. So personally, I have had situations like, for example, on a Sunday where the whole entire team, they were demanding that I really walk this patient, but there was not a surgeon in-house. There was nobody there. So if something goes wrong, I just can't do this. So everything has to be done correctly. In addition to that, for patients that are on mechanical ventilation, the RT must be present to manage a ventilator. And walking activities outside the room is only indicated for the low-risk patients, and I just keep saying that over and over again because that's one of the most important messages that I want to bring here. Now, the safety screen, this is done every single time. That's not going to be done one time. We're going to look at the neurological status. Is the patient able to minimally participate with planned activities? Because again, the patient's status change from day to day, right? It could change even in the same day. The cardiac status, the patient has to be hemodynamically stable. They also have to be with stable ventilation and oxygenation status, and they also have to be able to stand up and take steps. You would not believe how patients' conditions change from one day to another. They may be able to stand today, and the next day they just can't. So that is a safety screen. I'm sure you see that I put some a little, clip art there with a little flag man there. There's not only one, there's 4 of those, because that is one of the most important safety aspects. We have to do that before every single time that we mobilize those patients. Importance of securing the ECMO cannulas properly. We have to make sure that those cannulas are not going to be dislodged. So we take every single effort to secure that in a way that we don't have to worry about it. Now, contraindications. Who are the patients that I talk a little bit about high risk, but if the patients have an unstable ECMO vascular access, this is not going to be an opportunity for these patients to walk because we can't really be doing this. Or if they're having a significant drop in the flow with any kind of mobility activity, or if the cannula does not have a stitch, it's not really secured in place, I think the risk is too much. I don't think it's worth taking that risk. And also, if the patient has active bleeding with a significant drop in the blood count, or if they're recurrently blood transfusions, and we know that the patient is bleeding, and we have to be very careful with that. Also, I would say that pending end-of-life decisions or final decisions for comfort care. And the reason I say that because when I hear, the patients walk on ECMO, I want everybody to understand that for some of these patients, this is a significant effort. It's just like a fish out of the water. It is very difficult. So they suffer. It's not an easy thing. So we have to really make sure that we are doing the right thing for the right patient. Also, on contraindication, if they have some kind of hemodynamic instability, requiring escalating dose of vasopressors. I've had situations where we've had patients on pressors and then they wanted the patient to continue to walk, which I really don't feel comfortable doing that just because, if something goes wrong, it's really going to complicate. And also, another contraindication, if we do not have the sufficient support personnel to ensure patient safety. Okay?
I'm so glad you brought that up. You talked about how much effort it is to do.
It is a tremendous amount of effort.
Because I'm sure you have heard this. I'm sure you have heard this also. John, you may have heard it. I know you've heard it, Patrick, because we all know the same people. And they really think that the ARDS septic patient, flu, influenza derived, that's just really sick. We're controlling their temperature. They're just sick. Is going to get up and walk. They're not going to get up and walk.
Well, sometimes.
Or what do you think?
Well, it's again, this is like the story of my life because the expectations of the team, they want those patients walking no matter what. And I've had situations when I had to address some, team members. I said, well, think about a day that you had a flu. Or maybe you had a severe gastroenteritis that you can barely get out of the couch and you feel so sick. Is that the day that you pack your bag and you go to the gym? Sometimes you just don't feel like doing anything. You don't feel well. And I would say that these patients, for the most time, they don't feel well any day. they still get up and do it, but there are some days that they just can't do it. So we just
Well, I
have to
guess
be
I'm
careful.
saying acute disease versus chronic disease. Do you what's your feelings about that? Do you think there's this mentality to try to push people to do things in an acute disease state where we shouldn't be?
Well, it depends. I mean, different patients react differently. It's hard for you to tell that, but I can tell you, like, for example, if we just mentioned ARDS, those patients, they cannot ventilate, so no matter what you do, they can't breathe.
They have no reserve.
They have no reserve. So it's different, like when you walk somebody with a VA ECMO, they do not really have the respiratory symptoms, they can tolerate a lot better. I mean, I've had patients, they're walking like 2,000 feet and they just walking around.
On VA ECMO.
Yes, and but others not really. And if they don't have the pulmonary reserve, it's very difficult to tolerate the activity.
Yeah,
and I'm going to show in a little bit a situation like that. All right, so another thing that is very important for us to be aware is, like, what is the criteria for termination of this ambulation activities when the patient is already walking? Anytime the patient has any kind of acute change in the mental status, if they're unable to follow commands and participate, all of a sudden they are not really understanding what you're saying, that kind of already tells you that something is wrong. If we have like a significant drop in the ECMO flows and they cannot correct that, any kind of hypotension associated with fainting, dizziness, or diaphoresis, because we just know that it's going to go worse from that on. And again, significant change in the heart rate or in a change of rhythm. In addition to that, when you have like an SpO2 less than 75 with adequate supplemental oxygenation, so if you've done everything you could and you cannot maintain 75, severe intolerable dyspnea, significant chest pain or discomfort, extreme fatigue, and also if the patient requests to stop. Sometimes they've done enough and they can, please, I can't do it anymore, and I can see that there's always those on the team that they feel like they're the cheerleaders, and no, you can go on, and but there are times that you can clearly see those patients cannot do anymore, so we have to kind of respect that. So here's a couple of patients that, just to illustrate, so this is, you've seen this before, where the patient is intubated and she's also on VV ECMO, and I want you to pay attention on the incredible teamwork that it takes for that, and we have some of the intensivists also available, and it is a lot of effort. Another thing that I want to make sure that for safety, every single one of my patients.
That's my brother.
That's your brother. That's
that-
Ben's brother.
That's my brother.
Really?
That was young.
So anyway, so
Not the patient. Not the patient.
is that really your brother?
That's my brother.
Oh my gosh, that's interesting.
Yeah, when I left, he took my place at Methodist.
Oh, really? Oh, okay. So anyways, another thing that I do 100% of the times is that when I walk those patients and they are in the hallway, we always follow them with one of those stretcher chairs. Because again, if any of those patients, if they kind of pass out or something and they're sitting in a regular chair, it's going to take like a incredible effort to safely, return them to the bed, especially if they're not able to stand up and get back to the bed. So I feel like having the stretcher chair where the patient sits in the chair and it becomes a stretcher and we can just do a lateral transfer back to the bed. So 100% of the times, I would not ever, no matter how strong the patient is, how young, how well they're walking, for safety reasons, we always follow them with a stretcher chair. So, okay, so now what happens if the patients are unable to ambulate? Because I'm going to be honest with you, I don't think that really the community realizes that the patients that can ambulate on ECMO, they are really almost the exception. That's not every patient can walk on when they are on ECMO. So basically, if they cannot ambulate, I just want you to know that there are other things we can do. So just general nursing mobility, in bed activities, they just turn side to side or repositioning. They can put the bed in the chair position, do some exercise in the bed, or they can also be transferred to just a stretcher chair where they don't have to bear weight. Now, as far as physical therapy, there's a lot of things that we can do for those patients. We can educate them about a variety of things, particularly the exercise. That's very important in their progression of activity. Positioning, again, bronchopulmonary hygiene, exercises. We do transfers training, pre-gait activity. Sometimes they're not able to walk, so we spend a lot of time at the edge of the bed, just sit to stand. They're taking steps in place in preparation for the gait re-education, in addition to other things. So here are just a couple of movie clips to illustrate that, like this patient, she was on VV ECMO, femoral, and she was unable to bear weight, and there's no way that she could do that, but she was doing exercises throughout the day, the arms and the legs. This is another one that also could not bear weight, so she's doing exercises with the little weights in there. And all of those, I feel like for those patients, I'm primarily a consultant because in this particular patient, the mother sat at the bedside like probably 20 hours a day, and they did a lot of those exercises. So I was like a consultant. I would change the exercises, but there was a lot of collaboration from other people to do that. This is another, now using exercise equipment. So this is like for this particular patient, it's almost going to the gym. So we have like equipment that they can do quite aggressive strengthening exercises in the bed. And this is very interesting. This is a patient with a femoral ECMO, VV ECMO, and I put her on this exercise table. And with a lot of help from the perfusionist team and also the physicians, they were able to determine how much she could bend without impacting the flow. And we were doing like, this is the leg press exercise, just like when you go to the gym. Now, when I talked about, like the discomfort, this patient, they finally decided that she had to be pre-medicated with morphine in order to tolerate this. Because she was like, again, just like a fish out of the water, but guess what? She wanted to do it. You know, she was so motivated. She really wanted to participate. And for some patients, if they're unable to bear weight, sometimes we can put them, that's the same exercise equipment, that we can just put them on a tilting position where they can bear weight. I mean, there's no way. This person did not have any kind of functional strength to walk, but we could still do some activity to put some weight on the lower extremities. So I want you to know that there's also all of these strategies that we can use for patients that cannot walk, and that is also very helpful. What is the future? Like we just talked about it, I think ECMO is here to stay. Mobilizing patients on ECMO is not only here to stay, but it's just going to continue to be a challenge for all of us. So I got this from the internet. I thought that was very interesting. So not only now we are mobilizing those patients, I mean, you can see this is a patient that he's on ECMO with the Evelyn cannula and also on mechanical ventilation. And I'm not so sure what you can talk about this picture, but to me, it's like in the middle of nowhere because, I mean, it seems like he's in the middle of the road, or I don't know.
But it looks like the helipad, and the patient is outside getting sun and feeling the outside.
Maybe so. But
that looks like the helipad.
Yes, so we just hope that nothing bad happens there because he's probably long ways from ICU bed. As far as resources available, I have to say that there are so many articles that have been published in the past, I would say in the past 4 years. We have like an incredibly large number of articles published on mobilizing these patients on ECMO. So here I'm just going to talk about one that is a group from the UK. They put a consensus agreement for best practice, and they talked about for adults what kind of physical therapy those patients should have. And also there's one that was published last year on the Annals of Thoracic Surgery about ambulation with femoral cannulation and all of the safety aspects that have to be followed to do that. Because again, now the new thing is to ambulate them on ECMO, and there are several facilities around the country that are mobilizing those patients and walking them routinely with femoral cannulation. So the take-home message, so what is it that I want you to remember is that prevention of muscle weakness during ECMO support is much better than any treatment currently available. And I'm very concerned about sometimes time that is wasted on non-invasive ventilation before the patients are placed on the ventilator, and a lot of time wasted on the ventilator before they make a decision to put them on ECMO. And I don't think that they realize that every single day those patients stay in bed and they're not up and moving, or they're gasping for air where they're really using all of their reserves. I mean, the likelihood of them ever recovering is their function. It gets very, very slim. So we have to consider that also, and I'm not so sure that is on anybody's mind. I mean, I know that you're trying to save a life, but we also have to start thinking about quality of life. The second one is that physical therapists should be involved with patients on ECMO from the ICU admission. And we are there because we have to do a functional assessment from the beginning to see what are the possibility that patient can start being mobilized. We also can make recommendations, particularly if those patients are not the patients that can be walking, and also to be able to provide patient-centered rehabilitation treatment for those patients. In last slide, ambulation of patients on ECMO support is safe when all of the safety measures are taken. That's the only way. And that was it. So thank you very much for your attention.
Thank you very much. That was excellent. You get a clap on this one. That was very good. You put a lot of information out in a very short period of time. You talk fast. I thought I talked fast. You talk faster than I do.
Well, that way people pay attention.
Exactly. So tell me, if you will, and the phone lines are open, by the way, if anybody wants to call in and ask Christina a question, or Christiane, I keep saying it wrong.
Call me Chris. That's better.
Okay, Chris,
That's
and or anybody else, please call in. We do have a question from the web, which I'll ask in just a few minutes, but can you discuss maybe, because it looks like you have, you do seminars and you do some other things. Is there, for anybody that's out there in web world that may have a program that maybe is not thinking about how physical therapy can help their patients, do you have any ways, like this is the best way to reach out to you? Do
yes,
you provide
my
that service?
Yes.
Like to outside places? Do you go anywhere? I mean, what do you do? Like, how do you run your business?
What that is that is a 2-day course primarily that I offer that is called Fundamentals of ICU Rehab. And unfortunately, at this point, there's not really a specific training for physical therapists to take care of critically ill patients. So what I do is that I just have this course that I just go throughout the entire country, and then I go to the hospitals and I train their entire staff, or whoever wants to be there. So in 2 days, I teach them about everything about all the lines, all of the mechanical ventilation, and I teach a lot about the weakness that we see for patients in ICU, because this is a completely different kind of weakness. You cannot compare that with any other kind of weakness. And also the therapeutic interventions, how to really mobilize those patients and all the safety issues. So it's like 2 days packed with information to help professionals to kind of go back to their ICU and provide better care for their patients.
John, do you have a robust program where you are, or do you think this would be of some value?
Yeah, that's pretty robust, but I think I saw some things there that I haven't seen them do. I haven't seen leg presses and a few other things in our hospital, so I thought we were pretty aggressive. But there is an aspect of this that that's sort of a thorn in my side, it has been for a while. Do you work closely with the nutrition department, and would you ever consider the patients are catabolic and then they're trying to exercise at the same time? Because this is something that I've seen, and I've brought this up ad nauseum in my department, because we see patients lose 10, 20, even 30% of their body weight in a matter of a handful of weeks. And nobody gains weight on ECMO.
Oh, no.
Okay. So, or even probably maintains their same weight. But if they do, it's fluid weight, right? So I asked our cardiac surgeon, I said, are our patients catabolic? He said, they're all catabolic. Well, if you're catabolic, it's basic nutrition to know that you're in muscle breakdown mode. Your body thinks it is starving, and therefore it is utilizing your own muscle tissue for nutrition. So our nutritionists got involved, and I approached them, and they said, well, we give them double the normal nutritional intake for a person this size and whatever. And I said, yeah, but the proof is still in the fact that they're catabolic. On paper, you might be meeting their nutritional needs or then some, but they're still wasting away. And then you take the physical therapist comes in, and they want them to exercise. They're sick, they're very sick, they're catabolic. So you talked about patients who just don't want to do it. And I think an element of that is the fact that your brain tells your body, you are not spending any more calories. You are already wasting away. And I see this, and I just wonder the conflict between what we're doing and the patient's very, very sick, like you said, then the nutritionist who believes they're doing what they're doing, the physical therapist comes in and now they want them to exercise. And meanwhile, the patient's catabolic all the way around.
That is a huge problem. I completely agree with you. But I have to say that as particular me, I think that what I'm trying to do here is just to keep what they have, And so if patients can tolerate, I go like what the patients tolerate. I routinely check with the nutritionist. And sometimes I've had nutritionists that they're seeing us walk patients in the hallway, and she said, oh my God, I didn't know that this patient was walking. Let me revisit what they're doing to see if I can add something else. I totally agree with you. It's incredibly important, but what is the other option? So sometimes I really don't think, I cannot claim that I make anybody stronger on ECMO, or even if they're not on ECMO, because that's not possible. So what I'm trying to do with these activities is to keep what they have, you know, because sometimes if you can maintain what the patients have, or if you can at least minimize what they lose, that alone is a victory. But I completely agree with you that it concerns me sometimes the fact that they may be utilizing more than they should.
I have two more things real quick. How long do you think a patient, from day one being totally bedridden, do they start to waste away? I guess that's the best way I can put it. I mean, is 3 days of bed rest already impactful, or does it have to be 7 days before they really start to, you know, lose their muscle mass and lose their strength? Do you have any idea about how long that is?
I read a lot about that, so there's a lot of things to consider. Like, for example, let me start first with the kind of patient population that really worries me the most, the elderly. So if you have somebody who is 80 years old and that person comes to the ICU, it could be the healthiest 80 years old on earth, but that patient already has the process that we are familiar with, that's sarcopenia. So they're coming to the ICU with 40% less lean muscle mass. So when an elderly person is laying in the ICU, they're literally losing what they don't have. So it's very, very hard for them to ever recover if they lose the little bit that they have. So you have to consider, is that an older patient or a younger person? Another thing that we have to understand is the difference between being on bed rest and being immobilized. Because you can have somebody that is on bed rest, they're just lying down, so that means that they're not against gravity. So they're gonna be deconditioned. But this person that you could be doing exercise, they're clicking the TV button, so you're still, the brain is still connected to the muscles and they can maintain some of that. Now, the minute that you put somebody on sedation, those patients are on a chemical cast. So because you are taking away the patient's ability to think about the muscles and to coordinate the muscles. So if you can imagine, I'm sure you've seen somebody with a cast on the arm. What happens after, you know, like 4 weeks if you take that cast? I mean, there's massive muscle atrophy, there's loss of joints. But the most important thing that concerns me that not many people think about is the coordination, the ability to coordinate the muscles. So a lot of times when those patients, and we say, oh, they're weak, also, they don't even know where the muscles are because they haven't been able to think about it. So basically, the data that we have comes from studies that are done in patients that have a cast, okay, or the bed rest from NASA. We have valuable data from that. So it's hard for me to tell you because there's another thing that we have to consider. If the patients are septic or if they have a systemic inflammatory response, I mean, that is going to really cause a different kind of damage to the muscles, which is different than just somebody who's laying in the bed.
Well,
does that make sense?
All the ECMO patients are having sears.
Exactly. So
yeah,
then,
100%.
So I'm sorry I can't really answer your question.
No, but it's complicated.
But it's just like there's a lot of things to consider.
I don't know that I would agree with that, what you just said, that all patients on ECMO have sears. I mean, they may have some level of inflammatory response just from the ECMO, but really having sears, I would say that your patients who are, again, you know, the transplant patients who have a chronic illness have adapted to this either pulmonary problem if they have sarcoidosis, or they have some other thing that they're going to be getting a lung transplant, or they have a cardiac problem and they have a VAD in or something like that. They may have had some of that in the initial phase, let's say, of the implantation, but that goes away. I mean, it's somewhat managed. You know, it's not like somebody who is septic, who has that as a major, big problem.
Yes.
But you were talking about sedation. Add sedation and paralytics.
Oh, yes. Yes.
And
that's what's going to go next.
Patients who are going on VV ECMO are getting paralyzed. Who are there because they have severe ARDS, high peak pressures. They can't ventilate them at all, can't oxygenate them at all, and you don't want that person moving at not even a millimeter because you have no reserve at all. You have nothing. You're getting nothing from the lungs whatsoever. And I just think they're two different animals. I think you really described, but it brings up some very interesting points. But before we get to those 2 points, because I have some points that I want to ask you about too, is I have a message from somebody, Nestor in Texas, said that he wanted to comment on your presentation, that it was definitely an eye-opening presentation. And so you got a compliment there. And also Brian, different issue, he said with the national shortage, this is for Dr. Samir or John, with the national shortage of cardiovascular surgeons, do you see a trend with cardiologists wanting to handle initiating ECMO with perfusion but without a surgeon? I guess also Patrick can weigh in on that. So are you seeing that as well?
Actually, in some institutions, this has been going on right now. These cardiologists want to initiate ECMO, and without surgeons' presence, and to be honest, it's a battle between both disciplines.
What's your opinion? You got one?
I'm biased. I'm much more confident having a cardiac surgeon initiating ECMO in case anything goes wrong. I mean, and I have to tell you, I have to look at the Australian experience. In Australia, I don't know if you know or not, they don't believe in VV ECMO. Anybody in Australia, even ECLS, they get their chest zipped on the floor, chest zipped open, they go on center ECMO.
Oh, really?
Yeah.
They do all central
They
cannulation.
do central cannulation. Wow. Okay, so I'm very comfortable having a cardiac surgeon available at all times, because when you go to the cath lab, there's a perforation, what they call cardiac surgery. So, my full disclosure, all my friends are cardiac surgeons, but your cardiac surgery is the backup for any complication. So you want them available and involved from the beginning.
I agree with that.
Yeah.
I agree with that as well. So, Chris.
Yes.
And John, you were talking about, catabolism, and it's the major problem, and so forth. How do you feel, or has there been any work done on this? And am I just absolutely out of my mind to even be thinking this direction? But if you have a 65-year-old, either male or female, who is, maybe the dose would be different, but that is acutely ill, in the bed, going to be like that for a couple of weeks before you're going to be able to do any kind of mobility of them in the bed, maybe not walking, but just to maintain their anabolic state. Has anabolic steroids been useful or even considered, or is that just crazy?
I'm going to be very honest with you. I am not a physician, so I do not, prescribe medications, and I have not seen a whole lot in the literature. Have you seen anything in the literature about that, using the steroids for the patients?
I think they're using most testosterone.
Use testosterone, sure.
Testosterone has been a push in patients to help them recover. But testosterone has its own complications, but there has been a big push.
Well, the complications would be thrombotic. I guess you increase your clotting, so you have a risk of that.
And stroke, and there's concern about the thrombotic events, cerebral.
Stroke, sure, and then I guess sodium retention and that kind of thing. But is that risk, you think, the benefit ratio there in terms of maintaining the patient's muscle mass?
I think, to be honest with you, I've been used successfully. I know one of our nephrologists very strongly believes in it. That's described as a disease state, low T syndrome. And it's being treated with that. And I'll tell you, one of our nephrologists who's amazingly smart, he uses it on all his patients, and they do very well.
So I'm pretty smart too, since
You've always been very smart.
Okay, I'm pretty happy. I'm pretty proud of myself right now, because I thought you were going to tell me that I was crazy. I wasn't really sure what you were going to say, which would be true if you did. But that seems to make sense to me.
The only thing that I have to say is that at this point, we do not clearly understand the weakness associated with critical illness. So basically, there are some studies now that have been published on JAMA, and unfortunately, I don't think there's not anybody in this country that is really highly interested in this topic, but there are some physicians from the UK and Australia that are really doing a lot of research on that. So what they're doing serial muscle biopsies on these critical ill patients. I remember that one that was published on JAMA in 2013 that they did like day 1, 3, 7, and 10. So basically they're looking at this muscle cell and understand what's going on, because we do not understand exactly how that is damaged. Like you just said something about neuromuscular blocker, but when you work with transplant populations, when you add the neuromuscular blocker and large dose of steroids, that is even worse. So because that damages the muscle cells, so usually it takes about no less than 12 weeks for those patients to walk again.
You're talking about corticosteroids, like catabolic steroids, as opposed to anabolic steroids. Like
but it's a combination of those drugs. You know, it damages the cells at a certain level that those patients are almost flaccid, and no matter how much physical therapy, no matter what you do, they don't get better. You know, it takes easily 8 to 10 weeks before they're able to stand up and bear weight and start walking. So, but we don't really clearly understand the mechanism that causes that.
Yeah, that's a good. Well, you know, I'm thinking, of course, you know, just again back to the steroid thing or the testosterone. Infusing amino acids and giving them testosterone. You know, you can infuse amino acids into somebody, but if you can't utilize them,
if your cell cannot utilize
testosterone sort of drives that muscle building, you know, engine that gets going. So I would think that somebody acutely ill, even if they're a normal healthy individual, is probably going to have their testosterone level go absolutely to the tank. You know, and so I would think that, at least that's a thought. How much interaction do you do, or have you done, or considered doing with the space industry? Since, of course, weightlessness has a similar phenomenon. It may not be for the same reason, but it has. But the whole point is, you have this weightlessness, so you're not really using your muscles.
Well, actually, the best studies are done by NASA. There's no doubt about it. And now they are also using specific exercise equipment for them to exercise in orbit, you know, to save some of that mass. So I do think that there's a lot of incredible information that is being completely underutilized. So right now, unfortunately, a lot of the focus is just how much PT, how many times do you see, how many but we are not really focusing. Like I said, what we need to understand is, first of all, identifying what caused the weakness and what kind of weakness, because it also could be a neuropathy. The nerves could be affected.
Of course.
Because what's happening now, when you talk about critical illness, everybody's talking about heart failure, you know, respiratory failure, kidney failure. Has anybody heard anybody talking about muscle failure? What about nerve failure? Those things are not, they're at the end of the list, but.
No, this has been extremely, thank you panel, all solid. No, I think that this is, this has been a great talk. And so much out of our consciousness to add this into this. You know, how much of what we've heard today, Patrick, you know, John, in your setting may be a little different, but Patrick with ours, which our ECMO centers are much smaller than John's, but patients who are recovering from their ECMO event, they look like they're actually doing better. Maybe some of this simple, just raise your arms. You know, let's get a physical therapy consult in this patient. I've never even thought about it.
Right. To be honest with you, I mean, we are very biased. I mean, we get physical therapy consults very, very early. And I mean, I'll tell you, thanks to, I mean, a friend of mine and Chris's, a German surgeon. You know, Germans are crazy. And he's a friend of mine, so we can say that. And he was with me, just as open, said, Chris, it's your responsibility to get this patient going and extubated and going home. You know something? He had that vision. I'll tell you why. Because about a couple of years ago, I was on a flight to Dubai, and I see this guy behind me, and we kind of know each other. And it was a younger guy that has got a VAD, and Chris had been walking him.
Oh, wow.
You know, and now
we recognized him.
Yeah, we recognize each other, and he has his VAD, and he's traveling all the way to Dubai.
Wow.
So he would not make it that far if he was not walking. I mean, the one thing I want to mention is you always have to be strong for your physical therapist. Do not blame them for anything. If anything goes wrong, it's not their fault. We're doing high-risk maneuvers.
No, we all know.
You have to be supportive.
We all know it's never the physical therapist's fault. It's never the perfusionist's fault. It's never the respiratory therapist's fault. It's never the surgeon's fault. It's always the anesthesia's fault.
You're not going to find
we
you
all
outside.
know that. We know
You're going to find you outside.
Yeah.
You know, so I'll tell you, you really have to be supportive of your physical therapy team because things will happen, and you know, we're dealing with a high-risk situation.
Very good.
When we're talking about the walking, ambulating ECMO patients, we're told bad things will happen, and it's part of the deal, and it's okay.
Absolutely.
But that's why it's so important the collaboration, because I am not a physician. You know, I really rely on the physicians to really, you know, assure to me that that patient is safe. You know, to be mobilized away from the bedside. You know. Because I can't, as a physical therapist, I cannot make that determination. I really can't. So it is really a true collaboration from everybody in order for this to be a successful, you know, mission.
It takes a village, right?
It does.
It does. There's no question about it. Okay, so how about if we do this? Let's go with last thoughts, since they do final thoughts on the Greg Gutfeld show. We're going to do last thoughts. So we're going to start with, we're going to go down the line. Patrick.
First of all, your presentation was great because I wrote down a bunch of questions and then you answered them before the end of your presentation, so that was great. And then you kind of asked one of mine as well. But what I enjoyed most, it's not really a question, is those exercise beds that you showed. I've never seen anything like that, and that just looks like a great idea.
That is some awesome
that was
stuff,
really
isn't it?
cool. Yeah.
No, I learned something from this today. Let me tell you what, from everybody. I learned from everybody today.
Yeah.
That's what makes these programs so great, is that we learn something. That's the whole point.
So, you know, can you see our patients exercising like that?
Like that?
Yeah, because, and John, you kind of asked the question.
Well, I mean, if
how
you don't,
soon? Go ahead.
If you don't have an active physical therapy coming almost the first thing you want to do, get the patient to wake up and sit them up. The first thing they need to get off the anesthesia drugs, wake up and sit up. When they can sit up, they can start. That right away is going to help improve your success. Then when they can stand up and walk, no matter how they're cannulated, make sure they're secure, make sure you do it safe. But the physical therapy part will improve your ECMO outcomes tremendously. If you don't
I totally agree, because I think
you don't have that going on here at Houston, I'm sure.
No, well, sure we do where they are. We don't where we are.
Well, you're missing a big element.
Yeah, we don't.
I think we are. I absolutely agree. I think that it just helps with the patient's mentality. You know, I mean, we all know it. I mean, what would a surgeon do? What would any heart surgeon, any good heart surgeon do if the patient the morning of surgery says, "I ain't gonna make it"? Cancel the case.
Absolutely.
Okay? You have to cancel. Get patients who are that sick and start them moving. They start to have a purpose, and that purpose becomes, you know, a positive thing, and that positive thoughts make a huge difference. Patrick, I didn't mean to interrupt you.
No, I think we've covered it. I mean,
I just go on and on sometimes.
Like day 3, can you start thinking about? That's when you can actually start thinking about waking somebody up and getting them to even sit up. We just don't wake our patients up. That's the thing.
I don't think there's a day.
Yeah.
You try to wake them up as soon as possible,
Yes,
and if they're non-combative, and they can respond, you're on the right path. If they're combative, then you give them another day or so. You don't just put a number on it, right? And you try to get them awake and going as soon as possible.
But again, we have to be careful with the combative part and being a physical therapist, because a lot of times if you have somebody who can't breathe, and before they were sitting up because they couldn't breathe, and now they're awake and they are lying down, that is going to put anybody in panic if they're intubated and all that. So a lot of times we do not quite understand the reason why they are, they could be delirious, there could be a lot of reasons, you know.
They could not be hypoxic.
Yes, there's different reasons.
Creating all kinds
But
of
as
issues.
a physical therapist, I have found throughout my career, I mean, I would not be able to count how many patients that have chronic back pain and they're stuck in a position in a bed that they're in so much pain that they're just, or they can't breathe. So a lot of times, and it's hard to understand why, because they cannot talk to you, and then a lot of times they're not fully awake. But that can be a problem. Sometimes I see that it's delayed because of that.
Yes, absolutely. And I think that's you know, Patrick, to answer your question, I think when we get a patient that we put on ECMO, and you didn't even actually talk about this, Dr. Samir. I didn't see, at least I didn't hear you say anything about it. You may have had it in your slides. But you have a patient who's been in the ICU for 7, 8 days. They've been on maximum ventilatory support. for the past 7 days with peak pressures 35, 40, maybe even 45, sometimes even 50. They've been on 18 and 20 of PEEP for the past 7 days, 100% FiO2 for the past 7 days. That patient's probably, and they put them on ECMO, patient's probably not going to recover. And that is a big problem. And so I think that when we see patients who have at day 3 and 4 of that scenario, they may have a chance of surviving, but had they put the patient on ECMO at day 1 and gone, or day 2 at the latest, and gone to maximum lung rest vent settings and protected those lungs, then at day 3 or 4 of ECMO, they may be awake. If they can move and not desaturate and decompensate rapidly, well, then you can start, just by being awake, we've seen that, then you slowly start moving things to see what is their reserve. And I think that the more you can do that, the more likely they're going to mobilize fluid, their lymph system is going to start actually working, because it doesn't work worth a darn when you're paralyzed, you know that. So you have you get all that third spacing cleared, the lungs dry up faster, they start moving more, and you can get those patients decannulated and off ECMO a lot sooner and safer, with a better opportunity for long-term survival, not just short-term survival. Getting them weaned off ECMO is only half the battle.
Oh, yes.
They got to walk out of the hospital. If they don't do that, then it's not a success. Wean them off ECMO all day long. They died in the hospital. What good was it? Or the rehab center or whatever, and they just never made it out. I don't think I see the value in that. I don't think it's fair. Final thoughts, John?
Well, I was saying about the getting the rehab going and the value that it is for an ECMO program. Wake them up, sit them up, and just like she said in the talk, the best position for the lungs is upright. Everything starts to improve just about
clearly.
almost right away.
The VA
so
ECMO
even
works
if you
so
can't
much
get
better
it,
when you sit somebody up at least 30 degrees, and I prefer 45 degrees.
I mean, if you can't get them out of the bed, get
the diaphragm off the lungs.
Recline the bed and raise the bed. So when you were talking about when indications to stop walking, you said if the SaO2 drops below 75%.
SpO2.
The SpO2. How are you monitoring that? Like, should she know monitoring that?
I don't know.
The O2 sat?
Pulse ox.
Well,
Okay,
yeah,
but
but see, that's my point. If
but
it's
the
a pulse ox,
SpO2
but the
is-
pulse ox, we usually don't. The patient's not pulsatile enough a lot of times, and we
yeah.
don't get a good pulse ox.
Yeah.
So that's why I was wondering.
They might have one of those continuous meters of some sort, that draws the blood.
No,
like
we
the
don't
old-
use that. We just use
you
the
just run
routine.
the
Yes, and
blood
also we
gas.
monitor the patient very closely.
Yeah,
And,
we see this too.
Yeah,
the pulse ox.
when the lips turn
They
blue,
may not.
Yeah.
the SpO2 is low.
We're watching the pulse ox, which is like you're really focused on that. Next thing you know, it's just not working.
Right. 'cause you
No.
have-
I
Yeah,
would say
so we
no. We
see
are
that a lot.
checking to make sure that it's matching and all that. I think that is just for safety.
We just go without it if it's not working.
I
Until
think
the
that-
patient don't
Yeah,
want it.
you're right.
Maybe not. Well, yeah. I think you can just infer,
Yeah.
that if this patient is decompensating from oxygenation, if the SpO2
And you
is
start
under
watching
75,
you can watch
they're
your
not gonna do well.
SVO2s pretty quick after that too, and see
Yeah.
they'll change as well.
Yeah. Dr. Samir, final thoughts? Or
I think right now is you really have to. ECMO is a very important resource. Use it judiciously, and don't be emotional. Every patient you think about ECMO, I will get a palliative care consult if you have the time. If not, you have to look at the whole situation. See this patient is what's the chance going to walk out the hospital, have a meaningful life. It's not just live; it's having a meaningful life. And a meaningful life is a very important definition.
let me ask you a question. I got a question for you. You have a patient, they're decompensating, the surgeon or intensivist or cardiologist or somebody, it's a life-saving maneuver. They just put them on ECMO. They don't even get consent from the family. Put them on ECMO because that's what you got to do. Or you go see, let's say you see the family and say, we put him on ECMO where he dies right now, and they put him on ECMO. Why is it that now that you put them on ECMO and they're bleeding out or whatever other problem occurred, they have a a belly infarct and their lactates are climbing up, and it's just they're obviously not doing well and not going to make it. Why is it that you have to wait until the family now says it's okay to discontinue the care if you really didn't even involve the family or barely involve them with actually initiating the care? Where does this come from, and why does this happen?
To be honest with you, I mean, it's a good question, but I think palliative care helps with that situation. Palliative care is not just, it helps talk to the family and helps, will give them the realistic. Palliative care is a neutral, entity.
Mm-hmm.
There's giving a real evaluation what's going on and help the patient, family arrive to the decision with the best thing for the patient.
Mm-hmm. Well, what do you do when the family says, absolutely not, keep going, 100%, we don't want to turn anything off, but it is futile care?
At this point, you have to get ethics consults. And you have medical legally, you do have to get an ethics involved before you proceed anything else.
Mm-hmm.
You have to get ethics involved.
Mm-hmm.
And to be honest with you, again, we established that for every transplant or MCS patient, to get ethics and palliative care consult.
Mm-hmm.
To be evaluated, they get both consults. It has worked very well. Patients thank us, and the families thank us. There's no family ever was angry that you give them the realistic picture of what's happening and what the future is.
That's very important. I agree.
Yes,
with
and
you.
I think everybody appreciates the honesty and transparency. If you're honest and transparent, nobody ever gets mad at you. Okay, people who think they're being evasive or hiding, be honest and transparent, And you have to make a plan before this happens. Like if you saw somebody who's very high risk, and we have one of our surgeons say, well, this patient comes crashing to double doors, what we're gonna do? Nothing. We all agree. Palliative care. We're going to be comfort care, and that's what everybody says. That so before it happens, and you're doing a journal club at the end of the night, because those journal clubs do not work out. Emotions take over at that point.
Understood.
Yeah.
Chris?
Like I said, it's just not because we can do it. We can walk patients on ECMO that we should. So I think that is only for selected patients. And I also just want to make sure that everybody understands that there's this idea that if the patients are going to walk, that they're going to do better. I can agree to a certain extent, but we also have to understand that the ones who can walk, they're probably not as sick as the ones who cannot walk. So the fact alone that they're walking just means that they have a little bit more reserve. And also, do not underestimate that what you can do at the bedside. I've had patients that I did not feel comfortable walking away from the bedside. However, they were taking literally 1,000 steps at the bedside. They were walking one step, so they were doing a tremendous amount of walking right at the bedside, where I felt like for patient safety, if there was a change, all I have to do is just to let the patient down into the bed, and we can provide whatever care they need, versus that you are in the middle of the hallway, like 500 feet away from the bed. As a physical therapist, that is always in my mind. How can I safely bring that person back to the ICU bed? Because I definitely don't want this to be too late.
Or the helicopter pad.
Exactly, whatever. So again, don't think that just the walking, that is, because...
Would you agree any exercise, anything is better than nothing?
Oh, absolutely. There's no doubt about it.
Anything's better than nothing.
Yes, absolutely. And the sooner the better. Prevention is a lot better than treatment, because we don't have a whole lot of treatment for that.
Very good point. My final thoughts, Brian Crawford, thank you for your comment. He says, thank you to the whole panel. All solid presentations, very educational. 2 thumbs up. We appreciate that very much. My final thoughts on today's program is that I'm just so humbled and grateful to be around so many incredibly smart and very easy to talk to healthcare professionals. It's really an honor, and I think this was the best program we've ever done. And my thanks to our studio audience, and also to our technical staff over there, Magic and David, who did an outstanding job today. We have had not one hiccup, no problems. Everything worked seamlessly. I know it's at the end. It's at the end. We're good. I waited. Don't worry. But this has been a great program. For Friday, October 28th, from 4 p.m. to 6:30 p.m., We're going to be doing, Roger DeLong is going to be talking about recirculation on VV ECMO and how to monitor it with an ELSA meter, it's called. And it's a dilutional technique, so it's mostly for single cannula or double cannula, but it's VV ECMO. And you can calculate accurately the amount of recirculation you're getting from your cannula, so you can better optimize the position of your cannula or cannulas when you first put it in, or to check it later. And so the ELSA meter, Roger DeLong, and then Dominic Capoletti. So Dominic, that's a good Irish name, right? Dominic Capoletti from Kentucky, Louisville, which is where, if nobody knows this, remember, of course, Dr. DeVries, Bill DeVries, who did Barney Clark, the first Jarvik that was inserted, after Cooley, it was really the first total artificial heart that was implanted in Barney Clark. I don't know if you guys remember that or not, but he left Salt Lake and went to Louisville. So, and Dominic has a lot of VAD experience. I mean, this guy is really sharp on VADs. And he's going to be talking about them, the good, the bad, and the ugly, because there's all three of those things. And then I'm going to be doing a talk on sublingual incident dark field imaging of the microcirculation, because I think, like I said earlier, we're very in tune with the macrocirculation. We just really don't think at the micro level. And being able to see it and monitor it, I think, is something that we are, like TCD. I think we should be doing TCD more. I think we should be exercising our ECMO patients more, and I think we should be looking at evaluating the microcirculation a lot more than we do. So I think that's going to be good, and then a discussion. And we've got the application into the ABCP, and hopefully everybody will join us for that. So I've got to go cook hamburgers, and I've got to cook Dr. Samir 2 externally seared but internally raw hamburgers. So just to let y'all know, I'll be cooking those this afternoon. All for everybody else, they're going to be cooked well. Two special ones.
It's okay, I'm French, okay?
You're French?
Yes.
Yeah. Okay. And I'm Chinese. Not if you noticed. All right.
I can see from the eyes, yes.
Listen, I want to thank everybody for everything once again, and thank you all for allowing us to come through your computer systems or iPad or iPhone or smartphone or whatever. And we'll see you all in October, unless we decide to do something early, in which case, please subscribe, follow, share, YouTube especially. We needed 21 more members of YouTube before we get to this new level and we get these new tools that we can use for doing these programs. So please, please, please sign up for a second Gmail account if you have to, and please subscribe on our YouTube channel. Thank you very much. We'll see you all in October, on October 28th. Bye.
Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo Cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing. Passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.